IVAS, PCI with LV support, Ampella, and his area of interest is also fracture heart intervention, which includes TAVI and TMVR. I also would like to introduce Dr. Jitendra Singh Makkar, sir. He is the HOD and Director Cardiology at Eternal Hospital, Jaipur. Dr. Makkar is a senior interventional cardiology with a special interest and expertise in the field of clinical electrophysiology, pacemaker, heart failure, device management. He has more than 25 years of experience in the field of cardiology and has performed thousands of coronary angioplasties, RF ablation, pacemaker, heart failure devices, and he is a pioneer in this field in the state of Rajasthan, having established the first EP lab and pacemaker clinic in the state, implementing many devices for the first time in the state, like TRTD, leadless pacemaker, and ICDs. So I am privileged and honored to be inviting Dr. Sanjeev Keshar and Dr. Jitendra Singh Makkar, sir, to take this forward. Thank you.
Good afternoon, everyone. Thanks, Nitesh, for kind introduction for both of us. I, on behalf of Eternal Hospital Cardiac Sciences, me and my fellow course director, Dr. Chitan Makkar, extend a warm welcome for this fifth Eternal Heart Conclave. This year, we are celebrating the 10th successful year of operations of Eternal Hospital. The decade celebration will be celebrating in the month of September 23. During these 10 years, the cardiac science at Eternal Hospital has achieved many milestones in both interventional cardiology as well as cardiac surgery. And all these milestones has been possible because of a great man behind it, our mentor, our guiding force, full of energy and enthusiasm, Dr. Samin Sharma sir. Along with him, our co-chairperson, I am Manju Sharma, constant support, constant guidance in our day-to-day affair. And that led to achieve so many milestones so that we can have a big mark, not only on the national level, but also at the international level. At EHCC, we not only strive for the clinical excellence, but also for academic excellence. As a part of this endeavor, we have been organizing Eternal Heart Conclave in collaboration with the Mount Sinai, New York. And this is the 5th edition of Eternal Heart Conclave. And we are proud to have a distinguished international faculty from US, named Dr. Samin Sharma sir, who is well known to all of us, who is a director of Cardiovascular Clinical Institute, director of Interventional Cardiology, senior vice president, quality and operations, and president, Mount Sinai Heart. Along with him, Dr. Deepak Bhatt, who's a distinguished professor, Willingdon Fuster Professor of Cardiology, and also director of Mount Sinai Heart. He has recently joined this and is a position, and we are very happy to see his elevation to the next level. Next is Dr. Raj Makkar, who will be joining tomorrow morning. He is a professor of cardiology at Sinai, USA, and he is well-known expert in the field of structural heart intervention. And he is the director of cardiovascular innovation and intervention at Sinai. Then we have Dr. Sean Pinney, who is a professor of cardiology at Mount Sinai Hospital, and he's a director of heart failure and heart transplant program at Mount Sinai. And then we have Dr. Robert Rosenson, who is a professor of medicine at Mount Sinai Heart, and he's the director of lipids and metabolism at Mount Sinai Heart. So we are glad to have all these 5 distinguished international faculty with us. Then we have a national faculty from all over India. This time we got a top faculty from all over India who's expert in their respective field. And all these faculty will share their wisdom, their expertise with all of us during the next 2 days' time. The first day is focused on the clinical cardiology topics, and the second day is for interventional cardiology. We have different symposium touching the all different aspects of complex coronary intervention and also structural heart intervention. With this, there's one more announcement from my side. We are going to perform 3 live cases during this 1.5 day. 2 are complex coronary intervention and 1 is a structural heart intervention. And today evening, we'll be transmitting live the orbital atherectomy from Eternal Hospital, Jaipur. And I also am proud to announce that we have done India's first orbital atherectomy today morning at 10:15 under leadership of Dr. Sameer Sharma sir. So all these milestone has been possible because of a force behind it, and that is Dr. Sameer Sharma sir and Manju Sharma. And with this, I once again extend a warm welcome from my side. And now I will ask Dr. Chitan Bakkar to add a few words from his side.
Thank you, Sanjeev. Good afternoon, everyone. Really heartening to see a full house in the beginning of the conference. And we are happy to bring you back the Eternal Heart Conclave after a few years gap. I think last was, now they say 2018 BC. Now BC stands for before COVID. So we had this before COVID, and after COVID, this is our first conference, and we are very excited. Actually, this is a good platform for us to hear the advances from directly from horse's mouth, and we have distinguished faculty as introduced by Sanjeev. And this is also a platform for us, Eternal team, to showcase what we do and what we are able to do and what is our potential. And we are very happy to bring every technology very fast to India and this part of the world. So we are blessed to have people like Dr. Sharma with us and Manju ma'am, and a beautiful team of Eternal which work as a family. So next 2 days, as Sanjeev said, it will be a great academic experience. And don't forget that after today's academic session, we have kept some entertainment also for the evening, which will refresh you. Looking forward to everybody's involvement in form of interaction and questioning to our faculty. They will feel happy if they are questioned, if they are able to transmit the knowledge to all of us. Thank you very much once again. Thank you.
I would like to invite Dr. Sameer Sharma sir to brief about the conference. Move ahead.
Well, brief about the conference is, both of you done a tremendous job with the ESCC administration, our marketing, and the house full, as Jitendra said, right from the beginning. It's very rare. A special hand applause for them. And then I thank our international faculty who came and our national faculty and all the delegates. The goal here is to give you a platform to present the latest and ask questions. So this, I want to be very interactive, and that's the way you'll take the benefit of it. It's not only in person, and I think there's people are zoomed in also. So benefit should occur to everyone. What is our goal? Basically, what we are going to achieve in the next 2 days is in every aspect of cardiology. What are the latest advances, which you can take back to your practice, and maybe we learn from many things from you. The goal is to overall become better clinician, so we can provide a better care to our patients. So that's with that note, and that has been the goal of our ES. Clearly, what we also felt, there is a very rich agenda, very time limited. So I request all the speakers to be on time, and of course the moderators will press it because very limited time for the presentations, for the talks. So I have to be strict with the timing, which I felt, since we have brought eminent cardiologists from Mount Sinai, that evening session, we have the live case of orbital atherectomy from 6:35 to 7:25. So I can tell you we'll finish the case in 25 minutes. So we'll finish at 7. As long as you take us to at 6:35 start. So that I'm leaving it to your panelists and moderators here. So 7 o'clock, I felt that 4 of us, myself, Dr. Deepak Bhatt, Dr. Robert Rogenson, and Dr. Sean Pinney will be here on the podium with the question, basically here as a panelist that ask any question. So therefore, while you have an interaction with the faculty during their break, lunchtime, evening and so, but we'll be there for half hour to answer any question you have, and we'll try to answer it best to our knowledge. With that note, I'll just wish two exciting, this, I would say, educational marathon to become better clinician to provide a better care to our patients. Thank you very much and good luck.
Thank you very much, sir. So to start our academic session, I would request Dr. R.K. Madhok, Dr. S.K. Kaushik, Dr. Rajiv Bagaratta, Dr. G.L. Sharma, Dr. Sandeep Juneja, Dr. Milind Srivastava, Dr. Sanjeev Sidana, Dr. Ramanand P. Sinha, Dr. Rajiv Sharma, and Dr. Ashok Garg for chairing this session and to take this session forward.
Good afternoon. As has already been highlighted, that the first part is clinical, and one of the most interesting session in any conference, whether cardiology or medicine, is ECG quiz. And today we have none other than Dr. J.S. Makkad and Kush Bhagat, who are already renowned electrophysiologists of the state. They are going to tell us about the ECGs, and questions will be asked, and everybody should be ready to discuss with them. Dr. Makkad, please, and Dr. Kush.
A very warm good afternoon to all of you, and without wasting much time, we will start with the ECG quiz. As Samin sir mentioned that the session should be interactive, so going forward with that, I like every one of you to be interactive. So all the ECGs are very easy, and the first case is all of them are multiple choice question. I think most of you have the buzzers. You have to click the right option, either 1, 2, 3, 4 or A, B, C, D, and then press OK. So the first question is, please arrange for the chairs. 50-year-old woman admitted to the emergency department with complaints of chest pain. So I'll show the ECG, and I want you to tell all the findings are present except. So this is the ECG, and these are the options. So the options are, so junctional premature beat is present in the ECG, acute SP elevation interval MI, acute SP elevation RBMI, and LCX territory is the culprit lesion. So ECG is there, you have the options with you, you will be given 30 seconds, and don't forget to press OK with that. All the findings are present except. So when the time, I think the time is finished, and 40% people have answered, I think, option 4. So LCX territory is the culprit artery. So I think we should ask them. Anyone like to brief the ECG? What is present in the ECG? Anyone would like to brief? Do we have mics with us? Please give the mic to that lady. Anyone want to answer the question?
I think we have students.
Yeah, that's why I was telling them to answer.
Cardiology student or medicine student. We have very limited time, and we have another quiz coming up, eco quiz. So maybe.
Do we have the mic? Please give the mic to that lady. Please take a try, no issues. I think, sir, no one wants to answer the question. Yes.
So what was the maximum answer?
So maximum people answer it as H6 artery is the culprit artery, and 40% people have answered it correctly.
Yeah, please go ahead.
No, you're not audible.
Sir, actually, this along with that, in corner V4R is there, that is more specific for RVMI. So it is more specific for partial as the culprit for inferior MI along with involvement of the RVMI. And one more functional thing is also there in second group.
I think it's perfect. So I think he's answered mostly correctly. That V4R is present. There is ST elevation in lead V4R, which is suggestive of RVMI. So always with inferior MI, you should get an RV leads as well, the ECG of the RV leads as well, and posterior leads.
Yeah, one clue is that we get reciprocal ST depressions in precordial lead, but if V1 is isoelectric or little bit ST elevation, then suspicion of RV is.
So coming to the next question, he's a 56 years old male who presented to the emergency department, and he had history of chest pain, and ECG was done, which I'll show you later on, and he was thrombolized with streptokinase, and he was referred for angiogram, and this is the ECG, and I think yes, this is the ECG, and can we have the options? Can we have the options?
ECG and option together.
Yeah. This is the ECG and those are the options. So he had history of chest pain and he was thrombolized with streptokinase and referred to us for an angiogram. So your time starts now. The options are, we have to take the patient immediately for emergency cardiac cath. Maybe we have to go for conservative management, or maybe the diagnosis is inferior MI, or it's junctional rhythm going on in the ECG. So what is right in this?
Can you show options on one of these screens? Option on one screen is not possible.
So I think 40% have gone for conservative management, and 30% feel that emergency cardiac cath should be done in this patient. So anyone want to answer the question? I mean, anyone want to discuss what is going on in this ECG? Anyone? Yeah, so please give the mic to so. And I forgot to mention that there are exciting prizes after that. So please don't forget to answer the questions.
Your buzzer response is getting recorded, and we'll choose winner according to your right responses.
Okay.
Right, your answer is absolutely fine. So this ECG
Thrombolysis is not obligation, but although the chest pain is because of maybe PSVT or something.
Yes.
Yeah, somehow these patients with pre-excitation, they have atypical chest pain, non-cardiac chest pain very commonly. Mechanism is not clear, but they generally present with non-cardiac pain. So basically, sir, the purpose of showing this ECG was the MI mimics, which confuse us and lead us to the wrong treatment in emergency. You want to comment anything?
Yeah, this was a question in one of our DM entrance exam, which I had attempted. And the question was, WW mimics which MI the most, and that is inferior MI. So that's a very, I can't forget till now.
Anybody would like to comment on the position of this pathway, location of the pathway? Any student, or else we move on?
Anyone? Location of the SRE pathway? No one? Yeah, please. Please give the mic to him, Dr. Location of the SRE pathway.
Sir, the inferior leads are mostly negative.
Yes.
So it has to be going from behind to anterior.
Okay.
So it will be posterior, like inferior or the posterior wall.
Okay, perfect.
And more than that, there is a sudden transition from V1 to V2.
Yes.
So it is paraseptal posterior part, and the morphology is more of LBB type morphology. So it has to be paraseptal posterior and left side.
So paraseptal and posterior is right. But I think since it's negative, it's
negative,
V1.
it
It has to be on the right side rather than on the left side. Perfect.
It is very early transition in
So it is
V2.
septal. That's why.
Yeah, so it can be on either side.
That's why it was little confused. It would have been between V2 and V3 transition, more certainly say it is right side. It is a very early transition between V1 and V2.
Negative delta wave in V1, that's just right side.
So coming to the next question, he is a 32 years old male who presented to emergency with broad complex tachycardia, and there was hemodynamic compromise, and he had to be cardioverted. So this is the ECG, presenting ECG of the patient. Patient with broad complex tachycardia with hemodynamic compromise. So can we have the ECG and the options? So these are the options. The options are, your time starts now. Options are VT, atrial flutter, SVT with aberrancy, and atrial fibrillation with axillary pathway. This is the ECG. Young patient with broad complex tachycardia. He needed a cardioversion. He had hemodynamic compromise. So I think most of them have answered it as SVT with aberrancy. This is the ECG. So you would like to take forward.
So anybody who has voted for SVT with aberrancy, can he or she explain SVT with aberrancy?
Why it's SVT with aberrancy? Anyone would like to take a call? You want to answer? You want to answer the
Lot
question?
of people have voted for
Yeah.
this, so maybe there is something in the back of mind to say it is SVT with aberrancy.
This is for discussion only.
Yeah, it may be right. Still open to discussion. So, if nobody see white QRS tachycardia, yes, we have to differentiate between SVT with aberrancy and VT. But generally, it's a very typical MD question or DM question for directly going for morphology in V1 and axis and other things. I think most importantly, we should look for any evidence of AV dissociation. Any evidence of AV dissociation in form of AV dissociation may be less P wave and more QRS waves, and in form of fusion beats or capture beats. So do you see anything here suggestive of AV dissociation in this ECG? Can you find out P waves here, and are these P waves related anyway with QRS complexes? I think, hello? Yeah. I think it is a ventricular shock. Common differential type.
So he said that there is AV dissociation and hence patient had hemodynamic compromise. So more suggestive of ventricular tachycardia.
Yeah. So start from history. If there is any cardiomyopathy, structural heart disease, think of VT. Hemodynamic disturbance, think of VT. AV dissociation, think of VT. Nothing like that, then you go to the morphology criteria, Brugada criteria or any other like. But AV dissociation is first.
So he
I
was
think
saying
clearly there is
yes, sir.
there are P waves, you have marked them, which are separated from.
So this patient actually, after cardioversion, this was the ECG of this patient. Nothing significant except for T-wave inversions and slight SC segment depressions in the precordial leads. So he underwent
Go
properly.
back to the VT ECG. You tell us when our time finishes. Okay, so this is LBBB morphology and axis is superior. Yeah. So LBBB morphology means tachycardia coming from right side, right ventricle, and the what is the axis of
Negative and is also become to negative.
So not a typically RV.
And
This is a
and the QR is also relatively narrow as compared to conventional, VT ECG. So the reason was that because we got a baseline ECG, this was this. The property was negative, angiogram was normal, and he underwent a cardiac MRI. So any patient, young patient, hemodynamic compromised, 80 could undergo a cardiac MRI, and MRI was suggestive of ARVC. The ARVC is very common. And this will be the morphology of the ECG in ARVC. So basically, this was coming from the septum of the RV wall, and that is why the QRS was normal. We did a 3D mapping and radio frequency ablation, and the earliest site was in the septum. And after that, got stabilized, but still, I think we planted a history with this patient.
This is a very knee-jerk reaction when patient comes in VT, cardioverted, and we see T-wave inversion in the precordial lead. We think it is non-ST elevation MI and then angiography is done. So it is good to rule out coronaries anyway if there are any other risk factors, but T-wave inversion in basic ECG and patient presenting with a left bundle branch type of VT, ARVD should be ruled out by doing an MRI, which is very freely available now in city.
Classical epsilon waves, maybe many times you don't see the epsilon waves. The main finding might be T-wave inversion in the precordial leads. So if we have time, we can go to this question. So he is a 60 years old male who presented with history of pre-syncope, and this was the ECG which was recorded. Now, at other instance, he was advised for Holter monitoring, but before going for Holter monitoring, he had pre-syncope, and again he underwent an ECG, and this was the ECG which was recorded with the patient. Now the question is, what will be the management? I think we can start the buzzer, the timer. So the option will be is Holter monitoring. We have to go for angiogram. We have to go for pacemaker implantation, or probably we have to go for a neurologist consultation. So this was the ECG at one instance, and this was the ECG at the other instance, and we have the options over there.
So same patient having two different
ECGs
and history of syncope. So very clear clue.
This is one ECG, and this is the other ECG which was recorded at some other instance. I think most of them feel that we have to go for Holter monitoring this patient. Okay. So actually he was advised Holter monitoring based on this ECG, and again he had pre-syncope, and this was the ECG. Now the question is, should we go for pacemaker implantation, or should we go for Holter monitoring?
So why Holter? Anyone? Why voted for Holter?
Anyone can stand and answer. No issues.
Or just describe these two ECGs. What is difference between them?
Please, sir, you can answer the question. Yeah, the wants to answer. Please, sir.
Basically, there is no clear-cut indication of the pacemaker implantation by seeing this ECG. We need further evaluation for the patient as the ECG depicted. There is no block, but there is some ST depression, and we have to evaluate later on.
Can you comment on the ECG, this ECG and this ECG? What are the findings in these ECGs?
There is, I think, there is some abnormal topics in first ECG, but second ECG there
Any
is
kind of bundle branch block going on in this ECG?
there is, I think, there is a right bundle branch block.
Right bundle branch block in this ECG. And in this ECG, sir?
And this is the, I think, there is little change in the period morphology, and there is LVV pattern.
Exactly. So, at one time there was right bundle branch block, and the other instance there was left bundle branch block. So we have evidence of both right bundle branch block and left bundle branch block.
Yeah.
But as you mentioned, since we don't have any AV block, we have to go for Holter monitoring in this patient.
Yeah, so very beautiful issue raised that do we have enough evidence for a pacemaker? So I think we do have enough evidence. Sir, you want to comment?
I think alternating bundle branch block will itself qualify for a pacemaker implantation, and Holter monitoring is not required. You can go straight away go for pacemaker implantation. Yeah. The history is very important first thing. And once we are convinced that the patient has got syncope and not any history of epilepsy, and we have this evidence of alternating bundle branch block. At one strand is RBB and the other strand is FBB. That's enough evidence for going for pacemaker. Exactly.
Even if we have trifascicular block in one ECG, even then if there is syncope, then in guidelines wise, if it is a cardiac syncope, you have to implant a pacemaker. Same with LBBB and first degree AV block. Same with RBBB, LAHB, LPHB or first degree AV. One more ECG and then
Fine. So she's a 42 years old female with sudden onset dyspnea, and this was the ECG, and these are the options. So the ECG is showing atrial flutter, and the ECG, yeah. So the time starts now, and the diagnosis is either ST elution, MI, atrial flutter, tamponade, embolism. A female patient with history of sudden onset dyspnea and chest pain. 42 years. Most of the people feel that it's pulmonary embolism, and someone also feel that it's atrial flutter. So it's either atrial flutter or pulmonary embolism. Anyone wants to answer the question?
this is I think pulmonary thromboembolism. Because there is presence of sinus tachycardia with S1, Q3, T3 pattern with RBB and morphology.
Yeah, so you're right, but this is a very typical ECG, and most of the times we don't find these findings. Most of the time we see sinus tachycardia in the ECG. So history is very important in these kind of patients. Any patient with sudden onset dyspnea with sinus tachycardia, get an echo done immediately, and any doubt, you should go for CT pulmonary angiogram to confirm whether it's pulmonary embolism or not. But rightly mentioned, S1, Q3 pattern, RBB morphology, P-wave inversion, epicardial lead, sinus tachycardia, all goes in favor of right axis deviation, all goes in favor of this pulmonary embolism.
Good answer.
I think
I
we
think
can
at
end
the
the session.
sake of time we can finish with the ECG.
So now we move on to the next part of this clinical debate and the clinical symposium. We invite now Dr. Vinayak Agarwal and Dr. Hemant Chaturvedi for going ahead with the eco quiz.
So the results of this quiz will be declared later on with exciting prizes.
Good afternoon, all of you. Not wasting much of time here, and now we are going for a eco quiz, and I'm just like tell you that this is not just a quiz. This is some rare cases. Dr. Vinayak will show you, and you are free to ask any queries and any questions for them. These are very rare cases, and you will get very information and about them.
Most of us not knowing about Dr. Vinayak, but he had come to our institution and he had a very good workshop on 3D echocardiography. Thank you.
So I would like to introduce Dr. Vinayak. Dr. Vinayak is a director of non-invasive cardiology in FMRI Gurgaon. Over to Dr. Vinayak, sir.
Their persons and their
So instead of a quiz, it will be kind of a quiz, but I have basically got about 10 cases which I thought were a little unusual, which we should be knowing in our clinical practices. They have practical implications, and I hope you enjoy the cases that I'm going to share with you. And I'll keep asking you about the diagnosis as to what you feel about them. So let's begin with the first case. It's a case of a simple regional wall motion abnormality. The first one is not very clear, but there is global hypokinesia, more of the anterior septum, mild mitral regurgitation, biatrial enlargement, there is hypokinesia of the septum, there is an aneurysm in the basal inferior wall, infralateral wall. Any guesses? What could this be? Yeah, we'll go quickly because I have 10 cases to show and limited time. So any guesses? How many of you think this is coronary artery disease? Obviously it could be one of the differentials can be coronary artery disease. What now? Any other change that you see in the 4-chamber view now? Global hypokinesia, this is the infroseptum, the PDA territory. Can you see hypertrabeculations of the apex and the lateral wall here? Something which we see very commonly in non-compaction. So in non-compaction, the compaction starts at the septum, and then as it is going, the myocardium starts to get compact. There is a seize, or the non-compaction actually occurs because of delay in compaction or stopping of the compaction of the spongy myocardium during the developmental phase. And it's the septum which is compact, and the rest of the anterolateral walls remain non-compacted. And this patient actually turned out to be sarcoidosis, had aneurysms, non-compaction. So this was a rare case of cardiac sarcoidosis with aneurysms. Typical guidelines which means in 2017 looked at not only the classical regional wall motion abnormalities other than the ventricular tachycardia and arrhythmias, is you have the anterior septum on a plaque view which becomes a wall. There is a thinning of the wall like this. Especially the basal anterior septum gets thinned out, hyper-echogenic, and this is one of the hallmarks of cardiac sarcoid involvement, and you should be aware of that as well. There is also presence of aneurysms which can occur in the inferior, infralateral, even apical aneurysms are pretty common. So a high level of suspicion is required, especially in a younger population, less than 40 years, who comes to you with regional wall motion abnormalities. So not all wall motion abnormalities are coronary artery disease. Let's take another case. A 57-year-old male presenting in the emergency with complaints of progressively increasing angina. This was the ECG, a fully evolved anterior wall MI with 2 waves in lead V1 to V6, a typical tombstone appearance. The angiogram is shown to you before the stenting. So the right coronary was alright. The LAD was completely cut off at this point, the mid, just after the septal. Done was stenting was done, and as you can see that the stent has been, so traditionally most of the interventionists do not do echocardiogram before when they go for angioplasty, and that is something which that's a trend which is worrisome to me, because I started off as a interventional cardiologist and then moved into clinical cardiology and imaging. And I can tell you, and this is an example why you should be doing an echocardiogram before you intervene. So this patient underwent a primary angioplasty and a stent into the LAD. And look at the flow after the stent. Just look at this. Hardly kidney 1, kidney 2 at all. The patient this was the echo. Anybody, what do you think this is? bring the lights here. What do you see at the top? How many of you think this is a clot?
This is intramural thrombosis.
Yeah. So this part which you see here, can you see an echolucency within that flap? There is a flap here, the endocardium. There is an echolucency. This is a typical intramyocardial hematoma, which eventually will lead to a transmural scar. And there is no way that you would be able to actually do anything to that area once it has been. So the etiology of intramural hematoma is that there is a rupture or separation of the spiral fibers of the myocardium because of the excessive blood accumulation or hematoma, the capillaries burst, and that leads to intramural hematoma. And this is a non-viable area eventually. Has poor prognosis. In the long term, if the patient survives the initial insult, will lead to arrhythmias, heart failure, and sometimes even initially prolonged cardiogenic shock requiring MCS. So this is another case of typical intramyocardial hematoma. Most of us have seen will label this as clot. What I want to tell you is you need to distinguish between a clot and a hematoma. The endocardium is actually expands in systole. In an intramyocardial hematoma, there is a echolucency inside that area, and there is an intact epicardium. I'll give you another example of intramural hematoma. Here you can see there is a pseudoaneurysm which is formed at this area inside. So you can have a combination of an intramural hematoma and an LV clot in these patients, and a lot of times they will require surgery with limited prognostic value. Okay. One thing which I want to tell you here is that this is a patient who had MI, had an aneurysm at the top, LAD territory, and how many of you think there is a clot at the inside in this area, in the pseudoaneurysm kind of a apical aneurysm that you see here? The only idea is to make sure that you do use contrast very frequently in these patients, because as you can see there is a very soft clot at the apex here, which you cannot delineate very clearly, and the moment you use the contrast, Definity or Sonoview, whatever you have, it clearly, so you should use contrast. Your threshold for using contrast should be very low. Let's move on to a 7-year-old lady with diabetes, hypertension, CKD. She was on dialysis and presented with septic shock, and this is the echo. Now I'll explain. So there is a pericardial effusion clearly, and there is an apical hypokinesia of the entire apex, right? Anything else that you see? I'm not sure if you're able to see. Can you identify this? This patient has a permacath for dialysis. Anything that you see here? So this patient actually has any ideas? What are we looking at in the right atrium? Here. So this patient has what is known as, so this patient actually had normal coronaries, which we did later on, and has Takotsubo cardiomyopathy. There is an RA-RV collapse, which you can see, which means that she is in tamponade, and there is a CRAT, a catheter-related atrial thrombus, or CRAT, which is very commonly seen in permacath patients. So this patient actually has 3 concomitant pathologies together, which can be identified by just this echo. So you can see clearly now, I think you can see it very clearly. This is thrombus, which is attached to the permacath here. So this is known as CRAT. You have tamponade as well as apical ballooning syndrome. And this is a TEE and a PD. This is how it looks like. This is the catheter and it is attached to that. We
move on to another patient. Now this is a very typical, I'm sure most of you will be able to identify, 30-year-old presenting with acute onset breathlessness in shock. This is the ECG with right bundle branch block. Very typically Westermark and Hampton sum sign on chest X-ray. And this is the echo. So this is a very quintessential, very simple echo, classical, a dilated right ventricle. You can identify the clots. And so what is that? What are we looking at? Dilated RARV. And can you see this clot? So this is the pulmonary artery NPA, and there is a large clot sitting at the saddle embolus. This is pulmonary embolism. So this patient was in shock, massive pulmonary embolism, so was thrombolized and improved. Now this is a very interesting case. This is a 30-year-old lady. So any young patient who presents with stroke, we must always use echo and transesophageal echo, and I'll show you the reason why. She presented with a left hemiplegia. The CD showed ischemic stroke in the right MCA territory. This patient turned out to be mitral stenosis, but the appendage was clear, right? There was no thrombus in the appendage at all, which is possible that she may have formed a small thrombus which went, and now we're not seeing anything in the left atrial appendage, but we know that 90% of the strokes occur in atrial fibrillation, at least because in the LA, and in, of course, with mitral stenosis the risk goes up multiple times. Now, can you see, so this is the transesophageal echo, and this is the interatrial septum. Can you see this? This is the interatrial septum. That's the tricuspid valve. This is a normal interatrial septum normally. Can you see a pouch here? And there is a clot inside that pouch where the arrow is. So this is known as the atrial septal pouch, which is basically formed due to the partial fusion of the septum primum and septum secundum. And some of these patients, it remains open, and it is a potential source of stroke in these patients, which can lead to recurrent strokes. So this is one entity you should be aware of. The other causes of strokes in the young can be fibroadenoma, fibroelastoma, as you can see here attached to the aortic valve. Then this is of course a struck mitral valve, a 3D. One leaflet is open, the other is completely struck by the thrombus. Now these are a patient of SLE with biventricular dysfunction and biventricular apical clots. This is a case of RHT with left atrial appendage clot in the 3D, you can see very clearly. And this is a case why I said that you should do a transesophageal echo is, this lady came with stroke, again a young lady. The echo was normal, there was just a whiff of MR, mild MR on echo, nothing else could be seen. The moment you do transesophageal echo, you start seeing these small little vegetations on the mitral valve. There was no history of infective endocarditis. She presented with stroke, eventually turned out to be APLA positive and SLE. So these are NBT or non-bacterial thrombotic endocarditis, which are very well seen on transesophageal echo. Sometimes you may be able to pick up these kind of vegetations on transthoracic echo, on mitral and aortic valve. These are what the non-NBT look like on an echo. Now this is a case of very typical, what is, can any spot diagnosis when you look at this man? Anyone?
Acromegaly.
Acromegaly, right? Very typically. So, has a pretty much spot diagnosis. Now here I want to tell you that this patient had a macroadenoma, left bundle branch block, and this is a typical case of advanced acromegaly, which has been hard. They hardly do anybody hardly does echo in these cases, and they eventually move on to develop what is known as an acromegalic cardiomyopathy with global LV dysfunction, left ventricular hypertrophy. So this is this was an acromegaly. cardiac cardiomyopathy. Now this was another case of a 60-year-old lady, homemaker, had diarrhea, flushing, abdominal fullness, and of course the history itself is suggestive of carcinoid if you look at it. And when we did the 5-HIA tests, they were increased, and chromatographin A and synaptophysin were also positive. Now this is a typical case of this. I just wanted to show you that, please, if you look at this picture, this is hallmark of carcinoid, where you have both like fixed tricuspid valves. You can see that the tricuspid valve is both like fixed here. The pulmonary valves are also fixed. They're not moving. There is a non-coaptation of both tricuspid and pulmonary valves, leading to severe low pressure TR as well as severe low pressure PR. So this is a classical case of carcinoid which we should be aware of. Now another case, this is very, very interesting. I'm pretty sure nobody would have seen this case. I saw it in my lifetime only once. So this is a 34-year-old Iraqi patient who came to us with severe breathing difficulty. He was wheelchair bound, and this is what he looked like. Some people may have seen, this is what he looked like. Okay, any guesses what this is? Now he had cardiomegaly. This is his echo. There was significant valvular calcification all over at aortic and mitral valve. You can see mitral annular calcification significant. There was mild to moderate MR, mild AR. There was also significant pulmonary hypertension. This patient has CKD and scoliosis, and he couldn't get up. So this patient was actually a case of secondary hyperparathyroidism secondary to chronic kidney disease. And in advanced cases of this, they lead to what is known as brown tumors or osteitis fibrosa cystica, which are rare non-neoplastic lesions and affect the axial, skeletal and femora. So they're actually, the jaw becomes hypertrophied in these cases, and that's what you saw. This is another case where a female presenting with exertional breathlessness, loss of appetite and pedal edema, and she was thin built, periorbital purpura. Any guesses what we are looking at? Raccoon eyes. So this is a case of amyloidosis. And here this is a very typical, so please remember that when we see this kind of a picture with ground glass appearance of the myocardium, sparkling ground glass appearance, where there is mild pericardial effusion, atrial dilatation, severe left ventricular hypertrophy, this is likely to be cardiac amyloidosis. But amyloidosis can be very, very deceptive. It can be ATTR, AL varieties, and many other. So that's a topic, separate topic in totality. But this is what a classical amyloidosis looks like with intra-atrial septal hypertrophy, the apical sparing, typical apical sparing on the strain imaging. Now, this was another very important case I saw of a young 18-year-old male who came to the ER with seizures. He used to have recurrent seizures, generalized weakness, and presented with heart failure. And this is what he had: multiple lesions, atrophic changes in the ventricles of the brain. And this is what his echo looked like. There was a global hypokinesia, a large clot at the apex. Again, you can see a ground glass appearance of the myocardium here, so these, not all ground glass appearances of myocardium will turn out to be amyloids. This patient actually turned out to be, you can just see more images here. It turned out to be a case of MELAS, or mitochondrial encephalopathy with lactic acidosis and stroke-like episodes. So I think clinical decision making is very important. Echo can help us in that. And sometimes you may lose, you just look at a ventricular hypertrophy, which can be something like Fabry's disease, which is very easily missed. There are certain clues in Fabry's, which is, of course, very significant hypertrophy of the papillary muscles, which are giant papillary muscles seen here. And there is also a binary sign, which there is a hyperechogenic endocardial surface because of the deposition of the glycolipid deposition at just below the subendocardial, subepicardial layer. So in the subendocardial layer, you have the hypoechogenicity. So this binary sign is not very specific, it is specific but not very sensitive. But these are some of the things which you will be able to pick up. So I'll end with the last case of somebody who presented with dyspnea on exertion. Any guesses what this is? I have written the diagnosis but not the details. So this is a case of double orifice mitral valve, a congenital abnormality. You can see that there are two orifices here, one small, the other larger. Both are mitral valves and very well seen on transesophageal echo. So I'm sorry this was not so much of a quiz as it is just tell you what echo and imaging can pick up in clinical practice and help us in making diagnosis. Thank you.
Thank you, Dr. Vinayak, for excellent case presentation. You have not only presented the case, but you have presented 10 clinical scenarios and clearly shown that how echo is important. So congratulations for that. I think he needs a big round of applause. One thing I would like to add, that recently in JAP, there was a publication that they probably withdrawn the non-compaction term. And they proposed that we should use excessive trabeculation of the right ventricle or left ventricle.
So the problem with, there are at least 5 different diagnostic modality, the criteria which have been proposed by different people. And now if people who are actually doing echo or MRI would tell you that it is very, very loose, in the sense it's vague. Whether it's not even defined whether it's in systole or diastole, whether it is 3:1, 2:1 ratio that we're looking at of the compact to the non-compaction. And we see a lot of non-compacted, so-called non-compaction in multiple clinical conditions. It can even be seen in dilated cardiomyopathy, a lot of pediatric age group cardiology, pathologies. Like in this case of sarcoid, we picked up hypertrabeculations. So I think it is still something which is evolving. We are not sure. There are very few cases of an actual non-compaction, which are, once you do the genetic testing, you'll be able to pick up. So I think that's probably the part of the evolving definition of non-compaction that we are discussing. I'm not sure that's the last word on it.
Okay, so till now we should continue with the non-compaction term. So thank you, Dr. Vinayak. And for next presentation, I would like to invite Dr. Vinayak Agrawal again. He will be speaking on hypertension, myths and facts.
So this is a clinical topic. I've tried to just pick up relevant parts of hypertension that we deal with in day-to-day practice. Now, I'm not going to go into the detail of hypertension being the silent killer and the fact that in a population of nearly 1.4 billion people, the incidence of hypertension, or prevalence of hypertension in India is 25% or greater. So 1 in 4 in India is actually a hypertensive as compared to 1 in 8 in the world. And as we grow older, the hypertension becomes nearly 60% in these cases. But the blood pressure control is less than 15% or even worse than that. So you're looking at a very large population which is affected with hypertension but very poor control. Now it's a double whammy because we know if you look at the deaths because of ischemic heart disease and BP levels, an uncontrolled blood pressure is directly linked with coronary artery or CVD, cardiovascular disease, both MI, stroke, heart failure. And look at the financial burden of CVD in India, which will run into billions and billions of dollars. The problem is compounded with the fact that both the American Heart Association and the ESC actually have different guidelines for diagnosing hypertension itself. So sometimes the guidelines themselves cause hypertension. And that is one way to say that if you look at American Heart Association, they have decreased the thresholds for hypertension diagnosis and have actually created more patients with hypertension. So if you look at the difference between the two, the hypertension by ACC-AHA is defined as 130/80 or more, while ESC still sticks to the older one, 140/90. What is defined as elevated by AHA is actually normal by ESC, and ESC defines another which is high normal. Grade 1 is 130 to 140 and 80 to 90 by ACC, while it is 140 to 160 and 90 to 100 by ESC. Similarly, ESC has a class, a grade 3 also, which is not present in ACC or even ISH guidelines. So you can see that if you go from one part of the world to another, you will have different criteria for defining blood pressure goals. And this is a very nice look at the ACC, ESC, Japanese and ISH, International Society of Hypertrophy Hypertension Guidelines. So here the grade 3 is present only in ESC and Japanese, not in the ACC or ISH guidelines. And the criteria for normal, elevated and high normal is different. So in some part of the world, if you go, you would actually be in high normal range, in some you would be diagnosed as hypertension. So this is one discrepancy that you should be aware of. But one thing is clear, that the risk of CVD, stroke or CHD is directly linked with high normal BP, elevated blood pressure, etc. So if you look at carefully, in the ISH, ESC guidelines as well as the Japanese guidelines, when you look at the high normal blood pressure, this is linked with stroke risk. And this has been found in almost all the guidelines, that if even a high normal blood pressure defined by either criteria leads to an increased risk of stroke, if not coronary artery disease. There is another term which we use is isolated diastolic hypertension, when the systolic blood pressure is less than 130 but the diastolic is above 80 or equal to 80 or more. Now, prevalence of isolated diastolic hypertension is more common in the younger age group, less than 50 years of age. And it was also said previously that IDH is not related to high mortality or morbidity. In a recent trial in 2019 published in NEJM by Flint et al., they have shown that in the Kaiser group of 1.3 million adult patients, when they analyzed the data, they found that both systolic and diastolic hypertension was associated with increased CV risk. Much more with systolic, less with diastolic, but IDH was not so innocuous as we used to think. There is another study which came as called the SUTA study recently, and this was from Japan, and they compared normal blood pressure of systolic less than 120 and diastolic 120/80 or below with elevated blood pressure and hypertension. And they said that the elevated blood pressure, even 130 and above systolic or diastolic 80 and above, was associated with higher risk of CVD and stroke. So we know that the interventions for hypertension control should start very early at a population level. Now, one thing which we keep talking about after the SPRINT trial was the fact that should we intensively control the blood pressure or not. Now, SPRINT trial was actually done in nearly 10,000 patients, and these patients had a systolic blood pressure of more than 130 with a history of CVD, stroke, and also 28% of these patients had CKD with high risk factors. And the intensive treatment was defined to bring down the blood pressure, systolic blood pressure below 120, while the standard arm was to keep the blood pressure around 140 or below, but not below 120. Now, what it showed was that there was a 25% decrease in primary combined endpoints 27% reduction of death from any cause, and 38% reduction in heart failure if you were treating these patients intensively, bringing their systolic blood pressure below 120. But one catch here is CKD. Now, in the CKD group, though these 28% patients, none of these patients who were enrolled in SPRINT trial were in, actually the GFR was above 20. So the stage 4 and 5 polycystic kidney disease patients and those who had proteinuria more than 1 gram were not included in these studies. And in these, the criteria for bringing down or say intensive control is not very well defined, so we prefer to keep it 130/80. So in diabetics, CKD, we don't want the blood pressure to come down below 130/80. Please remember that. Now, chronotropy. What time, does time matter that I give it in the morning or in the night? So if I look at the ISH review, which was published in 2022, 8 studies were analyzed. Out of that, only 2 were randomized controlled trials, the MAPEC and the HYGEA studies. And both of them showed that the evening, if you give the antihypertensives in the night or in the evening, they had better outcomes in the long run. But there were a lot of errors in the way the patients were, the data was analyzed. So a very recent study published in Lancet in 2022 called the TIME study. It was a large randomized open label study, and they did not find any difference whether you give therapy antihypertensives in the morning or in the night. So this is the latest trial as far as the chronotropy of the medication is concerned, and there was no change in the mortality either. So you can choose, you can give it either in the morning or in the night depending on the patient's profile. Now, self-screening, should we do it or should we not do? The NICE guidelines, if you look at, they say that you should recommend that you should check your blood pressure once a year, right? And this is largely a clinician or office-based checking. So you have to go to a doctor, get it checked. But if you look at the concept of self-screening or home blood pressure screening, this is coming up in a big way. And if you look at Japan, there is almost 100% penetration of home blood pressure monitoring in Japan as compared to, say, in UK, which is 1:10. So in the recent trials, it has been recommended that self-screening is not a bad idea. Home blood pressure screening or monitoring is recommended now as compared to what it was earlier. And newer techniques, of course, techs are coming, like the smartphones, the blood pressure instruments. They're not very expensive. Now, the other concept is ABPM. So ambulatory BP monitoring is something which is recommended by all the hypertensive societies across the world. And that is something, all newly diagnosed hypertensives, patients where the blood pressure is not controlled, where you're suspecting MAST or white coat hypertension, or patients who have CKD, obstructive sleep apnea, where they have more of nocturnal hypertension and non-dipping, ABPM is the only way you can find out what kind of a blood pressure profile we are looking at. So both home-based and ambulatory blood pressure monitoring is a newer concept which is recommended for hypertension control. Now, lifestyle interventions, we keep talking about it, but what is the impact of lifestyle interventions? If you look at weight management, if you lose 1 kg, the blood pressure will come down by 1 millimeter, according to the studies. Okay, though in my clinical judgment, it's much more impactful. Now, if you consume a DASH diet, which is rich in fruits, vegetables, whole grains, and low-fat dairy, it will come down by 11 millimeter reduction in systolic blood pressure. So diet plays a huge role. What about sodium? Now, sodium, 1 gram sodium is equal to about 1/5, the tablespoon is about 5 gram of salt. So if you reduce 1 gram of salt in your diet, your blood pressure will come down by about 5 millimeter. If you take more potassium, it will come down by 4 millimeter. Physical activity of about 30 minutes every day will bring it down by about 4 to 5 millimeter in the systolic blood pressure. And moderation in alcohol will also bring it down by about 3 to 4 millimeter. Now, what about the salt? There is a lot of conundrum about salt. So if you look at salt, there are a lot of guidelines or studies which have been done. which are not actually per se in the, I would say very good evidence-based data. And 1 gram of sodium is equal to 2.5 gram of salt. That is how we equate the two. And there is enough data to tell you that salt reduction matters, and you should decrease the salt intake to between 2 to 5 grams per day in your diet, and it works. The single pill concept is now here to stay, which is known as SPC. So more patients should be on combination therapy. Most of them are actually recommended to use the ACE inhibitors, ARB plus C, which is the calcium channel blockers. In blacks, they recommend using diuretics. And then, so A, C, D is your bread and butter. And then, of course, you add, in a resistant hypertension, you add MRAs like spironolactone, etc. So moving forward, what is not recommended is to combine ACE inhibitors with ARBs, and use of device-related therapies like your, the recent trials have not been in favor of the denervation therapy as such, though it is coming up again, but we are still awaiting more data on the renal denervation therapies. There is no J curve for blood pressure, which we must understand. In the CKD group, I have already told you that the traditional teaching used to be to not give thiazide diuretics in CKD. The moment the GFR falls below 30 ml per minute, we say that the thiazides do not act. But there was a recent trial called the CLICK trial. CLICK trial has clearly shown that chlorthalidone has, in the dose of 12.5 to 50 milligram, can be effective in preventing, in treating hypertension. Coming to primary aldosteronism. Now, this is something which we don't look at, and especially in less than 40 years of age, patients who have hypokalemia, resistant hypertension, and family history of hypertension or CV at a young age, we should look for hyperaldosteronism, or what is known as primary aldosteronism. Now, the recommended test for that is the aldosterone-renin ratio, or ARR, which is a blood test. However, in a recent trial in 2020, it has been shown that the urine aldosterone levels are far better than the ARR. But ARR is part of the guidelines. Urinary aldosterone levels are not part of the guidelines. But most likely, in future, you would be using urinary aldosterone, which has a much higher sensitivity for picking up primary aldosteronism in resistant hypertension group. If you look at the, I will move towards hypertensive emergencies. According to ISH, if you have a patient who comes to you with malignant hypertension, your goal is to reduce the blood pressure by about 20. Somebody comes to you with 230 by 120, your goal is not to bring it to 130 or 120. Your goal is to reduce it by 25% only on the first few hours. So please remember that. If you have a stroke, then the criteria are different. If the blood pressure is above 220 by, systolic blood pressure is more than 220, and you want to thrombolize the patient, you have to rapidly bring down the blood pressure to 180 to thrombolize. You cannot thrombolize the patient if the systolic blood pressure is above 180. So that is one thing to remember. Even for, say, hemorrhage, your blood pressure goal is to bring it down to not below, say, 150, 80 or so. So because there's a compensatory increase in blood pressure during the first 48 hours of stroke, and you should be careful. Now, this is my last slide about sexual dysfunction. Traditionally, we've been saying that it is the beta blockers which cause sexual dysfunction, but that's not the only drugs. Thiazide diuretics and even aspirin has been shown to cause erectile dysfunction. So in appropriate patients, you could actually use that knowledge to treat hypertensive patients. So this is, in general, I actually created a small talk about the practical points in hypertension, myths and facts. Thank you.
I think, I don't know whether we have enough time to ask any comments or questions, but we really thank you for giving such a pragmatic view, taking a pragmatic view of the treatment of hypertension. That will be very useful, I suppose. 2 points which probably needed mention was regarding the primary aldosteronism. And more often than not, it may not be the diagnosis which is effective, which may be important, but severe hypertension, at least in my clinical practice, we have found that spironolactone is a very useful adjunct. So I think you'll agree with that, probably. Yeah. So with that comment, I think we come to the end of this particular talk, and for the next one, please.
Thank you. So the next topic is cure of hypertension in 21st century, and our speaker is Dr. Rajiv Gupta ji.
Good afternoon, and thank you very much for the invitation to talk on a very controversial topic. Can we cure hypertension? There's the big issue. I think after talking of diabetes reversal, that diabetes can be reversed by appropriate lifestyle changes, there has been some interest now whether we can reverse hypertension. So I think we need to think of this for the next, the topic given to me is 21st century, so in the next 30 or 40 years, what's going to happen in the field of hypertension? Can we cure hypertension? Can we one-shot therapy or one-time intervention? Can it be useful for hypertension prevention? We all know that hypertension is the most important Hypertension is the most important cause of cardiovascular disease. This is data from our own peer study over a period of 15 years, 11 years. What we found was these are risk factors for heart disease in our country. Hypertension is number one. Unfortunately, despite hypertension being so well, known and all these medical therapies are available to us, the highest mortality from hypertension is in our low-income countries and low-middle-income countries as compared to high-income countries. So clearly we need to think that what can we do for that. Lowering BP is protective. Dr. Agarwal just showed you lots of data on how to lower blood pressure. And we clearly have evidence that if you lower blood pressure, you can prevent heart disease or strokes by between 20 to 30%. And this lowering is effective across the age groups. So if you are a young person or an old person, the lowering really helps. We just heard about the hypertension management guidelines, lifestyle factors, definition of hypertension, out of office blood pressure measurements, and use of single pill combinations. Yes, they are all available to us. Unfortunately, there are problems with adherence. Studies after studies, not only from India, but from all over the world have shown that adherence is very poor. Only about half of the patients of hypertension in a system like the UK NHS took antihypertensive treatment after 1 year. So clearly, when somebody is paying for your health care, even then the adherence is 50%. What's happening in India? In India, I think the adherence is about between 20 to 30%. So clearly, we have a problem of adherence on hypertension. So that's why we have sort of a new hypothesis that whether we can produce remission of hypertension by certain interventions, and that's what I'm going to talk to you. I won't talk about drugs because drugs are not, they are have to be taken for lifelong therapy. I'm talking of remission, possible cure, and remission doesn't mean that we treat every hypertension. We have a curable forms of hypertension, curable phenotypes, also known as secondary hypertension. Obstructive sleep apnea is very common. That's what now I think these data are emerging. CPAP support, and there are lots of data to show that if you have adequate CPAP support in a person suffering from obstructive sleep apnea, you can reduce the blood pressure and control blood pressure. Similarly, Dr. Agarwal and the group talked about primary aldosteronism. Again, a very important problem, 20 to 30%, almost 20% in resistant hypertension. And you can use spironolactone, which is a very widely available molecule with us. Renal artery stenosis, we all think is a curable disease, curable form of hypertension. Yes, not on everyone, But in a few of the patients who have bilateral renal artery stenosis, if you give them angioplasty or revascularization, you can have cure of hypertension. Renal parenchymal disease, unfortunately, no. The only issue here is that if you have renal parenchymal disease and these people undergo transplantation, many of these people become off the antihypertensive medication. So clearly, this is a form of curable hypertension. Of course, drug-induced alcohol, pheochromocytoma, thyroid disorders, they are all sort of curable forms of hypertension. But what we are more interested in the 80%, and the 80% is primary hypertension. What can we do? So they have listed about 4 or 5 strategies for the future. Renal denervation therapy, a brief mention was it was mentioned briefly in the previous session that it may not be very useful. I'm going to show you how useful is it. Bariatric surgery also is useful for remission of hypertension. Hypertension vaccines are now emerging as a possibly one-time treatment for prevention of hypertension. We have gene-based therapies, lifestyle therapies, of course, healthy lifestyles. So what are the hypertension interventional therapies? Renal denervation, it was hypothesized to treat resistant hypertension. It was also hypothesized to treat permanently cure hypertension. What we do is to ablate the renal nerves along the renal arteries in the adventitial layer. It was evaluated in the resistant hypertension patients, Simplicity 1, 2, 3, and then the recent trials. Now this is the first trial, the first Simplicity 1 and Simplicity 2 trials performed on a case control basis, not a randomized trial. There was no intervention in the control group. Control group was given usual treatment, and the intervention group was given the renal denervation therapy, and it showed a very huge benefit. That means if the patient undergo intervention, the systolic blood pressure falls as compared to the control group. But then our friend Dr. Deepak Bhatt, who is here actually, in this, not in the hall right now, but he performed in the US a very large study of about 500 patients. What he did was half of them were given renal denervation, half of them were given a sham control. That means a catheter was placed and the patient was told that, of course, you have got denervation done, and at the end of 6 months, no benefit. So in a sham control trial, denervation therapy failed, and that's what the reason was, that we all thought that is a useless technique, no future. But then people developed newer ways of denervation, the same design, the sham control design, that yes, there was a scope for hypertension control using denervation therapy. This is a meta-analysis of interventions, that what can you do, whether by pharmacotherapy or by denervation therapy. And this particular meta-analysis showed that yes, but it only controls blood pressure as good as one drug. So if you have mild hypertension, maybe this is a good way of treatment, not in a patient with severe hypertension. And remember, denervation is a one-time therapy. You give it, you do it, and the patient goes home, doesn't take any treatment, as compared to the drug therapy, which is a lifelong commitment. But in the last 2 or 3 months, we had a publication of the Simplicity 3 trial, long-term follow-up, that means 3 years follow-up. And here again you see, as compared to the first trial, the first phase 6-month follow-up, in the 3-year follow-up, there is a significant decline both in the office-based blood pressure and the home ambulatory blood pressure monitoring. So this particular follow-up shows that the benefit is ongoing, and at the end of 3 years, you tend to have a very significant decline of systolic and diastolic blood pressure in patients who undergo renal denervation therapy. So this may have a future in hypertension control, especially also in hypertension remission, but I think in the next 10 or 15 years, we'll have more data coming out of it. The second approach is bariatric surgery, and bariatric surgery came from diabetes. We all know that diabetes can be controlled or even cured by bariatric surgery, especially in obese people. These are data from STAMPEDE trial. STAMPEDE was a randomized trial in diabetics, bariatric surgery versus no bariatric surgery. It showed benefit. But in this particular trial, I looked at the hypertension control and didn't find any benefit of any of these, either gastric bypass or sleeve gastrectomy, as compared to medical therapy in significant p-values. But there is another trial known as Gateway, which is a randomized trial to evaluate efficacy of gastric bypass in hypertension and obesity, BMI of more than 30. In USA, it is 35 actually. So, and here you see that the gastric bypass had almost 83% patients remitted. That means remission of hypertension happened after gastric bypass. So gastric bypass is not only useful for diabetes, also useful for hypertension. And almost 25% of patients at the end of 1 year were off all medication. So clearly, we are heading towards that side that we can stop the medication totally. One more study, the Kaiser Permanente study cohort, retrospective study, 9,500 patients. And you look at surgical, at the end of 5 years, almost 60% of patients did not require the treatment of hypertension. So clearly, bariatric surgery is heading towards cure of hypertension. We need a good quality, high quality randomized controlled trial to understand the benefits. Therapeutic vaccines, very surprising. We all think of vaccines for infectious disorders, but now we have vaccines for hypertension also. And it's been going on for the last 20 years now. Angiotensin 1, angiotensin 2 antagonists or vaccines against those particular things are developing. There have been lots of phase 1 trials. Phase 2 trials are still going on, and we'll have some data. What I think is that the vaccine development for hypertension and other non-communicable diseases, such as Alzheimer's disease, will accelerate using technologies which have been developed in the COVID-19 epidemic. So clearly there is a future for vaccines, especially also in terms of non-communicable diseases. A very interesting example of vaccine, Professor Eugene Braunwald, father of cardiology, says that once a year, inclisiran, or twice a year, inclisiran, or small RNA molecules are just like vaccines, actually. You can have longer-acting small RNA molecules to control LDL, and that particular vaccine will control LDL, maybe prevent heart disease, although it needs a large-term trial. So we already have vaccines in cardiology in terms of mRNA. We are awaiting vaccines for hypertension. The third issue is lifespan-enhancing therapies, and I think there is a great scope. Right now it's in the animal experimental stage. People have doubled the lifespan of mice and rats and other things, and this is the work at the Harvard University. This is the revolutionary science of aging, and there are longevity gene enforcements by various chemical substances, AMPK, TOR, sirtuin, and then there are gene boosters. And interestingly, a very useful gene booster, which has shown to increase life, at least in rats, is metformin. Metformin is widely available, and maybe we'll have, for primary prevention of hypertension, metformin and other drugs like NAD boosters or rapamycin could be available. So what works? Prevention to intervention and back to prevention. That's what my particular theory is. In the isolated tribal communities in Brazil and South America, in Africa, blood pressure does not increase with age if you're living as a tribal lifestyle. So known as Paleolithic lifestyle, you are very active, consume very low amount of salt, the blood pressure will not happen. You will never get hypertension. So can we go back to this particular lifestyle is crucial, and I don't think it's possible now. And Dr. Agarwal already talked about the interventions, lifestyle interventions in hypertension. Weight loss, diet, sodium, potassium, physical activity, tobacco, alcohol, all these things are well known, can reduce blood pressure between 5 to 10 millimeters of mercury, almost like one tablet of a particular drug. Yoga, again, is a useful technology. Lots of trials combine is 6.5 systolic, 2.8 diastolic reduction can happen if you use yoga. And what I have shown here is that yoga is healthy lifestyles can achieve the same benefit as drugs. So clearly, healthy lifestyle is the future right now for prevention or cure of hypertension, especially if you're living an unhealthy lifestyle. But I think other interventions will have to wait till the research. So we asked a question, can we cure hypertension? And the answer is no, not yet, because complexity of hypertension treatment and the lifelong adherence have prompted search for holy grail or once and done therapies. Promising approaches, I've told you, denervation therapies, bariatric surgeries, vaccines, and gene-based personalized therapies are in the pipeline, and I think that's the future. But I think currently the only available option is to revert to healthy lifestyle, Paleolithic nutrition, physical activity, very healthy diet, and I think that's the way for the future. Thank you very much.
Thank you very much, sir, for your excellent and lucid talk on the hypertension. And I wish to congratulate all the speakers who have presented excellent ECG cases, echo cases, and clinical hypertension studies on the hypertension. One simple question I just want to ask Rajiv sir and Bhagarata sir and Kaushik sir. Sir, what I have observed in my clinical practice, that is there any variation in the seasonal variation for the hypertensive patients in the blood pressure? Because what I have observed in my clinical practice, that in winters, in hypertensive patients, BP goes a little bit on higher side, needing the increase in the antihypertensive drugs. And in summers, it goes a little bit down to decrease the antihypertensive drugs. These are my just observations. So is there any studies, and what are your observations, sir?
I think hypertension variability is a very important issue. Variability can be day to day, that within a day there could be variation, and there are variations, which is protective actually. You reduce your systolic blood pressure while you are sleeping, you increase your systolic blood pressure while you are exerting. So I think it's a physiological variation. So as long as the variation is within the physiological limit, say between 100 and 100 systolic in sleep, 140 to 150 systolic when you are exerting, that's normal. It's only the ordinary variation, that extraordinary variability, which is harmful for the target organ damage.
Thank you very much.
Okay, thanks for a really interesting clinical session. There was some pearls, ECG and echocardiography pearls, followed by myths and facts, and finally the trying to find the holy grail of the treatment of hypertension. So thanks to the organizers for bringing out such a interesting and useful scientific session. Thank you.
Thank you so much to all the panelists and speakers. So here we conclude the session 1, and to begin with the session 2, may I request Dr. Rajiv Gupta, Dr. R.K. Tongia, Dr. Anup Jain, Dr. S.M. Sharma, Dr. Chandrakant B. Patil, Dr. Atul Kasliwal, Dr. Vinayak Agrawal, Dr. Sunil Mittal, and Dr. Chitresh Chahar for chairing this session and to take this session forward.
एक मिनट रुक अरे एक मिनट रुक आ गए क्या सर अरे मुझे सर की पीपीटी चेक करनी थी यार किसी की चल
Good afternoon, everybody. We are running only 15 minutes late, so I hope that during this time we may be able to recover a bit. This is a very interesting session now on heart failure. And as we all face every day, heart failure is a big challenge no matter where we practice and what we do. And with the increasing age of population, this is going to get worse and worse. The first talk is on heart failure, past, present, and future. And I would request and invite Dr. Sean Penney from USA to deliver his talk.
Well, thank you very much. I'd like to extend my thanks to Dr. Sharma, Dr. Rana, Dr. Sharma, and Dr. Makar for inviting me to be with you this afternoon. It's really a pleasure to be here. My charge over the next 20 minutes is to cover all of heart failure, past, present, and future. So let's begin. So I'm going to start off by this nice summary slide, and I would posit that the last 4 decades have really been characterized by success with heart failure. And it's best typified by this slide that shows the large-scale randomized clinical trials that led to practice-changing medications that have significantly improved the lives of patients suffering with chronic heart failure. Starting with the vasodilators and ACE inhibitors back in the 1980s, the beta blocker trials in the 1990s, the trials in the early 2000s with cardiac resynchronization, and then coming up to treatment with sacubitril valsartan around 2014 and 2015, and then more recently, the SGLT2 inhibitors around 2018 to 2020. Now with that, we've seen a significant improvement in survival for patients living with chronic heart failure. And if we think back to the 1970s, 5-year survival for patients with chronic heart failure was less than 30%. And if we look only a decade ago, that survival had increased to more than 50% to 60%. Significant improvements, yet there's still a lot of work that we need to do, and that's because heart failure mortality is as bad or worse than most forms of cancer. We also know that heart failure remains widely prevalent throughout the entire world, with a lifetime incidence of about 1 to 2% for all adults living across the globe. And you can see that the rates of cardiovascular mortality, heart failure incidence is very similar between the United States, where I live and practice, and here in India. Now, what is new is that about a year ago, multiple societies came together and came up with a new definition, a universal definition for heart failure. And it states that heart failure is not a specific diagnosis, instead it is a clinical syndrome. And it is characterized by having symptoms or signs caused by a cardiac functional or structural disorder. And this is important, it's corroborated by evidence of congestion, either through the presence of elevated natriuretic peptide levels, evidence of pulmonary congestion, or systemic congestion. Now, what did not change is the classification, the staging system of heart failure. It still remains A, B, C, D. So patients who are at risk for developing heart failure are stage A. Those patients who have evidence of structural heart disease but have never had symptoms of heart failure are stage B. Those patients who have symptomatic heart failure are stage C, and they remain stage C unless they progress to stage D or end-stage heart failure. But what this new society guideline has done is drawn very clear lines in the sand around ejection fraction to characterize the 3 forms of heart failure. We talk about heart failure with reduced ejection fraction. That's defined by having an ejection fraction of less than 40%. For those patients who are between 40 and 50%, we now term that heart failure with a mildly reduced ejection fraction. And heart failure with preserved ejection fraction right now is clearly defined as having an ejection fraction of 50% or higher, and it removes the ambiguity that had been developing over the last several years. This new document also introduces a concept of heart failure with improved ejection fraction, and that's defined by those patients who had heart failure with reduced ejection fraction who experienced an improvement in their EF by at least 10%, and end up having an ejection fraction greater than 40%. And the last thing is that language does matter, and one of the things that is emphasized in this new definition of heart failure is that we cannot cure heart failure. We just heard about some exciting ideas that maybe we could cure hypertension, but heart failure is irreversible. And so for that reason, we can't talk about heart failure being stable. Instead, we say it's persistent. And we can't say it's recovered, we say that it is in remission, the term that was just used also as we talked about hypertension. So one of the nice things about treating patients with heart failure, reduced ejection fraction, is that we have these guideline-directed medical therapies. We have 4 major classes of guideline-directed medical therapy. And this new ACC, AHA, HFSA guideline published last year establishes the primacy of ARNIs, sacubitril valsartan, as being better than an ACE inhibitor or an ARB. Everyone who has heart failure with reduced ejection fraction should be treated with an ARNI, combined with an evidence-based beta blocker. And when I say evidence-based beta blocker, I mean metoprolol, carvedilol, or bisoprolol. After patients are on those 2 classes of medicines, you have to add an SGLT2 inhibitor. I'm going to talk a little bit more about those in a minute. A fabulous group of cardiometabolic drugs that has made significant improvements across a wide range of heart failure. And then lastly, for those individuals with reasonable kidney function who do not have hyperkalemia, they should be treated with a mineralocorticoid receptor antagonist or an MRA. And the reason why these are all level 1 recommendation is because they all significantly reduce mortality in heart failure and do so by 20 to 30%. And if we think about 2-year mortality for heart failure, a few years ago, 1 out of every 3 people would die within 2 years of having been diagnosed with heart failure. Now it's 1 in 10. And it's 1 in 10 because of these 4 classes of guideline-directed medical therapy. But where the greatest opportunity lies and where the greatest challenge is happens to be in our ability to get these medications into patients. And the reality is that, at least in the United States, we do not do a very good job of prescribing, initiating, and escalating doses of guideline-directed medical therapy. This is data from the CHAMP registry looking at individuals who were enrolled at the time that they had heart failure with reduced ejection fraction, were followed for 12 months, and look to see what were the changes in their medications. Then you can see that the biggest piece of that pie is in red, and those are patients who started the trial or started the observation period on less than a maximal dose of that particular form of guideline-directed medical therapy and ended 12 months later without any change in their dose. In fact, it's only the minority in green that achieved the maximally tolerated dose, the indicated maximum dose of those guideline-directed medical therapies. And if one asked a question, what are the percentage of patients who were tolerating a maximum dose of an ARNI, a beta blocker, an MRA, and an SGLT2 inhibitor after 12 months? The answer is a staggering less than 1%. So why is it so difficult to initiate and escalate these medications? I actually don't think it's because we as physicians don't try to do it, and I also don't think it's because patients don't try to do it. The reality is that sometimes it's difficult to tolerate these medicines either because of blood pressure limitations or because of kidney function or because of just subjectively not feeling well. But I do think that there are some approaches that can be institutionalized to try to improve our ability to deliver guideline-directed medical therapies. In my center at the University of Chicago, we created a heart failure disease management program. And one of the things that we did is we partnered with pharmacists. So my patients will go and see a pharmacist every week to increase the doses of those 4 classes of guideline-directed medical therapy to rapidly achieve maximally tolerated doses. We also combine that with remote patient monitoring, either patient-facing apps that they can use on their smartphone or vital signs that they can take at home or some invasive monitoring devices so that we can increase their medications while monitoring them at home. And then lastly, we also introduced outpatient pathways with clear triggers for initiating and escalating these doses of guideline-directed medical therapy. Now, the other thing that the guideline has done for us is to say that we need to be restless. We can't just accept that patients are sufficiently treated. And if they are on those maximally tolerated doses of guideline-directed medical therapy, we then must look for other targets for treatment. And one good one is looking at functional or secondary mitral regurgitation. What the guidelines have now done is to say that it is appropriate in those individuals who continue to remain symptomatic in spite of being treated with guideline-directed medical therapy, who have an ejection fraction less than 50%, meaning that their mitral regurgitation is functional, and not due to a structural problem, that they have, that they then look at the mitral valve anatomy. If the anatomy is suitable and they fit the COAP criteria, which essentially means that the ventricles can be big but not too big, the pulmonary pressures can be high but not too high, that if that's the case, then it's a 2A recommendation that they be treated with mitral valve transcatheter edge-to-edge repair, which goes by the acronym TEER. Well, moving on then, if we move up the ejection fraction from reduced ejection fraction to mildly reduced ejection fraction, we now have this new category, but there have been very, very few clinical trials performed in this group of individuals. And for that reason, the current guidelines only have one 2A recommendation, and that is to treat patients with an SGLT2 inhibitor. Now, the reality is that we don't know why these medications work in heart failure. We have a number of theories, and some of them are actually quite compelling. One of them is that it activates the starvation pathway, the sirtuin-1 pathway, that ultimately leads to decreased oxidative stress and leads to improvements in left ventricular function and left ventricular remodeling. The second one has to do with interference with sodium-hydrogen exchange in the kidneys, leading to less cardiomyocyte injury, less sodium avidity, and again, less myocardial remodeling. But the theory that I think holds the most water is the fact that these medications induce a form of ketosis. And as a result of that, the heart then begins to use the epicardial fat as its energy source. And we know that epicardial fat happens to be very cytokine rich, and it produces pro-inflammatory, pro-fibrotic cytokines. And by eliminating epicardial fat, you decrease these pro-inflammatory, pro-fibrotic cytokines, and as a result of that, you abrogate the remodeling process. Now, if we look at the use of empagliflozin or dapagliflozin, one of the things that has emerged as we combine, let's say, the EMPEROR-reduced trials with the EMPEROR-preserved trials, is we see that SGLT2 inhibitors have an effect, a very consistent effect, in reducing heart failure hospitalization and total heart failure hospitalization across a wide range of ejection fraction. And in fact, we can continue to see a signal of benefit up until an ejection fraction of greater than 65%. And if we look a little bit further and look at combination therapy, not just with an SGLT2 inhibitor, but also with an ARNI and with an MRA, a couple things emerge. Very nice study by Muthu Vaduganathan from Brigham and Women's Hospital, who looked at and pooled together all of these trials and showed that as you had a lower ejection fraction, in this case around 45%, we see significant benefits with this combination therapy in reducing both mortality as well as the risk of heart failure hospitalization. But as the ejection fraction begins to increase, if you're in that mildly reduced range, you can see that there is some benefit in reducing hospitalizations, but not so much in reducing mortality. And once you get up above 60-65%, you don't see those reductions in mortality or heart failure hospitalizations. And I think that's well characterized by that curve on the right-hand side, showing where the benefit begins to phase out with an ejection fraction around 60-65%. All right, let me pivot to heart failure preserved ejection fraction. It's the largest group of individuals who have heart failure characterized by signs and symptoms of heart failure, but with a preserved ejection fraction, particularly manifest in patients who have exertional intolerance. We can screen individuals with the H2FPEF score, where they're weighted according a different point scale if they have obesity, hypertension, atrial fibrillation, pulmonary hypertension, older age, or elevated filling pressures. You can add up the score, look at the nomogram at the bottom. So people who have a score of 4 have about a 70% chance of having HFpEF, whereas those who have a score of 7 have a greater than 95% chance of having HFpEF. But what I'd like you to remember about HFpEF is that this is a hemodynamic disorder. This is well characterized by these two slides. If you look on the left, this is data from Barry Borlaug, showing that in normal patients, health controls in black, when you lift the legs or when you do low level or medium exercise, there is not a significant increase in the wedge pressure. But look what happens in red when you treat or test patients who have HFpEF. Just raising the legs is enough to increase the wedge pressure from 10 to 20 millimeters of mercury because of that increase in venous return, with further increases of wedge pressure to 30 and 40 millimeters of mercury with exercise. Very characteristic of HFpEF. The second thing is to look at a new marker, which is looking at the change in wedge pressure over cardiac output. And what is characterized by patients with HFpEF is that the wedge pressure increases much more over time with exercise than the cardiac output goes up, suggesting that cardiovascular compliance, vascular compliance is very poor, so that if you see a slope of more than 2, it is almost 100% certain that they have HFpEF. How do we treat it? Well, we treat the underlying cause, treat hypertension, treat sleep apnea, just as we heard a few minutes ago, and then after relieving symptoms with diuretics, treat with an SGLT2 inhibitor. All right. I've been asked also to talk about the future of heart failure, to think about what does the future state look like, and I would characterize it by 5 things. We're going to develop new conceptual models. I just walked you through how ejection fraction is what we use. I think we're going to come up with better integrative models, and I'll talk about that in a minute. We're going to focus more and more and more about healthcare delivery. We're going to see a rapid expansion of device therapy for treating heart failure, something I'm going to talk about later this afternoon. We're still going to see new pharmacologic therapies, and I think the promise of regenerative or replacement therapies remain out there. So why do we need to reclassify heart failure? I think it's because we see that there are limitations in defining heart failure just by ejection fraction. And that's because we see that the things that cause heart failure across the entire range of ejection fraction are consistent. High blood pressure, obesity, coronary artery disease, older age, all of these things contribute to heart failure. And instead of looking at it as being defined by ejection fraction, we should really look at it as the comorbidities that drive the syndrome. We're also going to use precision medicine. Not only are we going to look at genetics and pharmacogenomics as well as proteomics, but we're going to do deep clinical phenotyping, using our electronic medical record, combining these together to develop clear phenotypes that we can then target either for personalized medical therapy or for new clinical trials to define why a drug or therapy works in one group and doesn't work in another. As I mentioned to you about our heart failure program in Chicago, we're going to develop new healthcare delivery models. Essentially, we want to take the care that's delivered in the hospital and move it to the outpatient space, and we want to take the care that's being delivered in the outpatient space and shift it to the home. One thing I'd like to introduce is this concept of the door-to-diuretic time. We certainly know about door-to-needle time, door-to-wire time, but door-to-diuretic time. Rapid decongestion of hospitalized patients will decrease inflammation and should also spare the kidney and improve outcomes. I won't touch upon the device therapies right now because I'm going to go into it in greater detail in just a few minutes, but I think we are going to see an expansion of some of these experimental therapies. In terms of new drugs and new approaches to treating heart failure, I think these non-classic RAS like Ang1 to 7 are potentially exciting, as are cardiac myosin activators and some of the gene therapies, adeno-associated viral-directed therapies. And lastly, what does the future hold in terms of regenerative or replacement therapies? We're going to see a total artificial heart that works, a left ventricular assist device that works. Xenotransplantation is certainly right around the corner, and we were all enthused about the fact that there was a successful xenotransplant 1 year ago. And then lastly, why not be able to grow your own organ? This is currently happening where you can have a decellularized structure that you can then use one's own cells to repopulate it. This is happening for kidneys, it's happening for livers, it's happening for lungs, and it's going to happen for the heart. So in conclusion, chronic heart failure survival has significantly increased, but we still have a lot of work to do. I think our greatest opportunity and our greatest challenge is initiating and escalating guideline-directed medical therapy, new conceptual models for the delivering of, for understanding heart failure, powered by artificial intelligence will help to lead the way to personalized therapy, New drugs and devices are in the pipeline, and I think the future is very hopeful and very exciting. So with that, let me stop and thank you very much for your attention.
Thank you. Thank you very much, Professor Penny. Can we have two quick questions from Professor Penny if somebody is interested?
Very nice talk. Thank you for that. Just want to ask one question. When we diagnose HFpEF today, you showed H2 HFpEF score. The recent paper from Mayo actually said that the accuracy of that data, scoring algorithms which we have today is not more than 50%. Do you agree with that? Do you use these scores in your clinical practice to diagnose HFpEF? Or is there a more, say, common sense pathways that we use for diagnosing HFpEF?
It's a great question, and the reality is, no, I use common sense. And in my practice, most of the persons who I see with HFpEF tend to be older, they tend to be women, and they tend to be a little overweight. And so if you throw in atrial fibrillation on top of that, it's HFpEF.
Thank you.
Thank you.
Thank you very much. So we'll have the next talk by Dr. Sanjeev Sardana. He'll be speaking on what's new in armamentarium of heart failure pharmacotherapy. Dr. Sanjeev Sardana is a senior consultant cardiology at the Eternal Heart Center.
Thank you, Dr. Rajiv, for the introduction, and good afternoon and warm welcome on behalf of Eternal Hospital in this Eternal Heart Conclave. So from previous presentation, we have already discussed how to make diagnosis, what is the epidemiology, symptoms of the heart failure. So I'll straight away go to the pharmacotherapy of heart failure and what are the recent advances which have been done. And this slide has already been shown, and paradigm onwards, that is ARNI and newer drugs I'll discuss in my presentation. And we know that ARNI caused a paradigm shift in the management of heart failure, and it is a combination of sacubitril, valsartan, and what valsartan does is it blocks the renin-angiotensin system, which has got many deleterious effects in the heart failure patient. And what neprilysin does is that it augments the natriuretic peptide system as well as the bradykinin system, and so it will take care of the three system. And drug was tested in the Paradigm HF trial, which was the largest clinical trial in heart failure, and there was initial run-in period, and after that patient were randomized either to enalapril 10 mg twice daily or sacubitril valsartan 200 mg twice daily, and there was significant 20% reduction in the primary endpoint, and all individual components also contributed to reduction in the cardiovascular death, hospitalization for heart failure, overall mortality, heart failure death, and there was also reduction in sudden death also. And now we have evidence that with the use of ARNI, there is reverse cardiac remodeling, and which have been proven in the PROVE-HF trial, and there was reduction in left ventricular end volume index and systolic volume index, and there was improvement in ejection fraction and reduction in the left atrial volume index also. And now we have evidence from the Pioneer HF trial that drug can be started even in the patient who are still admitted for the acute decompensated heart failure. And after the initial stabilization, patient was randomized either to sacubitril valsartan or to enalapril, and the result showed greater reduction in the anti-proBNP levels as compared to enalapril, as there were improvement in cardiovascular death and hospitalization for heart failure. All these studies were done in the patient who had previous exposure to either ARBs or AC inhibitor, but now we have evidence that from the transition study that this ARNI can be started even in the patient who present first time with the heart failure and there is no previous exposure to AC inhibitor and ARBs, and even these de novo patients, they tolerate the drug better than the follow-up patients. Now coming to the second group of drug, that is SGLT2 inhibitors, and mechanism of action has already been discussed in the previous presentation, and these drugs cause the reduction in the preload and reduction in the afterload, and there is effect in the myocardium also. Ultimately they lead to improved cardiac structure and function, and use of these drugs are not associated with any significant change in any of the electrolytes. And DAPA-HF was the first trial in dedicated to with the SGLT2 inhibitors, and for the heart failure patient, both diabetic as well as non-diabetic patients were included. And these are the result of this trial. There was 26% reduction in the primary endpoint of worsening heart failure as well as cardiovascular death, and number needed to treat was 21, and drug was found to be very safe and well tolerated even in patient who has diabetes or patient who do not have diabetes. And the drug was tested in patients of heart failure with preserved ejection fraction also in DELIVER trial. Again, there was 18% reduction in the primary endpoint of cardiovascular death or worsening heart failure, and all individual components, they contributed to the superiority of primary composite endpoint, and a consistent treatment benefit was seen across all the pre-specified subgroup, including the patient who has got ejection fraction of more than 60%. So now we have evidence that this drug can be used in all the patients of heart failure irrespective of ejection fraction. And the second drug in this class is empagliflozin, and which was tested in Emperor reduced trial. Again, it caused a significant reduction in the primary endpoint of cardiovascular death or heart failure hospitalization. There was 25% reduction and 5.3% absolute risk reduction, and number needed to treat was 19. And again, this drug was also tested in patient with the heart failure with the preserved ejection fraction in the Emperor preserved trial. And it was the first trial which, with any of the drug, which caused significant reduction in the primary endpoint in patients with heart failure with the preserved ejection fraction. None of the other previous trials has shown significant reduction in the primary endpoint. There was 21% reduction in the primary endpoint, 27% reduction in the hospitalization for heart failure, and the drug was effective in both the subgroup with the mildly reduced ejection fraction as well as in the preserved ejection fraction. So again, with the empagliflozin, we have evidence that drug is useful in all heart failure patients irrespective of ejection fraction. And with the empagliflozin also, now we have evidence that drug can be started while the patient is still in the hospital, and this is the IMPULSE study which was conducted, and after initial stabilization, patient was randomized to either empagliflozin or placebo, and there was 36% greater likelihood of clinical benefit, and benefit was consistent regardless of heart failure onset, whether de novo or chronic, regardless of ejection fraction category, as well as diabetes mellitus status. Now we have evidence of reverse cardiac remodeling with the empagliflozin also as with ARNI, and there was reduction in the end systolic volume index and diastolic volume index as well as ejection fraction. So now coming to the third class of drug, that is SGC stimulator. These are the new drug which is now available in the India, and the name of the drug is Vericiguat, and we know that in heart failure, oxidative stress and endothelial dysfunction reduces the bioavailability of nitric oxide, and which contribute to impaired vascular function and contribute to heart failure. And Vericiguat, by directly stimulating SGC, it has got potential to impact the heart failure pathophysiology. And what it does is it increases the availability of cyclic GMP, and which has got a lot of beneficial effects in the patients with the heart failure. And Victoria trial was done to test this hypothesis, and 5,000 patients were included in this trial after the worsening of a heart failure event, and there was 10% reduction in the primary endpoint, and absolute risk reduction was 4.2, and number needed to treat was 24. And Vericiguat has a very favorable safety profile in Victoria trial. Almost 90% of the patient, they could achieve the target dose of 10 milligram, and there was no significant difference in the symptomatic hypotension or syncope. And the worsening renal function was also similar in placebo as well as Vericiguat group, and there was no change in sodium levels or potassium levels. And drug is started with the dose of 2.5 milligram and increased every 2 weeks to the target dose of 10 milligram. And it is not recommended to be used with 5-phosphodiesterase inhibitor 5 and other SGC stimulators. And now coming to the another class of drug, which is omecamtiv mecarbil. It is a cardiac myosin activator or myotrop, and it is a very different class of drug. It is the only drug which focuses on the basic pathophysiology of heart failure, that is reduced contraction, and it activates cardiac myosin and augments the speed of ATP hydrolysis, and it thus accelerates the production of strong actin myosin complex and recruits more number of myosin heads, which lead to increased force production, and therefore it prolongs the systolic ejection time, it increases the cardiac contractility, and it increases the cardiac output. And all this is not associated with no change in calcium hemostasis, no change in myocardial oxygen consumption, and there is no change in LV dP by dt. And this drug was tested in Galactic HF trial, and there was 8% reduction in the primary endpoint of cardiovascular death or heart failure hospitalization event, and it was major contribution to this was heart failure event, and there was no change in the cardiovascular death and no change in the quality of life. And this drug is not associated with any reduction in the blood pressure, and there is no negative impact on the renal function or potassium. And it is not associated with increased myocardial ischemia or ventricular arrhythmia when it was compared to placebo. But still, this drug could not actually get US FDA approval, and this drug is not available in India also. And now coming to the guidelines, these are the guideline recommendations for stage A and stage B heart failure. And for stage A patients, that is at the risk of heart failure patient, we should have optimal control of blood pressure. We should treat the patient with diabetes mellitus, preferably with the SGLT2 inhibitors, and appropriate management of cardiovascular disease should be done. And patient who has got ejection fraction of 40% or less, they should be treated either with ACE inhibitor, or if they cannot tolerate ACE inhibitor, we should subject them to ARBs, and beta blockers should also be given to all the patients. And we should continue lifestyle modification and other management strategy in all these patients. And in this subgroup of patient, we should avoid drugs like glitazones, that is pioglitazone, and a non-hydropyridine type of calcium channel blocker. They are contraindicated in this subgroup of the patient. And this is the management protocol for the class C, that is patients with symptomatic heart failure. All the 4 drugs, that is ARNI, beta blocker, MRA, and SGLT2 inhibitors, they are the class 1 recommendation, and diuretics should be given whenever needed to reduce the congestion. And some of the patients, they will improve with this treatment, and we should continue this medication in these patients even if they improve, and this is a class 1 recommendation to continue the treatment in this subgroup of patient. And if patient still remains symptomatic despite use of all these possible drugs, then we can add the additional therapies like CRTD, or we should consider the additional therapies. And if patients still remain symptomatic, that we label them as refractory heart failure. And these kind of patients, they should be given the option of mechanical circulatory support, or patient can be given the cardiac transplant. And these are the additional medical therapies for the patient with heart failure with reduced ejection fraction. Ivabradine has been given class 2A recommendation whenever patient has got heart rate of more than 70 despite the use of beta blocker, or patient cannot tolerate beta blocker. And Vericiguat, digoxin, PUFA, and potassium binder, they all have class 2B recommendation. These are the important comorbidities treatment according to these latest guidelines. And there should be optimal treatment of hypertension and hyperglycemia. If patient is a suitable candidate for revascularization, he should be subjected to surgical revascularization. And all these are class 1 recommendation, and IV iron therapy has been given class 2 recommendation for these patients. This has already been discussed. And these are some of the contraindications in the patients with heart failure. And these are the class 1C antiarrhythmic medications and doniadarone. And these heart failure patients should not be given glitazones like pioglitazone, and DPP4 inhibitors like saxagliptin and allogliptin, they should not be given in patient with the heart failure, and we should avoid using NSAID in these patients. And ACE inhibitor, ARNI should not be given within 36 hours of the exposure to ACE inhibitor, and ARNI and ACE inhibitor, they are contraindicated in patient with the history of angioedema. And we can actually classify our patient into one of these 9 profiles, so that we can prioritize which are the drugs which should be given a preference to for that particular patient, depending on the various parameters like heart rate, blood pressure, and presence of AF, CKD, or hyperkalemia. And for rapid introduction of all the GDMT, we can actually choose the rapid sequencing, so that we can introduce all the medications within 4 weeks. Thank you. With this, I'll end my presentation. Thanks.
Very nice presentation of the heart failure pharmacotherapy.
Thank you, sir.
Fully, I think you have touched most of the drugs. We have got lot of options for reduced ejection fraction.
Yeah.
Starting with the 4 pillars and later adding other things. But we have got limited option for a heart failure, preserved ejection fraction.
Yeah.
What is your go on that.
So now we have evidence of benefit with the SGLT2 inhibitors, and these drugs has been given class 2A recommendation by the latest ACC/HA guidelines, which were released last year in May. And diuretics are definitely the class 1 recommendation, and all other drugs like ARNI, ARBs, they have been given class 2B recommendation to be used in this class
So
of
we have
patient.
got a very limited option.
Yeah, definitely.
Except that treating the comorbidities.
Yeah.
And if any revascularization, I think that has to be undertaken. So that is very important with preservative, because we have got limited pharmacotherapy
Limited
there.
option.
Thank you.
Dr. Sidhana, excellent talk. I have a question regarding the reduced, what are the signals we have with the reduced doses of Vimada? Because I would agree, you would agree that a lot of our Indian patients are not able to achieve the 200 milligram dose. So do we have any signals? And of course, we need to generate data in the reduced doses also, because not more than, I think, 25% of your patients would be on the complete total dose of Vimada. And the second question is, sir, regarding what are your personal practice in patients who have borderline hemodynamics? So we have all these therapies, but what about, because our Indian patients are especially prone to the hypotensive effects of these full dosage guideline directed therapies?
One thing I would like to say that we as Indian, we should stop underestimating ourselves. So whatever the drug which have been tested in Western patient, our patient can also tolerate. Just we need to increase the doses very gradually. And many of my patients, they are on 200 milligram twice daily on the of the sacubitril valsartan. And definitely, if patient remains symptomatic and patient cannot tolerate GDMT, then definitely these are the patients who are in stage 4 heart failure, and these patients should be offered additional treatment in the form of mechanical circulatory support, or they should be referred for cardiac transplantation if patient remains symptomatic. But most of the patient, they are able to tolerate, and if we have to reduce the dose of guideline directed medical therapy, that means patient is progressing into the stage 4 heart failure, and these patients should be chosen very early for the definitive treatment. So unfortunately, we don't have any
Even if you
data.
give 50, half tablet of the ARNI, that is, the trials have shown that they are also beneficial. So start with the lowest dose possible. You can have, why not? We have got different class of dose. ARNI, you can give a half tablet. Even now in some Indian companies, they are coming with 25 milligram of ARNI also. Well, we have got Concor, bisoprolol, good. You can start with the 1.25 milligram. You can increase up to 10 milligram. So in all other groups, though with the SGLT2 inhibitors, there's no problem with the hypertension. You can straightforward start with the 10 milligram. I think SGLT2 2 inhibitors, they are the class drug. Even in the hypertension you can give. And Verisvagat has also shown in the trials that you can start even with the 90 and 100 millimole.
So definitely we need not to start the drugs in their historical discoveries. Definitely we can start with the SGLT2 inhibitors also, because all these 4 class of drug has been given class 1 recommendation, so there is no preference of one drug over the other drugs. So that's why I presented these 9 profiles, so that we can categorize our patient into one of those profile, and we can prioritize the medical treatment. Second question, he was asking the benefit of reduced dose is that unfortunately we do not have any data in which reduced dose was compared with the full dose. So unless we have that randomized trial in which reduced dose is actually compared with the full dose, till then we should try to make all our efforts to increase the dose as high as possible.
Thank you very much, Dr. Sidhana.
Thank you, sir.
Excellent talk. And I think from this discussion we can all at least summarize that because heart failure is such a devastating disease and we need more and more option. I remember my student days when the only option available was digoxin and mercurial diuretics. I'm sure many of you have not heard of mercurial diuretics, which was the only diuretic available at that time. Since then, we have gone a long way, and today there are lots of very interesting and encouraging drugs available. So moving on to non-pharmacotherapies, I'll ask Dr. Jitendra Makkar who's a HOD and Director Cardiology at Eternal Hospital and a go-to person for any EP problem, to please give his talk.
Thank you, sir. Good afternoon, everyone. So, little bit diverting the discussion to, as told by Dr. Tongia, to non-pharmacological therapy, and we have an upcoming lecture by authority to speak about this. But this conduction system pacing may be a new terminology for some of our colleagues. That's why I have chosen this topic, that this is the latest in our armamentarium, which we are doing now. So, conduction system disease and heart failure, they have many interactions, and there are few examples like wide QRS leads to dysynchrony, and which leads to worsening of heart failure. So, any patient who has heart failure, who has a narrow QRS is having better function class, who is wide QRS is having worse function class. Pacemaker created dysynchrony lead to pacemaker induced cardiomyopathy. That we all know that pacemaker can do cardiomyopathy. In different studies, 10 to even 50% of patients on pacemaker, and more is the need of pacing, more is the chances of heart failure. Once we narrow this QRS duration by CRT, that is cardiac resynchronization therapy or biventricular pacing, it improves synchrony and that improves heart failure. This is proven beyond doubt now. Narrower the QRS after CRT, more is the response. So previously when we started implanting CRTs in early 2000, we were skeptical about the end QRS duration and its relation to the clinical effect. But later we realized that it is actually the narrow complex which matters, and narrower the QRS, better is the response. Pacemaker-induced cardiomyopathy can be treated by upgradation to a biventricular pacemaker. So this slide I have presented just to make you learn this, that how conduction disturbances are associated with heart failure and how they are related to pathophysiology of heart failure, creating dysynchrony, and how this creating resynchronization by different methods matters for a heart failure patient. So what are the methods for maintaining this synchrony? One of the oldest and most established therapy is cardiac resynchronization therapy or biventricular pacemaker for people with heart failure, less ejection fraction, and left bundle branch block and a wide QRS more than 120. There are certain limitations of CRT which we realized over the years, that up to 1/3 or at least 25% of patients in our clinical practice, even if well chosen, they are non-responders to this therapy. And considerable failure rates are there despite growing experience. We are still able to not find a suitable vein sometime because of the difficult coronary sinus anatomy. A possible limitation to conventional CRT is that electrical synchronization via BIV pacing is achieved through non-physiological means via fusion of an epicardial LV wavefront with an endocardial wavefront from the right ventricular apex. So it's not exactly biventricular pacing is a good way of resynchronization, but exactly not physiological because it is a combination of epicardial and endocardial wavefront, and physiology means that going from endocardium to epicardium and not from epicardium to endocardium. So what is the solution then? What is next? What the limitations of CRT, biventricular pacing, can they be taken care or not? So recently his bundle pacing and left bundle branch pacing have emerged as physiological pacing modalities which engage the intrinsic cardiac conduction system and can achieve favorable electrical and mechanical synchrony. Several previous studies have also shown that his bundle pacing and LBB pacing can correct left bundle branch and improve cardiac functions. So why at all we need physiological pacing? Why? Because the conventional pacing, where we pace the right ventricle at the apex or we pace at the RV septum, it creates mechanical dysynchrony, systolic dysfunction, diastolic dysfunction, atrial fibrillation, which is very common adverse effect of a pacemaker, mitral regurgitation, whether systolic or diastolic, and also tricuspid regurgitation directly because of the presence of lead inside the tricuspid valve. So these deleterious effects of conventional RV pacing are there. That's why we need some kind of physiological pacing. So when we talk of physiological pacing, we should know a little bit about the conduction system, sinus node, AV node, and right bundle, left bundle. I believe that all of you know that. So his bundle pacing and left bundle pacing. So this was an hypothesis that if we directly pace the conduction system, we screw the lead with conduction system, how is going to behave? So first came his bundle pacing. So where the permanent pacing lead is attached to the his bundle region of the AV conduction system, and he hopes to preserve or normalize biventricular activation. So if we pace the his bundle here, then of course both ventricles would be depolarized simultaneously. So if there is complete heart block, how can his bundle pacing work? So if we pace, like for example, this is bundle of the Hayes and this is the site of block. So if we pace distal to this site of block, then theoretically as well as practically it can capture the conduction system. So this is how it was done. But there are certain disadvantages of his bundle pacing. One is higher and unstable thresholds, and it's not easy to locate because it's a point, not an area. And there can be progressive His-Purkinje disease below the site of pacing, and low R-wave amplitudes, and right bundle branch block, and a few randomized clinical trials. In fact, we attempted his bundle pacing, we did in few cases, but because of complexity of the procedure and uncertainty about the threshold and long-term thresholds, we stopped his bundle pacing, and we used to do only in patients who are not dependent, like in sick sinus syndrome, where actually it may not be needed that much because we need synchronization when patient is pacing dependent. So his bundle pacing is not that practically useful in clinical practice. So then what next? Left bundle branch area pacing. So this is to be understood that this is a place where we don't need exactly to target the left bundle, but even if we pace around somewhere or near the left bundle, it will capture the left bundle. So this is how it is seen on the fluoro. This is the his bundle need, and around 2 to 3 centimeter down and towards the apex there is left bundle pacing site. So in basically what we do is for left bundle pacing, we cross the septum from right, we go to the right ventricle, cross the septum by screwing the lead and go to the left side of the septum, and then pace and see whether left bundle is captured or not. So that technical detail cannot be presented here. Well, let's talk about the evidence. So this HIT-SYNC pilot trial by Dr. Vijayaraman and their group showed that the CRT, they randomized people to HIT CRT and conventional bi-V CRT. So HIT CRT, QRS duration was better and EF increment was better, but there were a lot of pacing failures and lot of crossovers to the bi-V side because of the technical difficulty. So this was not a positive trial in fact, but then his HIT-SYNC pilot showed that at least QRS duration and LV ejection fraction was better in patient with CRT, his CRT. So now there is more evidence in favor of left bundle pacing, and this LBBB pacing resync trial, it actually included non-ischemic cardiomyopathy patient with LBBB, and they randomized to conventional CRT with the conventional CRT with the adaptive algorithms and left bundle pacing, and there were much improved ejection fraction, much improved quality of life, and much improved QRS duration in case of LBBB pacing. So this was a Chinese study. This was about his bundle pacing and left bundle pacing. Now, what is the relevance with heart failure? So what we can do is we can use it as an alternative to CRT. We can use it as a failed case of CRT, and sometime we can use it along with CRT. How to use with along with CRT? Indication of left bundle optimized pacing when baseline QRS duration is not very high, because CRT doesn't reduce the QRS duration to that extent. So if there is borderline increased QRS, LBBB can actually narrow down. LBB pacing can actually narrow down. So this is the left bundle pacing here, and this is the normal QRS. So this is how, so this was a CRTP where 3 leads were implanted, but if it is CRTD, a 4th defibrillator lead is also implanted. So another indication for this is pacemaker induced LV dysfunction. So if patient is already on the pacemaker and patient has developed LV dysfunction, previously we used to upgrade to CRT, and still guideline wise, indication wise CRT is indicated, but as an alternative left bundle branch pacing can be used. So this is how is the pacing QRS by conventional pacing, and this is paced QRS by the left bundle pacing. So CSP as an alternative to CRT. So this is again, so this is also, now you cannot say whether it is a paced QRS or not, because this is a bipolar left bundle branch pacing. So if I put this ECG in a quiz, nobody can find out that this is a paced QRS, but actually this is a paced QRS. And this is bipolar pacing, so basically anode and cathode both are pacing, but actually the left bundle is paced by cathode. So if we do unipolar pacing, this looks like this, still a very narrow QRS, but right bundle branch block type. And in this ECG, when pacing is from both sides of septum, a fantastic synchronized QRS can be obtained. So our aim is to get a narrower QRS, not to do definitely a selective left bundle pacing and creating a right bundle branch block, but because with the availability of pacing. Thank you very much.
Role of CCM, cardiac quantity, is not useful. Is there any role?
I am not aware of this.
No, cardiac contractility modulation, CCM, right-sided pacing, the septum, biphasic pacing.
I am not aware of such terminology in this.
Okay, thank you.
So I have a question regarding what is your take on, because a significant chunk of the patient who did not improve with CRT were the patients who had ischemic cardiomyopathy. So what is your take on the conduction system pacing, especially left bundle branch area pacing in ischemic patients? And secondly, what about hypertrophic patients? So what is your experience in both kinds of subset?
Yeah, so I think as we are growing up with these technologies, we consider that non-ischemic cardiomyopathy is good to have because everything works, and in non-ischemic cardiomyopathy, they work less. So as far as non-responder to CRT, ischemic cardiomyopathy, we can do left bundle branch pacing, but the problem is the necrosed septum and thin septum. So to go across to the septum, we should have at least 9-10 millimeter thickness of the septum preserved, which may not be a case in ischemic cardiomyopathy, but it is a case in non-ischemic cardiomyopathy. So one thing, yes, if suppose somebody had inferior posterior MI, then infarct expansion, remodeling, and septum is okay, that patient is good even if it is ischemic cardiomyopathy. But an anteroseptal MI with necrosed septum, we have refused in our clinical practice to do LVB pacing. Hypertrophic, yes, it is an option, but we should have those thick leads to pace and to go to that side of the septum. So it is not applicable in hypertrophic cardiomyopathy as yet with the conventionally available leads. But yes, with stellate driven leads, we there is work going on in this direction.
So not an option in aortic stenosis patients post TAVI? who develop the conduction block.
Yes.
Not an option in those, I consider.
Yeah. So initially, in our Eternal Hospital, initially tower program, we have done many CRTs after doing tower because they didn't improve because of heart failure. And now, yes, left bundle pacing is, but if valve is implanted correctly, not much below the aortic annulus, it is an option, but we have to find out. I have yet to do after a tower LBB pacing, but it is practically possible. Yes.
Just a practical question. When you are doing CRTP or say CRTD, and you have the option of doing lot CRT.
Lot CRT, yeah.
Lot CRT. So do you actually put a LV lead also in these cases always now, right now? Because, I mean, in terms of concept, in a patient who has ischemic cardiomyopathy, even if you, so the major issue is that there is a dispersion of electrical impulses, there is a scarring which is happening. So even if you were to pace the left bundle, those electrical impulses may not actually reach. That's why the site-specific pacing is important in those cases. That's how the dyssynchrony concept came up. So the inhomogeneity is going to be less in a non-ischemic cardiomyopathy as compared to ischemic cardiomyopathy. So what is your take on it?
Yes, of course, LVV pacing works better in non-ischemic cardiomyopathy. It's not the case that in ischemic cardiomyopathy we cannot maintain the synchrony by CRT or left bundle branch pacing, and they still work. And the concept behind lot CRT is because of two reasons. One, that we not have clear indication to just do LVV pacing and forget in a heart failure patient. Guideline wise, we have to give CRT. And when we think that CRT alone is not going to benefit that much, then we can add on, because you are implanting anyway 3 leads. So you can implant to the left bundle branch, the RV lead can be implanted on the left bundle branch block. And to our surprise, whatever is the size of heart, no matter how LV is dilated, if you can capture the left.
Just want to point out, cardiac contractility modulation is listed here. So CCM is delivering an electrical impulse during systole, and what that does is it paces during the absolute refractory period, gives a little bit more calcium release, so you get a little bit more contractility. It's been shown to improve exercise capacity in patients with heart failure and is being explored as an adjunctive therapy. What I want to do is to first focus on physiology, and I want to bring us back to Laplace's law. And Laplace's law tells us that the wall stress for a cylinder or for a volume is equal to the pressure inside that volume times the radius divided by twice the wall thickness. So let's look at this in 2 scenarios. One is in aortic stenosis. In aortic stenosis, you have an obstruction of flow that increases left ventricular pressure in the ventricle, and the heart attempts to normalize that wall stress by getting thicker, and by increasing in size it can decrease the wall stress. The other way of looking at Laplace's law is what happens in dilated cardiomyopathies, where you have adverse LV remodeling, where the ventricle gets bigger, where the radius gets bigger, and as a result of that, the amount of wall stress increases significantly. And although there is hypertrophy in these hearts, it's eccentric, which means that the increase in volume is greater than the increase in wall thickness. And that means that in the case of heart failure with reduced ejection fraction, wall stress is very, very high. So, are there some things that we can do to treat this from a mechanistic viewpoint? Well, one of the first attempts was the Batista operation. This is a surgical approach of cutting out healthy myocardium, removing a portion of the anterior wall of the ventricle, reapproximating the edges of the ventricle in an attempt to restore a more normal mass to volume ratio. And unfortunately, this operation did not work. But it did serve to introduce the surgical ventricular restoration, or SAVR procedure, which is a variation on the Batista operation, where a surgeon will incise through an apical aneurysm, then sew a cerclage around the border between viable and non-viable myocardium, cinch that together like a purse string, and if there's a defect remaining, close that with a patch. And effectively what that does is it removes non-contracting myocardium, it decreases left ventricular radius, and it decreases wall stress. Unfortunately, when this was studied in the STITCH trial, it was not found to be helpful. Patients were randomized to CABG alone versus CABG plus SAVR, and as you can see, over a 5-year follow-up, there was no clinical benefit. Well, there were a couple other observations. One is this is the coapsis device. This was a surgically implanted device. It consisted of a tether that would passively restrain the ventricle. It was designed as a buttress for the posterior mitral valve leaflet, and this posterior pad would support the posterior leaflet of the mitral valve during contractility and was thought to decrease mitral regurgitation. Well, it turns out it did a fair job, not a great job in reducing mitral regurgitation, but when they went back and reanalyzed this, they showed that in those individuals who were treated with this device, it could slow down the LV remodeling process. Now, if you put these two technologies together, what you end up with is this BioVentrix device where you can plicate an LV aneurysm and do so either in a hybrid OR or in a cath lab with a joint procedure between an interventional cardiologist and a cardiac surgeon. And here what you can see is by using this device that consists of an internal and external anchor, you can plicate that ventricle, exclude the non-contracting myocardium, reduce left ventricular radius, and remove some of the stress off of the left ventricular myocardium. This also has led to the idea of doing a ventriculoplasty, and that is to decrease left ventricular radius through the use of something called the AccuSense CoreSense device. And so this consists of a device that is comprised of a series of a number of anchors, usually 12 anchors, that are inserted percutaneously into the left ventricle, a cable that is passed through those anchors made out of PTFE, sliders or spacers that are in between each one of those anchors that can distribute the load evenly across that cable, and then lastly a locking mechanism so that when you cinch the device, you end up locking it in place. So here you can see in the arrows are the number of anchors that are being inserted into the myocardium, and at the end of the case, the interventional cardiologist will cinch it and bring the left ventricle closer together. So this is what it looks like. Obviously, it's a cartoon showing that this device is placed in the basal left ventricle, done so not so much just underneath the annulus, but a little bit further down in the ventricle, a little bit more apically displaced. And again, the attempt is to try to bring in the anterior wall of the left ventricle and distribute some of the load onto that cable. Now, what's exciting about this technology is that certainly when you cinch the device, the left ventricle gets smaller, but when we look at these hearts 6 months down the road, they continue to reverse remodel. So in this magenta color was the CT scan doing volumetric assessment at the time of the implant, and then the blue is looking at the volumetric assessment 90 days later, showing ongoing reverse remodeling of the left ventricle. This is it here in tabular form showing 25 to 40% reductions in systolic volumes out through 6 months. Obviously a small sample. We've reanalyzed the early feasibility study data, and it also shows this pattern of ongoing reverse remodeling. Well, let's look at Laplace's law another way. I said that one way to decrease the wall stress is to bring the radius in. The other way is to make the wall thicker. So this was originally done in Germany, where surgeons would inject something called alginate hydrogel, which is a biometric polymer derived from seaweed and is very, very stable. You can see that the surgeons would insert this hydrogel into the wall of the left ventricle, making the left ventricle thicker and therefore attempting to normalize the wall stress. Well, we now advance this out by about 6 years, and we can do this percutaneously. This was data that was just presented about 2 months ago, showing first in human experience with the X-drop system, where one can now percutaneously insert this hydrogel into the left ventricular myocardium to get the wall to be a little bit thicker, again, with an attempt to try to normalize wall stress. These are early results, again, first experience in human, showing everything going in the right direction. New York Heart Association functional class significantly improved so that by 6 months, Everyone was class 2. Significant improvements in 6-minute walk distance, as well as improvements in the Kansas City cardiomyopathy questionnaire, and also favorable indices of cardiac remodeling with smaller ventricular volumes and increases in left ventricular ejection fraction. Well, I showed you this slide before. This is the pivot to talk about secondary or functional mitral regurgitation. You are all certainly familiar with the results of the COAP trial, which was published now almost 5 years ago, showing significant improvements over 2 years in those individuals treated with transcatheter edge-to-edge mitral valve repair, significant reduction in heart failure rehospitalization, as well as a signal of decreasing cardiovascular mortality. But I want to leave you with this point about TEER, and that is that in order for these therapies to be successful when targeting the mitral valve, you have to eliminate the mitral regurgitation in order for it to work. This is a nice analysis by Dr. Saibal Kar, who looked at the degree of reduction in mitral regurgitation in those individuals who were treated with the MitraClip versus those individuals who were treated with guideline-directed medical therapy alone. And if you're scrutinizing these Kaplan-Meier curves, what you will see is that they are essentially identical, that those individuals in green who had no mitral regurgitation or at most trace mitral regurgitation at the end of the procedure or on medical therapy had the exact same endpoint over 2 years. What is different, though, is the numbers. If you look at the number of patients who were treated with MitraClip plus guideline-directed medical therapy, there were 200 patients who had 0 or trace mitral regurgitation versus about 20 who had significant 3+, 4+ mitral regurgitation. This was exactly flipped in the medical therapy arm. So yes, those individuals who had 0 or trace mitral regurgitation on medical therapy had great events, great outcomes over the next two years, but you can see that there are only 21 of them. So it's about 1/10 as powerful as the MitraClip. Moving on, talking about intra-atrial septal devices. These shunt devices are predicated on the idea that shunting blood from the left atrium during exercise, which is a high pressure chamber, over to a low pressure chamber in the right atrium, will decrease pulmonary pressures and improve exercise performance. There are a number of these devices that are in current clinical trials. The most ones that have been studied the most are the Corvia device as well as the V-Wave device. So I want to bring you back to this slide that I shared with you a little while ago, and that is to remind ourselves that in normal individuals with exercise, there is no significant increase in pulmonary capillary wedge pressure, as opposed to those patients who have heart failure with preserved ejection fraction, where you look at what happens with the wedge pressure just raising the legs. You can see with increased venous return, the pulmonary capillary wedge pressure may increase from 10 to 20 millimeters of mercury, and with low level or moderate level exercise, that can go up to 30 and even 40 millimeters of mercury. If we then look at that and plot that against pulmonary capillary wedge pressure against measured peak oxygen consumption on a cardiopulmonary stress test, you'll see that those individuals who did not increase their wedge pressure beyond 20 with exercise all had pretty preserved peak oxygen consumption, whereas those individuals who increased their wedge pressure with exercise greater than 20 had significant impairment in their peak VO2. So can we use an intra-atrial septal device then to decompress the left atrium and shunt the blood over to the right atrium? So this is the Corvia device. Consists of an internal aperture of about 8 millimeters, which seems to be the right size to facilitate shunting of blood and decreasing pressures maximally without creating too large of a defect. And the idea is that you do not need to shunt that much blood in order to drop the pressure, and that's because they're operating on a very steep portion of the pressure-volume relationship. And in the case of the Corvia study, the amount of QPQS was very small, only about 1.2 to 1.3. So the first in-human study, the Reduce LAP Heart Failure 1 randomized clinical trial. On the left-hand side is the control arm looking at baseline in 1 month, very similar pattern with increases in wedge, with legs up, and with low-level exercise. Those individuals treated with the intra-atrial septal device 1 month later had less of an increase with legs up and with exercise, certainly a promising result. This led to the definitive trial, the Reduced LAP Heart Failure 2 trial, which enrolled just about 600 patients with an ejection fraction of greater than 40% and elevated wedge pressure of over 25 with exercise, and a difference between the capillary wedge pressure and the right atrial pressure of at least 5. And unfortunately, in spite of the early favorable results, this was a completely negative trial. There was no benefit in reducing cardiovascular death or non-fatal stroke, and there was similarly no decrease in the cumulative incidence of heart failure hospitalizations in those individuals treated with the shunt device. So this led the investigators to go a little bit deeper. These are the forest plots looking at differences based upon various clinical characteristics. 3 things emerged. Men did particularly poorly. Those who had more right atrial remodeling, suggestive of more chronicity of pulmonary hypertension, also fared poorly, as did those who had latent discovery of pulmonary hypertension or exercise-induced pulmonary hypertension. And those who had a significant bump up in their PVR with exercise were found to do particularly poorly. The flip side of that is that if you had a peak exercise PVR of less than 1.7, they actually fared pretty well. So moving on to the splanchnic bed, the idea is that most of the blood, in fact about 25% of our venous blood at any point in time, is stored in the splanchnic circulation in the liver and in the spleen. This then serves as a buffer so that when one needs to exercise, you can very rapidly mobilize this by venoconstricting, shunting the blood into the central space so that more blood is available for circulation during times of stress. The challenge, of course, is that in those individuals who have a non-compliant circulation, that additional volume leads to significant increases in pressure that then lead to dyspnea. So what if we could open up this splanchnic bed? And that is the idea behind doing greater splanchnic nerve block or greater splanchnic nerve ablation. It's early data from Murat Fudim from Duke, looking at giving a nerve block where they could paralyze the greater splanchnic nerve and show that there was actually a significant reduction in pulmonary capillary wedge pressure when they did this. This then led to a more definitive procedure, which is greater splanchnic nerve ablation, where the azygous system is accessed, an ablation catheter is passed down through the azygous vein as it crosses over the thoracic vertebrae between T10 and T11. Energy is delivered there, ablating the greater splanchnic nerve. This procedure can be done in about 45 minutes to an hour and tends to be pretty well tolerated by patients. This is the first in human experience. The pivotal trial is the early feasibility study is just wrapping up and will lead to a pivotal trial that will be underway in the next 6 months. But looking at the first in human experience, again, all of the indicators are pointing the right way. Significant and sustained improvements in cardiomyopathy, Kansas City Cardiomyopathy Questionnaire, indicating an improvement in quality of life, as well as improvements in 6-minute walk distance that remain stable out over the next 12 months. Last slide that I want to leave you with, I was asked to talk about LVAD and transplant. Not enough time to do that in any meaningful way, but I did want to leave you with the 5-year data from the Momentum 3 trial. This was a randomized study of using a durable mechanical circulatory support device, the HeartMate 3, comparing it to what was then the industry standard, the HeartMate 2 device, which was an axial flow pump. With the new centrifugal flow HeartMate 3 pump, it was a better tolerated device. There were fewer hemocompatibility related adverse events such as stroke and bleeding. And now we have evidence out over 5 years that this device significantly improves survival more than its predecessor, the HeartMate 2. We're now looking at the ability to achieve 5-year survival of 60% with this current generation device, which is now beginning to approach the outcomes that we see with heart transplantation. Now, there are still some significant differences in terms of exercise capacity and quality of life compared to those patients treated with heart failure versus a durable MCS device. But I think this is very exciting for those of us who practice within the field. So just to wrap up, Knowledge of structural, functional, and interdependent features provide the therapeutic targets for new device therapies for treating heart failure. Interventional reduction of left ventricular diameter produces significant clinical benefit. Normalizing wall stress through LV wall augmentation is a promising new therapeutic target. Benefit from intraatrial shunting still remains unproven, but there are studies ongoing not just in those patients with HFpEF, but also in those with reduced ejection fraction. And then lastly, greater splanchnic nerve ablation seems to be a very promising therapy for heart failure preserved ejection fraction. And with that, I'll stop there with 9 seconds to go. Thank you very much.
Thank you. Thank you very much, Professor Penny, for your nice exposition. Any questions now? So Dr. Sanjeev Sharma wants to inaugurate something. Yeah.
Thank you so much to all the panelists and speakers. May I request Dr. Sanjeev K. Sharma, sir, to please join us as we have some inauguration and he'll be updating us for this. In the meantime, may I request the corridor and at the back if we can have some silence so that we can have more concentration and we can really enjoy this conclave. Thank you.
As it is a heart failure symposium, we have got a new machine which can detect the fluids in the lungs, and thereby it can help in diagnosing heart failure and also for the assessment of improvement in the heart failure. In the pre-discharge also we can use it just to assess whether the patient is fit enough for discharge. It also helps in follow-up with the heart failure patient. And for unveiling this machine, I would like to invite Dr. Samin Sharma sir, Dr. Sean Penne, the experts in the heart failure, and also Dr. Jitendra Makkar, our fellow course director. Yeah, just a brief break. And then I would like to request Dr. Sean Penne later on just to give a brief about this machine, how it works and how it helps in diagnosing and treatment of heart failure. Yeah, let's open, yeah.
Okay. We need your hands. Okay.
You know, Dr. Dr. Sean Penne, just brief about this, how it helps in assessing.
So this is the this is a
you can come.
Non-invasive.
Yeah.
This is a non-invasive device that uses radar technology to measure the amount of water that accumulates in the lungs of patients with heart failure. This is used clinically in a number of different clinical scenarios. Probably the one that's best studied and best understood are those individuals who have been recently hospitalized with heart failure, come back into the clinic for a follow-up visit. There we go. And one can use this device to see how congested or how free of congestion the lungs are. If the lungs are very, very wet, one can then tailor the use of diuretic therapy in order to increase the diuretics and get the lungs a little bit drier. For those individuals who come back and their lungs are actually in a good state, then you can use that then as the platform to increase guideline-directed medical therapy. This has been studied in a number of other different locations in the emergency department to determine whether or not someone's cause of dyspnea is due to heart failure or due to a non-cardiac cause. It's been used in the hospital to determine when is the appropriate time to discharge someone after they've been treated with decompensated heart failure. And it's been used in subacute nursing rehabs, subacute nursing facilities, rehab facilities, in order to longitudinally follow patients after they're stepped down in their care out of the hospital to a post-acute care facility. So lots of different uses. We found in our experience that it was a significant tool for us to decrease the risk of subsequent rehospitalization, which is the best thing for our patients.
Now, compared to CardioMEMS, how does it work it out, knowing that that's more invasive?
So CardioMEMS is a fantastic device, measures pulmonary arterial pressures that one can then follow longitudinally when patients are at home. We found that this device, which is non-invasive, can be used to follow patients in the office and in the hospital for those who don't necessarily have a CardioMEMS. So I view them as complementary. So that's exactly right. It's applied with the transmitter.
in the anterior chest, in the receiver, and the posterior chest. It samples a region of the lung, usually in the right middle lung, to see whether or not there is excess fluid buildup in that area. It takes about 45 seconds to do a reading.
Well, thank you so much. So after this second session, and of course after this launch, let's move ahead with the session number 3. I would like to request Dr. R.R. Kasliwal, Dr. Arun Kasliwal, Dr. J.S. Makkar, Dr. Pushpendra Garg, Dr. Ruchi Gupta, Dr. B.M. Goyal, and Dr. Avnish to please join us on stage for chairing this session and to take this session forward. Once again, I repeat the names. Dr. R.R. Kasliwal, Dr. Atul Kasliwal, Dr. J.S. Makkar, Dr. Pushpendra Garg, Dr. Ruchi Gupta, Dr. B.M. Goyal, Dr. Vivek Tandon, and Dr. Avnish. May I request all the doctors to please join us on stage and take the session ahead. Thank you, sir.
Good afternoon, everyone. Good afternoon, ladies and gentlemen. I hope you had a very exciting time. Yes? New things on the horizon. Update in lipid management, LDL and beyond. Dr. Robert Robinson, sir. May I invite you for a topic which is always topical. The stage is yours.
Thank you. It's really a great pleasure to return to Jaipur. I was here for the first conclave many years ago. I'm going to be talking about LDL lowering, and I'm going to use the example of familial hypercholesterolemia, a common monogenic disorder that results in very early and aggressive coronary and other vascular disease. These are my disclosures. I'll be talking about LDL cholesterol lowering, the role of PCSK9 inhibitors, and moving on to a new class of therapies known as the angiopoietin-like 3 protein inhibitors. I will then present treatment algorithms for patients with both homozygous and heterozygous familial hypercholesterolemia, and then move into mixed dyslipidemia. Familial hypercholesterolemia occurs with a frequency of 1 in 244 to 1 in 313 individuals in the world, a common monogenic disorder affecting LDL receptor activity. In individuals with ischemic heart disease, it's much more common, occurring in 1 in 31. In individuals with early onset ischemic heart disease, 1 in 15. In those individuals with LDL cholesterol levels greater than or equal to 190 milligram per deciliter occurs in 1 in 14. Most often, the underlying etiology is not identified by the clinician. They're encountered with a patient with difficult to treat LDL cholesterol that doesn't respond to high-intensity statins. It's very important to obtain the family history and to examine the patient for tendinxanthomas which affect the dorsum of the hands, or more commonly, the Achilles tendons. You can use one of the validated tools such as the Dutch Lipid Network's criteria, Simon Broom, or the American Heart Association, American College of Cardiology criteria to diagnose familial hypercholesterolemia or get a genetic test. The reason it's important to identify whether somebody has familial hypercholesterolemia versus acquired hypercholesterolemia is that those individuals with familial hypercholesterolemia had the disorder before they were born, and the cumulative exposure to the high cholesterol is greater, resulting in a 22-fold higher risk of ischemic heart disease over 10 years compared to individuals with LDL cholesterol levels less than 130 milligram per deciliter. This rare genetic disorder affecting 2 alleles, resulting in a loss of activity in patients with the homozygous disorder, is a condition that's difficult to treat because therapies that upregulate the LDL receptor, such as statins and PCSK9 inhibitors, work less well. The Odyssey HoFH trial was a double-blind, placebo-controlled, parallel group study to evaluate the effects of the PCSK9 monoclonal antibody alirocumab in patients with clinical or genetically confirmed HoFH. In this study, individuals were randomized 2-to-1 to receive alirocumab versus placebo, followed by an open label treatment period of 12 weeks, and then followed by an 8-week follow-up. At the primary endpoint of 12 weeks, we can see that there was a reduction in LDL cholesterol of about 36%. There were many different etiologies in the individuals with homozygous FH, shown here, but the response to PCSK9 inhibitor in HoFH patients is highly variable. In contrast, individuals who have compound heterozygous FH have a more consistent reduction with PCSK9 inhibitors than those with heterozygous FH, even though they were thought to have homozygous FH, have a more consistent LDL cholesterol lowering response. But in these individuals, very few are able to achieve a 30% or more reduction in LDL cholesterol. It's about 57%, a 50% reduction seen in about 27%. In individuals who have HoFH or severe manifestations of heterozygous FH, the Tausig study reported a more marked reduction in LDL cholesterol as reported in this paper led by Raul Santos. PCSK9 inhibitors are safe, side effects are mild, limited to site reaction in most individuals. Rarely there's a diffuse rash that occurs, and then we need to think about alternative approaches. I want to now move on to the new class of therapies, angiopoietin-like 3 inhibitors. This is a target that's being identified by multiple different companies. A failure of the ASO, the antisense oligonucleotide, companies looking at siRNA inhibitors, and this is also a target for gene editing. First, the genetic studies show that in individuals who have loss of function mutations in angiopoietin-like 3, that they have lower triglycerides, lower HDL cholesterol, lower LDL cholesterol, and a lower risk of coronary artery disease. So through the effects of disinhibiting endothelial lipase, resulting in this reduction in HDL cholesterol, that is not related to coronary disease. And this pathway was previously identified by Sakar Katharesan in a very pivotal study published in The Lancet about 15 years ago. You may not know so much about angiopoietin-like 3, but this protein inhibits two pathways. It inhibits lipoprotein lipase and endothelial lipase. Lipoprotein lipase is the key enzyme that results in triglyceride hydrolysis. It's located along the endothelium. So if you disinhibit lipoprotein lipase, the inhibitors will decrease triglycerides by about 60%. Endothelial lipase has been less well studied with regards to its effect on LDL metabolism. What happens in the liver is the very large VLDL particles are reduced in size. The large VLDL particles, when they're secreted by the liver, get converted to a small LDL particle that's not as well recognized by the LDL receptor. When the VLDL particle size is smaller coming out of the liver, it gets converted to a larger LDL particle, and the ApoB, the major protein on the LDL particle, has a different conformation that's more easily recognized by the LDL receptor. That may be one mechanism whereby angiopoietin-like 3 inhibition results in a reduction in LDL cholesterol, but it's more complicated than that, as I will show you in a moment. So the ELLIPSE HoFH study was a study with a fully human monoclonal antibody directed against angiopoietin-like 3. We randomized individuals 2-to-1 to receive evinacumab or placebo, followed by an open-label extension. We included individuals that were 12 years of age or older who had documented pathogenic mutations in 2 LDLR receptors, or they could have been compound heterozygotes having a defect in ApoB, LDLR, or PCSK9 overproduction in LDLR, or untreated cholesterol level greater than 500 milligram per deciliter, or both parents having total cholesterol is greater than or equal to 250 milligram per deciliter, or cutaneous or tendinxanthomas before the age of 10 years. In this study, the pivotal finding was that individuals treated with evinacumab had a 49% placebo-corrected difference in LDL cholesterol. Most importantly, in individuals who had null receptors and LDL receptor activity less than 2%, the therapy was equally effective. This tells us that disinhibiting angiopoietin-like 3 is lowering LDL cholesterol by an LDLR-independent pathway, and therefore provides a unique opportunity for the most difficult to treat patients with homozygous familial hypercholesterolemia. In addition, we report a reduction in ApoB, non-HDL cholesterol, and triglycerides in this study of 50%. In the long-term extension trial, where individuals were followed for an additional 24 weeks, open label extension, another follow-up of 24 weeks, there were sustained reductions in LDL cholesterol. Individuals with HoFH, where the guidelines never recommended they get to the goal of those who have coronary disease, even though most of them have coronary disease. And the reason they didn't recommend that is because it was impossible to get them down to these targets. But for the first time, you can see that there was great efficacy of a therapy in HoFH patients. LDL cholesterol was lowered to less than 100 milligram per deciliter in 50%, less than 70 milligram per deciliter, about 32%, and in those individuals with clinical atherosclerotic cardiovascular disease and HoFH, we can see that 37.5% achieved an LDL cholesterol less than 70 milligram per deciliter, and 31% achieved an LDL cholesterol less than 55 milligram per deciliter. So for the first time, we could really do something important for our patients with HoFH. And by lowering LDL cholesterol, fewer of these patients required LDL apheresis. And those individuals who were on LDL apheresis needed it less often. And LDL apheresis is a big burden for the patients, where they have to go in 3 to 4 hours every 2 weeks to have their blood cleansed of their LDL particles. So this was a pivotal study, resulted in a very rapid approval by the Food and Drug Administration. This therapy is available in the United States, Canada, and many other places around the world. Another trial that we're involved in is looking at a small interfering RNA directed against angiopoietin-like 3, ARO-ANG3. And this is an open label study, really proof of concept, looking at individuals with homozygous FH by the same criteria that we talked about before. The trial is still ongoing. All of the patients that we've entered in the trial are now in the open label extension trial. So we hope in the next 6 months to be able to analyze these data and present those findings. So what is our treatment algorithm with all these possibilities? Because homozygous FH is a rare disorder and the therapies that are approved have orphan indication, we have more options than we do in patients with heterozygous FH. We start with a high-intensity statin, but realize that statins don't work in all HoFH patients, that in individuals who have null receptors or LDLR activity less than 2%, there's only an 8% reduction in LDL cholesterol. Is it worth continuing the high-intensity statin? You need to evaluate and reevaluate. Then you would add ezetimibe, then you would add a PCSK9 inhibitor, and recognize not everybody with HoFH is going to respond to a PCSK9 inhibitor. If they have no residual LDLR activity, that protecting that LDL receptor from destruction by PCSK9 isn't going to do anything. Then you have options. You could either use evinacumab, lomidopide, LDL apheresis, or sometimes you need to use all three. Now, what about those patients with heterozygous familial hypercholesterolemia? Very common, and there's probably many in your practice that you may not even recognize. They're very difficult to treat as well. And in this real-world study by Realitas from the Netherlands, they showed that 45% of individuals with cardiovascular disease and HeFH were able to achieve their target. So most individuals were not. So let's talk about individuals with this refractory hypercholesterolemia. We had the opportunity to use evinacumab at 2 different doses, 5 milligram per kilogram IV every 4 weeks, 15 milligram per kilogram IV every 4 weeks. And in this study, you can see that the LDL cholesterol levels were high at about 130 milligram per deciliter, and that was on the background of statin therapy in as many as 77 to 87%, ezetimibe used in a third to 43%, and everybody was on a PCSK9 inhibitor, or should have been. There was one site that enrolled somebody without a PCSK9 inhibitor. So this is on the background often of triple therapy. And in this study, the IV arms resulted in a 51% reduction in LDL cholesterol compared to placebo. And we also evaluated a subcutaneous arm every week where there was up to a 56% reduction in LDL cholesterol. So in those very difficult to treat patients, we're again able to achieve things that were unattainable before. There were also reductions in ApoB, non-HDL cholesterol, triglycerides, and a non-dose dependent reduction in lipoprotein A. So how do we operationalize this for our patients? We start with a high-intensity statin, often use ezetimibe in combination, add a PCSK9 inhibitor, and then we might be able to consider an angiopoietin-like 3 inhibitor in the future when these therapies get approved for individuals with heterozygous FH. But LDL apheresis is always an option for those individuals that have severely elevated LDL cholesterol levels. We then had the opportunity to evaluate individuals with less severe forms of hypercholesterolemia, the non-FH patients, those with mixed hyperlipidemia. And this was a study that I presented at the American Heart Association in November of 2022. It was a 3-arm, parallel arm study of 3 different doses of ARO-ANG3. And this therapy is given subcutaneously every 3 months. So 50 milligram, 100 milligram, and 200 milligram versus matching placebo in each arm. In this study, the average LDL cholesterol was about 102 to 113. The ApoB was elevated at 95 to about 107 milligram per deciliter, and the triglycerides were also elevated at about 200 milligram per deciliter. The therapy, so very favorable changes. And in this study, we looked at hepatic fat, because prior to this study, the antisense oligonucleotide, vupanorsen, was evaluated by the TIMI group, TIMI 70 Translate study. And in that study, there was only a modest reduction in LDL cholesterol of 8%, but a dose-dependent increase in transaminases, more than 3 times the upper limit to normal, and also an increase in hepatic fat. So it's important to evaluate hepatic fat, the hepatic fat fraction in these studies. And in contrast to the antisense oligonucleotide, the siRNA inhibitor resulted in a dose-dependent reduction in hepatic fat, and we were quite pleased with those results. So as I mentioned, compared to the ASO, where there was an increase in hepatic fat, dose-dependent up to 76%, we reported a dose-dependent decrease in hepatic fat of 30%. The monoclonal antibody showed no difference in hepatic fat. So even though these agents are inhibiting the same protein by different approaches, they have different efficacy and different safety profiles. So we're waiting for this study to finish. This was an interim analysis, and then we're in the process of designing a phase 3 clinical outcome study. So these new therapeutic targets are providing opportunities for our patients and allowing us to achieve LDL cholesterol levels that were unachievable in the highest risk individuals. And I think this is really a great opportunity. And moving forward is gene editing, which is being developed not only for PCSK9, but also angiopoietin-like 3. And so there may be an opportunity for a one-and-done approach for our patients with these genetic disorders. And I think that is tremendously exciting for those patients. Thank you very much.
Thank you very much. This was a master disposition on LDL and beyond.
If you can join us on the dais itself, and also request Dr. Jiten Makkar sir to please join us.
I want to ask one question. Do you have any role of bempedoic acid? Though it works in familial heterozygous situation. Okay. Because we have in India now, we have got bempedoic acid.
Yeah. So bempedoic acid is a acetylcitrate lyase inhibitor, and the therapy is most effective in individuals that can't tolerate a statin or take low-dose statin because it's inhibiting cholesterol synthesis at the step before HMG-CoA reductase. And statins are so effective in inhibiting HMG-CoA reductase that it adds very little to those patients who are on a statin at high intensity. but the agent does work in heterozygous FH patients, and it is indicated, by the FDA for treatment in heterozygous FH.
What you're saying is it is a limited role at this point of time.
And in about 3 weeks from now, we're going to find out the results of the CLEAR outcome study, which is the first phase 3 outcome study with bempedoic acid. This is a population of individuals with statin intolerance. And so again, it brings up the point that if you're not on a high dose statin, or if you're on no statin, that you get about a 25% reduction in LDL cholesterol in combination with ezetimibe, up to 45%. So, we're encouraged by the release of the preliminary results that it was favorable in reducing cardiovascular events, and then we'll see the details in about 3 weeks from now.
So before I ask my co-chairman to speak, a comment from you, sir.
So, a question. Actually, I am Dr. Khatri, and because the speaker is from USA, and this question directly is not related with the LDL, but I want to ask a question because recently there has been a controversy that this cholesterol has been removed from the list of nutrient of concern. So, can you throw light on this, that the cholesterol myth, what we say today, is a truth or a myth?
No, so there's new concept that's really been developed by Valentin Fuster, which is a cumulative burden of hypercholesterolemia over one's lifetime. And the longer the LDL cholesterol is elevated, the greater the risk of cardiovascular disease. So I don't think there's any dispute about for LDL and LDL. There certainly are other factors that have no other major cardiovascular risk factors, no family history of heart disease, your risk is going to be lower. It's, we have to think about LDL cholesterol in the context of other risk factors. And, sometimes, we do non-invasive assessment, starting with the exam, of course, but may do coronary calcium to see if an individual does have subclinical disease, and then we want to treat them aggressively. Our treatment algorithms are really designed based on the risk of the individuals. The very high-risk individuals who have had an event, an MI stroke or intermittent claudication with abnormal ABI. LDL cholesterol goal is less than 55 milligram per deciliter. Individuals with coronary disease, but not an event, less than 70 milligram per deciliter. And for other individuals, maybe less than 100 milligram per deciliter, but over the long term, we probably want to be a little bit more aggressive with our treatment. And even though I was focusing on therapy, we all can do a great job if we counsel our patients on diet and focus on reducing saturated fat, total calories. Dietary cholesterol is less important in terms of raising blood cholesterol, but focus on decreasing saturated fat, I think, is something that we should emphasize. And I think that diet's important, and we need to counsel our patients on diet each and every time we see them as outpatients or in the hospital.
Can I ask a practical question?
Last one and then we'll move on.
Now, in India, we're seeing a lot of patients who are getting heart attacks at less than 40 years of age. More and more young individuals. Maybe because we are a young nation, so numerically we will have more young patients with heart attacks. When the patient comes for a primary angioplasty or with acute MI, I have yet to come across a very large burden of high LDL levels. In the sense, FH is not that prevalent in the clinical settings as we know it is in the population. Now, what I want to know is that what is your approach to picking up FH in acute coronary syndrome patients?
So the measurement following a myocardial infarction is challenging. If you obtain the lipid panel within about 48 to maybe 72 hours after the event, the results are fairly stable. But there's an acute phase response where after an MI, the LDL cholesterol can fall by about 50%. The HDL cholesterol can fall a third. Lipoprotein A goes up about 227%. Triglycerides go up about 60%. So if you wait for the patient to have a lipid panel on the day of discharge, assuming they had an MI and they're there for 4 or 5 days, the results may be spurious. And so that's an important concept to keep in mind. There are many individuals with early onset coronary disease. The most common prevalent lipoprotein abnormality is high lipoprotein A, which I'll be talking about in the next lecture. That goes up dramatically following an ACS, and LPA is triggering inflammation and thrombosis, which I'll also review in the next talk.
So thank you. So I think we move on. We have Dr. Atul Kasliwal, and he'll speak on the role of aspirin in primary and secondary prevention, the current status.
Well, good evening, everybody. Well, today my topic is role of aspirin in primary and secondary prevention. What's the current status? Well, we all been using this aspirin, and we call it a wonder drug. And its fascinating story dates back, almost more than 3,000 years, when willow bark was used as a painkiller and antipyretic by Hippocrates. And its use as an antiplatelet drug started in the late 1960s. Well, we all know how the aspirin works, the mode of action. Well, it decreases the production of the thromboxane A2 in the platelets by inhibiting the PGH synthase enzyme. Well, there are established benefits of aspirin when we considered coronary thrombosis, venous thromboembolism, and even we have got some positive benefits regarding colorectal cancer and the cognitive impairment. These has been substantiated by the observation studies and meta-analysis. Now coming to the how to prevent the cardiovascular events in a patient. Well, we have a term primary prevention. We all know that primary prevention is basically preventing cardiovascular events before they occur in the asymptomatic subjects with cardiovascular risk factors. Patients have already got cardiovascular risk factors. We want to prevent the cardiovascular events. So what is the guidelines? And we have been using the aspirin for this primary prevention for quite long period. But we know the benefits, but we also know the safety point of the aspirin, in that it can cause bleeding instances. And therefore, so what's the present role of aspirin in the primary prevention? Do the benefits outweigh the harm, or is there a benefit while using the aspirin? Well, there have been a number of trials for last 30 years. Some trials have shown that there's an efficacy if you use this aspirin. There are a lot of trials where the efficacy is not proven. In some trials, there's some bleeding risk. Sometimes in other trials, there's no bleeding risk. But in the last 2018, we've got 3 trials: ASPRI trial, ARRIVE trial, and the ASCENT trial, which have changed the scenario for this primary prevention with aspirin. Well, first, let us discuss something little bit of meta-analysis. We have got different trials, 11 low-dose aspirin trials. In this, when we talk about low-dose aspirin, it means we are using around 81 to 150 milligram of aspirin, and there have been trials, like 11 trials have been done on this low-dose aspirin. And what the meta-analysis of these say, that if you use this drug as a primary prevention, there's a 10% decrease in the major cardiovascular events. There's an 11% decrease in the myocardial infarction, 18% decrease in ischemic stroke. And what about the safety? We know it can cause bleedings, and it has shown that there is an increase of around 58% major GI bleeds, increase of 31% with intracranial bleeds. So you can see there's a modest benefit is seen, but it is really offset by the increase in the incidence of the hemorrhages. Now, the trials which were there in 2018, which have changed the scenario, was ARRIVE trial, ASCEND trial, and SP trial. Basically, you can see in all these trials, they were done for a period of 5 to 7.5 years. Sample size is almost 12 to 20,000. The drug used in the 100 milligram doses. Now, the ARRIVE trial, basically, it included the patients of moderate cardiovascular risk. It included the patients, men with more than 55 years age, with 2 to 4 risk factors. Well, the second trial, ASCEND trial, basically was done on diabetic patients which were more than 40 years, and ESPRIT trial was done on the elderly patients who were more than 65 years of age. Now, what all these trials show, that if you talk about the benefits, you can see in the ARRIVE and ESPRIT trial, hardly there is any benefit of reducing the primary cardiac endpoint. In the ASCEND trial, there was a marginally 12% decrease in the vascular events. When we talk about the harm, the negative point of the aspirin, you can see in all the trials, in ARRIVE trial, almost 2.1 times there is increase in GI bleeding. In the ASCEND trial, which was done on diabetic patients, almost 29% increase in the major bleeding. ESPRIT done on the elderly patients, again 38% increase in the major hemorrhage. So clearly, all these trials, these three trials have clearly shown that there's a modest benefit if you use this drug to reduce the cardiovascular events, but simultaneously these drugs also increase the bleeding risk. And in ESPRIT trial, there was increase in mortality was also there. Now we have got a different guidelines for the primary prevention. Well, the European Society of Cardiology, because we know that aspirin cause bleeding and can cause major bleedings, therefore antiplatelet therapy is not recommended in low or moderate severe risk. It's a class 3 indication. One should not use in any patients with low to moderate risk. But aspirin may be considered in diabetic patients with a very high cardiovascular risk and no clear contraindications. There's a class 2B indication. When we talk about ACC AHA recommendations for low-dose aspirin, it says that aspirin may be considered with adults 40 to 70 years of age who are at higher ASCVD risk but not at increased bleeding risk. That means you should not administer this drug on a routine basis to the adults who are more than 70 years of age, and you should not be administering this drug whom you feel there's an increased bleeding risk. Now recently there is a guidelines from US Preventive Services Task Force. The previous guideline was in 2016, but latest, just last year, 2022, the USPSCF trial guidelines have come into the picture, and that has changed the scenario for using this drug for the primary prevention. Well, this guideline says that one should take an individualized decision to initiate aspirin in adults between 40 to 59 years of age who have 10 or more than 10% 10-year cardiovascular risk. That 10-year cardiovascular risk, these are risk calculators, ASCVD risk calculators are available online. You can use this ASCVD risk calculator plus that is available online, and you can calculate a person's CVD risk. If the cardiovascular risk is more than 10% and the patient age is between 40 to 59, then one can use aspirin, and clearly in that patients, there should not be increased bleeding risk. And they also say that before starting the drug, one should have you should talk to the patient regarding the risk and benefit of this drug. And they clearly, this guideline clearly recommends against the initiating the aspirin in adults if the age is more than 60 years. So whenever you are using aspirin, you should ask 3-4 questions to yourself, or you can ask to a patient. Is the patient 40 to 70 years old? If all these, the answer is yes, one should use the aspirin. Is the patient 40 to 70 years old? Yes. Does the patient have a high burden of severe risk factors or ASCVD risk enhancers based on the clinical judgments? If you feel like it, it's yes, you can go for aspirin. Another question, is the bleeding risk low? Okay, if the bleeding risk is low, you can go for it. Another, you should talk to the patient about the risk and benefit issue. If it is yes, you can go. Another, does the patient favor ASCVD risk reduction, prevention over bleeding avoidance? If it is again yes, so if your answer is yes, you can go for aspirin primary prevention. But if your answer is no, out for all these 5 questions, if anybody is no, then one should not use aspirin for a primary prevention. Well, we can consider a case study. A hypothetical case study. A 55-year-old man presents as a routine visit in your clinic. He is asymptomatic, no history of any cardiovascular disease. Well, if you ask for the ASCVD risk factors, he was a former smoker. He has a history of hypertension and hypercholesterolemia, but he doesn't have any diabetes. There's a family history of cardiovascular disease. He's on medications, amlodipine. Well, blood pressure is around 136/62. BMI is 26. Well, lab investigations, HbA1c 5.9, no diabetes. Total cholesterol 231, triglycerides 150, SDL 50, LPA 135. And imaging, we did coronary calcium scoring 200. Well, we have got this data for this patient. Now, you go for this risk calculation by ASCVD risk estimator plus, which is available online. Just feed all these data, your age, total cholesterol, SDL cholesterol, LDL cholesterol, systolic blood pressure, diastolic blood pressure, diabetes, yes or no, smoker, treatment for hypertension. So all these parameters are there in this ASCVD risk calculator. And if you go for this patient, it will calculate the estimate risk is around 22.2%. So the guidelines say if it is more than 10, here it is 22%. So for this patient, you can start aspirin therapy 75 milligrams. So this is the way one should proceed for initiating the aspirin therapy. Now there are other future perspectives if you use the primary prevention for this aspirin. Well, we can use coronary artery calcium and polygenic scores, to increase your accuracy and acuity of the current CVD risk scores. Number 2, the strategy is to mitigate the bleeding risk. Well, to decrease the bleeding risk, one should use low-dose aspirin. You can use concomitant, PPIs like pentoside, esomeprazole. Then one should try to eradicate H. pylori infection if the patient has got. And there's a studies also shown in statins. If you use statins, there's a decreased risk of peptic ulcer disease and increased H. pylori clearance. Now with the time, the scenario is also changing. One should try to use a tailored antiplatelet therapy. Now what is this? Well, we have got trials which have shown that if you use aspirin twice a day instead of once daily, it will work well in those patients who have got increased platelet turnover. So there is a trial which is called Andaman trial. So in this trial, it was shown that patients who have got increased platelet turnover use aspirin twice daily in spite of once daily. Then it has also been shown that the aspirin efficacy varies with the body weight of a patient. If the body weight is more than 70, then probably the low dose aspirin doesn't work. And if the patient weight is 70, you should increase the dose to 325 milligram. So coming to the secondary prevention, we know that what is secondary prevention? It's preventing cardiovascular events before they occur in subjects with established but asymptomatic atherosclerosis, or tertiary prevention, when there's you are preventing additional CVD events after the first event has occurred. Well, we have got guidelines for this secondary and tertiary prevention. We know that while using guidelines on DAP, dual antiplatelet therapy, in patients treated with DAPT, a daily aspirin dose of 80 milligram is recommended. If the guidelines on myocardial resuscitation say that you should use aspirin before elective stenting, lifelong single platelet aspirin should be there, and it should be used whether the patient has got STEMI or non-STEMI. And if you talk about guidelines for chronic coronary syndromes, well, obviously, if the patient has got a history of previous MI revascularization, go for aspirin therapy. Patient is recommended for after stenting, you should go for stenting. Now, with the secondary prevention, there is again a question has arises. Well, lifelong aspirin for all in the secondary prevention of chronic coronary syndrome is still there, is still sacrosanct, or is reappraisal is warranted? One should consider the role of aspirin in secondary prevention also. Well, it has been seen when you talk about this question of lifelong aspirin for secondary prevention, it's just like a house, you can see, that is still standing, but that is built on an unstable foundation of outdated trials and now threatened by a number of contemporary wrecking balls. You can see, well, nowadays we have got alternative strategies. When we treat the patients after stenting, now the recent trials of early aspirin discontinuation from the post-PCI dual antiplatelet therapy has come into the picture. I think our next speaker will going to speak about all these things. And when we talk about the secondary prevention, even the bleeding risk is increasingly being recognized, particularly among the elderly. And with the use of, we have got new therapies, beta blockers, statins coming into the picture to control the risk factors. Probably this has changed the scenario, and they have, they have decreased the efficacy of aspirin in controlling the ischemia. Well, we have got a lot of historical trials on aspirin after MI, but if you look for these trials, the patients, they were of young age, they were done in male patients. You can see in the old historical trials, the aspirin was used in 300 milligrams to 1500 milligrams. And the follow-up was hardly 3 to 4 years. And hardly these trials used beta blockers and statins. You can see the two trials, Paris and Ames, they used beta blockers just hardly 15 to 20%. So you can see the historical trials of aspirin, their work, they are really applicable in this today's scenario. One has to see. And we've got a number of, we know that aspirin is the cornerstone while we're dealing in different presentations of cardiovascular disease. But nowadays, aspirin-free strategies have come in picture. We have got early continuation of the aspirin component of dual antiplatelet therapy of PCI and fibrillation and chronic stable angina. One can withhold the aspirin. We have got a number of trials in which, early P2Y2 inhibitor monotherapy, you can use this therapy instead of dual antiplatelet therapy. We have got trials of like Stop DAP2 and Smart Choice with clopidogrel. In this, clopidogrel monotherapy is followed after the initial 1 to 3 months of DAPT. Similar to the triclopyr, we have got trials like Twilight and Global Leaders, in which one can stop, dual antiplatelet with aspirin, and you can continue the triclopyr for another 12 to 24 months. Similarly, recently, just a few days back, Optica trial from Netherlands has published, and in this trial, they have not used aspirin, even from the initial. They have used, they have evaluated the feasibility and safety of ticagrelor and prasugrel monotherapy directly following PCI. So they didn't use any aspirin in this, and this provides the first in human evidence that this ticagrelor or prasugrel monotherapy can be directly used without any aspirin from the very start. Atul, Dr. Atul. Okay, so my last summary, last slide. If you talk about the primary prevention, the aspirin may be considered for primary prevention in carefully selected patients based on risk-benefit consideration. And for secondary prevention, aspirin-free approaches are emerging after PCI. Thank you.
Thank you. So, because we are running late, and so I will ask the next speaker, Dr. Deepak Bhatt. And Atul has laid the foundation for his talk. So let's hear what Dr. Deepak Bhatt has to say. Welcome, Dr. Bhatt.
Thank you so much, sir. And before Deepak sir will join us, may I have your kind attention, please, especially our pharma colleagues at the back. Well, it would be nice if in case we can keep a bit silence there at the back, because this conference and conclave is going on, and it's an opportunity for us to have a lot of learning and knowledge sharing. So once again, I repeat, if in case we can keep the silence and maintain the decorum, especially at the back, our pharma colleagues, and the place where we have tea and coffee arrangements. Also at the corridor at the back. Thank you so much. Dr. Deepak, all yours. Thank you.
Great, thank you very much. It's wonderful to be here with all of you. I sense a lot of excitement, especially in the back of the room. They are very excitable back there, I agree. Really like to thank Dr. Sharma for inviting me to come and speak here at this heart center that he founded. I was lucky to have a tour of Eternal Heart Care Center earlier this morning, along with my colleagues from Mount Sinai. Really a wonderful hospital, just brilliant what you all have collectively accomplished under Dr. Sharma's leadership. So my congratulations to all of you. So I was asked to speak about antiplatelet therapy post-PCI, and I'm going to do so over the next few minutes. We're running behind on time, so I'm going to go through this quickly, but we will, I think, be speaking again at 7 o'clock if there are questions that come up on this or any topic. A lot of great questions already that I've heard today. These are my disclosures, and bolded are the ones that are relevant to this talk, including research funding from a number of companies that make antiplatelet agents or other antithrombotics or antidotes. So I think everyone in this audience understands the importance of platelet activation and aggregation in thrombosis, in particular in the setting of acute coronary syndromes and in the setting of stenting. A challenge, though, is when we deploy antiplatelet or any antithrombotic strategy, it's a bit like, as they say in Roman mythology or Greek mythology, navigating between Scylla and Charybdis, being between a rock and a hard place. For sure, more potent antiplatelet therapy delivered for longer durations of time reduces important ischemic events. There's no question that's true if you study enough patients, in particular high-risk patients, and follow them long enough. But it is also true that that will increase bleeding. Of course, any antithrombotic versus placebo can only increase bleeding. It can't decrease bleeding. So certainly more potent agents, longer durations of therapy will increase bleeding. The real question is, when is that trade-off worth it? And sometimes that's a bit more art than science. This was a brilliant talk we heard about aspirin for primary prevention. I won't say anything else other than show this graphic from a Lancet article where we describe the rise and fall of aspirin in primary prevention. There used to be a time, at least in the US, where essentially every middle-aged physician was taking aspirin for primary prevention. Now it's become much less frequent, and I think there is still a role, as the previous speaker mentioned, but much more limited, much more targeted than what we used to think. All right, well, what about going beyond aspirin, dual antiplatelet therapy, such as in the patient who has received a stent? Well, I think why they got the stent really matters. And if a patient has an acute coronary syndrome, that really increases the likelihood that they're going to benefit from long-term dual antiplatelet therapy. Not so much because of the stent, but more so because of the underlying atherothrombotic burden. And that's why the coronary anatomy really matters. Does a patient have long, diffuse areas of disease? Do they have disease involving bifurcations? Do they have metal involving bifurcations, overlapping areas of stent implantation? All these different things do raise the risk of future ischemic events. Again, I don't mean necessarily stent-related, in some part stent-related, but also just from the underlying disease. So lots of different factors go into whether one should use longer-term or shorter-term DAPT. I don't think anyone's ever going to come up with a very simple algorithm where you can just say, do this in every patient. I think physician judgment will matter a lot. And in that decision, the interventional cardiologist judgment matters a lot because they're probably best suited to decide on the complexity of the procedure they just did and the anatomy that they just treated. There are lots of meta-analyses out there. This is one that I happen to be involved in where we looked at all the different dual antiplatelet therapy after PCI trials and focused on the more contemporary ones using drug-eluting stents. The bottom line is the data still say consistently what they've said in the past, that longer-term dual antiplatelet therapy versus shorter-term dual antiplatelet therapy reduces the risk of myocardial infarction. That benefit is greatest in those patients who presented with ACS as the indication for their stenting procedure. Now, these data, in fact, are the longest-term data from a randomized clinical trial showing the benefit of dual antiplatelet therapy. And I don't know that I actually have a great way. This pointer, hopefully it projects on the screen there. What this shows is a hazard ratio, and it shows a hazard ratio under 1. It may not project so well with the screen, but a hazard ratio under 1 that's statistically significant. The dotted lines are 95% confidence intervals, out to about 6 or 7 years. So a significant benefit of DAPT versus aspirin alone about 6 to 7 years after the time of an initial PCI. So while there is a lot of interest and momentum in shortening the duration of DAPT, the data actually still do show benefit years after that initial PCI. Now, this patient population studied here is from Themis PCI. These are all patients with diabetes and stable coronary artery disease who'd undergone a stent procedure. So you can imagine in a stented patient, the benefit would be even larger. In a non-diabetic elective case, well, the benefit would be less. Now, for people that don't like that sort of loose way of interpreting, exactly who might benefit and want more precision, well, there are risk scores that are out there that can help with that. But sometimes the simplest risk score is just looking at the angiogram, as was done in this analysis with Antonio Colombo, where we pulled a number of the different trials, randomized trials of stented patients. And really what was seen is the patients who were most likely to benefit from longer-term DAPT were ones that had greater lesion complexity. So ones that had multiple different angiographic risk factors, things like bifurcation lesion stenting, long CTOs, multiple overlapping areas of stent coverage. These are the sort of patients where they had multiple sorts of factors like that that benefited from longer-term DAPT. And again, it may not be the stent per se. I mean, of course, stent thrombosis risk goes up in the situations I mentioned, but with modern generation stents, implantation techniques, concomitant imaging, that rate has gone down even in complex subsets, but it's probably representative of that underlying atherothrombotic burden, because if somebody's getting a bifurcation stent, well, that probably means they've got bad LAD diagonal disease, for example, and it's really that puts them at higher risk of future spontaneous myocardial infarction, where DAPT reduces that risk, as well as stent thrombosis risk. And for people that don't like just looking at the angiogram, as in that study, and just saying, yeah, this patient's high risk, that one's lower risk, there are formal risk scores. There are a number of them out there, the DAPT score, the PARA score. This is the precise DAPT score. I like it because of its simplicity. Just 5 different items, and if you're interested, this calculator is available online for free. But the 5 different things that are in the score are age, creatinine clearance, hemoglobin, white blood cell count, and previous spontaneous bleeds. Now, age, of course, and creatinine clearance are a little tricky because they raise the bleeding risk, but they also raise the risk of ischemic events. Hemoglobin, on the other side, that's easy, because if someone has a low hemoglobin, well, they're at higher risk for future bleeding, and they're less likely to tolerate a future bleed well. So low hemoglobin and low platelets, for that matter, are definite risk factors that argue against long-term DAP. White blood cell count is just a marker of patient acuity, so a higher white blood cell count, probably that was a patient with a big ACS, they're more likely to benefit from dual antiplatelet therapy. Previous spontaneous bleeds, that's an important one. If somebody's bled in the past already, say on aspirin alone or on nothing, well, that's probably not the sort of patient you want on long-term dual antiplatelet therapy, even if that prior cause of bleeding was treated and deemed to be reversible, such as a gastrointestinal bleed where H. pylori was eradicated or they were started on a proton pump inhibitor. And building upon the concept of risk scores, this is another way of looking at risk scores, the precise DAPT, but now looking at patients based on which quadrant they are. As if a patient is at high ischemic risk and low bleeding risk, well, then that's pretty easy. Do whatever you want. Use long-term dual antiplatelet therapy. If they're at high bleeding risk and low ischemic risk, well, obviously there, don't use long-term dual antiplatelet therapy. The challenge comes when there is concordance of that risk. That is high ischemic risk and high bleeding risk, such as the older patient with chronic kidney disease. What do you do with that one? And without taking the time to go through every detail of this analysis, is that the bottom line was that more than ischemic risk, bleeding risk should inform decision-making on dual antiplatelet therapy duration when concordant. So in that high ischemic risk, high bleeding risk patient, bleeding risk trumps ischemic risk. That is, that isn't the sort of patient that you want to use long-term potent dual antiplatelet therapy. Eventually that bleeding risk is going to dominate that ischemic risk. So there you want to be really careful. So if patients are at high bleeding risk, everything I'm saying about longer-term DAP, don't do it. All right, well, as I mentioned, there's been a lot of study of shorter durations of DAP. Much of it's come out of East Asia. Sometimes one can argue whether those data can directly be extrapolated to Indian populations or Western populations. But putting that point aside, the studies have been well done, even if relatively underpowered. But this was STOP-DAPT 2 ACS, looking at 1 or 12 months of DAPT. And the bottom line is that the p-value for non-inferiority was 0.06, meaning that it did not show non-inferiority, or you could say it was a negative trial. It didn't show that 1 month was as good as 12 months. But just breaking down the data, the bottom line is, yeah, there was less bleeding with the shorter term of DAPT. Of course that's going to happen. But there was an increase that was significant in the rate of myocardial infarction. So that's the downside for abbreviating DAPT. You do increase the risk of myocardial infarction. And there's a difference, as these STOP-DAPT investigators showed, between the ACS patient and the non-ACS patient, where it looks like in the ACS patient, you are sacrificing something by shortening DAPT duration, though of course in ACS or non-ACS settings, 1 month of DAPT, of course there'll be less bleeding than 12 months of DAPT. So that's not really the question. Here's another study, also from East Asia, now looking at a different strategy. The previous speaker alluded to this. These are patients who received a stent for a variety of reasons and then got DAPT for 6 to 18 months, per their physician's discretion, and then were randomized to aspirin alone or clopidogrel alone. And what we see here is a big win for clopidogrel monotherapy versus aspirin monotherapy, a significant benefit there in the primary outcome that is a net adverse clinical event outcome. And it's interesting because if we go back in time, well, this is something that was actually already known. These are data from the Capri trial showing a significant reduction in ischemic events with clopidogrel monotherapy versus aspirin monotherapy. These weren't stented patients. Host exam gives us contemporary data in a stented patient, but the concept that an ADP receptor antagonist is better than aspirin for high ischemic risk patients actually is something we've known for a while. And that benefit is magnified in higher risk patients, such as those with diabetes or diabetes treated with insulin here, where we see even greater benefits for clopidogrel monotherapy versus aspirin monotherapy in the Capri trial. And while there weren't stented patients in the Capri trial, we did have patients that had undergone cardiac surgery in Capri, and as we published a while back in Circulation, look at the benefits of clopidogrel alone versus aspirin alone in patients with prior cardiac surgery. A large risk reduction, sort of what the East Asians saw in host exam in stented patients for clopidogrel versus aspirin. There it was after an initial period of dual antiplatelet therapy. And if you meta-analyze the data, you can see really a consistent signal where P2Y12 inhibitors, now this includes a few studies with ticagrelor as well, beat aspirin with respect to reductions in major adverse cardiovascular events. No difference in all-cause mortality. It's really myocardial infarction and ischemic stroke that's being reduced. And that was a trial-level meta-analysis I just showed you. Here's a patient-level meta-analysis, the so-called Panther meta-analysis, basically showing a CV death, MI, or stroke, a significant benefit of P2Y12 inhibition versus aspirin alone. I'm just going to mention here, I was just talking about P2Y12 inhibitors as a class, but there is one thing that's happening. We'll see if it comes to clinical fruition or not, and that's the development of a ticagrelor antidote, a human intravenous monoclonal antibody called bentracimab. And that is something that has been developed experimentally. There are phase 1 data that have been published. These are some data from New England Journal of Medicine showing how bentracimab is able to essentially very quickly and completely reverse the antiplatelet effects of ticagrelor. So everything that I've said about dual antiplatelet therapy, everything that I've said about P2Y12 receptor antagonist monotherapy could get better with ticagrelor if there's a reversal agent for it, because if somebody comes in with really bad bleeding or needs emergency surgery, perhaps this is a way to decrease their bleeding risk a bit. The final comment I'm going to make in the few minutes I have is that other than dual antiplatelet therapy, there's also dual pathway inhibition one has to consider. And this is the concept of combining an antiplatelet with a reduced dose anticoagulant. And really the only one to discuss is reduced dose rivaroxaban, because that's what was studied in the COMPASS trial, where patients with stable coronary artery disease or stable peripheral artery disease were randomized to either aspirin monotherapy or reduced dose rivaroxaban, 2.5 BID plus aspirin. There was also another arm that I won't discuss, as that was more difficult to interpret, but the bottom line was that the combination of dual pathway inhibition beat aspirin alone, a significant reduction in ischemic events in patients with stable CAD or PAD. Now, patients with stents, recent ACS were excluded from the trial, so these aren't the sort of patients that I was just discussing in terms of patients initially on DAPT, but on the other hand, there are a lot of patients with stable CAD or PAD out there. And when we look at patients either without diabetes, but especially those with diabetes, we see large reductions in CV death, MI, or stroke with a strategy of dual pathway inhibition. And when we look at all-cause mortality as well, we see a significant benefit in patients randomized to dual pathway inhibition versus aspirin alone. And as we had shown in Themis PCI with ticagrelor plus aspirin dual antiplatelet therapy, in fact, the same thing was seen here in COMPASS PCI with dual pathway inhibition versus aspirin alone. That is a significant reduction in ischemic events and even all-cause mortality out to 10 years from the time of a patient's index PCI, with the caveat once more that patients with an acute coronary syndrome or an acute PCI weren't enrolled in the trial. Here we're going back to those with a history of PCI. But still, more data supporting the concept that in high ischemic risk patients, such as those who need PCI, that a pathway, a strategy of using more than just aspirin alone reduces ischemic events. And the benefits are even larger the greater the number of ischemic risk factors. So to conclude, a few points that I want to leave you with here. Aspirin in primary prevention, I agree with the previous speaker. Really, I think it shouldn't be used without consulting a doctor. It can be used in low bleeding risk patients that have diabetes and selectively in very high ischemic risk. So this is a patient who continues to smoke despite you're telling them not to, and who has a premature family history of MI. In ACS plus PCI, at least 12 months of DAPT if no bleeding remain, the guideline indicated standard of care, especially if they're post-MI, have diabetes or have undergone complex stenting or have underlying complex disease. There I'd consider even longer than 12 months. If they've got PCI, and I know this will be discussed in the next section, and also AFib, there I personally use aspirin in-house. but then discharge them on a NOAC plus clopidogrel. If they're very high risk due to ACS or complex stenting, maybe ticagrelor instead of the clopidogrel. And after 1 year, in general, I drop the antiplatelet and continue the NOAC. If they have PCI for stable CAD, at least 6 months of DAPT is what I recommend if there's no bleeding. And again, longer based on studies such as Themis PCI if they're high ischemic risk, such as those with diabetes. If they have high bleeding risk post-PCI, there I do abbreviate DAPT to 3 months. At that point, I think ticagrelor is preferred because of data such as from Twilight, but clopidogrel monotherapy is also an option. Most of those data, again, come from East Asia. And if one is de-escalating from DAPT, in general, I think ticagrelor or clopidogrel are better options than aspirin based on the data, some of which I reviewed here. And finally, in patients not on DAPT, but at high ischemic and low bleeding risk, one should at least consider the COMPASS regimen of low-dose rivaroxaban plus aspirin, especially in patients with peripheral artery disease or polyvascular disease. Thank you very much for your attention.
Thanks. Thanks, Dr. Bhatt. Excellent talk.
Yes.
You covered almost every aspect of antiplatelet therapy. There are 2-3 questions. Number one, in your practice, is there any place for aspirin as a primary prevention, or we can eliminate it altogether and replace it with clopidogrel? Second is...
Did you say aspirin for primary prevention?
Yeah.
Yeah, so I think, as the previous speaker said, I agree 100% with everything he said. I think use should be very, very selective. So the ASCEND trial that Oxford did was a positive trial. It showed a significant benefit in patients with diabetes without known atherosclerosis. But the benefit was small in magnitude, and there was a bleeding risk, mostly gastrointestinal bleeding. So I think in patients with diabetes that don't have evident atherosclerosis that are very high risk, one can still use aspirin, but you have to talk to the patient, let them know they'll probably have a lower risk of myocardial infarction, but they will have a higher risk of bleeding. Likewise, I think even without diabetes, someone that is an active smoker, say a 40-year-old actively smoking, you're telling them don't smoke, they're still doing it, that sort of patient, I think, would be reasonable to consider using aspirin, especially if they have other risk factors such as hypertension, hyperlipidemia. Of course, I would try to treat those risk factors, but I think those sorts of patients with a premature family history of MI, a parent that died in their 40s or 50s from an MI, those sorts of patients where their overall risk calculator says greater than 20%, I think it's reasonable to consider. But the role does seem to be shrinking. What I think will change all of this, though, the previous speaker mentioned coronary artery calcium. I think 10 years from now in high-risk people, we're going to be getting coronary angiograms non-invasively and quantifying the amount of plaque, the type of plaque, how inflamed the plaque is, and I think primary prevention will morph into secondary prevention in patients that have imaging evidence of atherosclerosis, but a few trials to do before that happens.
So can't we replace it with the clopidogrel as such?
Hello.
Because the clopidogrel is more efficacious.
Hello.
Yes.
And less bleeding, more efficacious.
For primary prevention, there isn't any clopidogrel data, no randomized clinical trial data. The guidelines allow it in patients with aspirin allergy and so forth, but in general it just hasn't been studied. If you mean for secondary prevention, honestly, I felt for a while, based on Capri, that in high-risk secondary prevention, there's really little downside to using clopidogrel instead of aspirin. There's a little bit of extra cost, even though it's generic. It's still more expensive than aspirin, which is extremely cheap. But other than the cost issue, there's really no downside because unlike the strategies I mentioned, that's the one strategy to date where there are lower ischemic events. And the bleeding, the GI bleeding, is a little less with clopidogrel than with aspirin, at least when aspirin 325 is considered. 81 aspirin versus clopidogrel, it's harder to say. We don't have large trial data. But in general, I think it optimizes the net clinical benefit. So yeah, if the patient can afford it, that's not an issue, sure.
So last question is, now we have an IV cangrelor available in India. So what are the clear indication of the patient in whom we can use that IV cangrelor?
IV cangrelor, sure. I mean, I'm
a big believer in it. I led the pivotal trial, Champion Phoenix, as we published in New England Journal of Medicine, that led to its FDA approval. And I think that it's a terrific drug for the cath lab. That's where it's been studied most extensively and where it's labeled for use in the USA. And I know it's available now in many parts of the world, including India. So I think, for example, ST segmental elevation of the eye, that's a great place to use it. Someone comes in with high thrombotic burden. It was the last time I scrubbed in a cath lab in India. I was seeing a lot of young folks coming in with STEMI with enormous thrombus burden. A lot of times there wasn't even that much underlying angiographic coronary artery disease. Maybe if you IVUSed or OCT, you see something, but at least on angio, it was just a big thrombus in the Proxel AD, for example. Those sorts of patients, I think Cangalore is really made for. It has all the benefits of an intravenous glycoprotein 2B3 inhibitor, but because of a short half-life, once you turn it off, it's completely out of the system in an hour. It's safer than a 2B3 inhibitor. And it isn't metabolized by the kidneys or the liver. Therefore, even in patients that say have some kidney dysfunction, it's safe to use. So I think it's very cath lab friendly in high-risk ACS such as STEMI, but even non-STEMI that's high risk or has high thrombotic burden, and also is published by Greg Stone in the European Heart Journal. In fact, from Champion Phoenix, that's the largest angiographic study ever done in interventional cardiology. What he described was that even in stable ischemic heart disease undergoing very complex PCI, those sorts of patients, there's a benefit versus those that just get aspirin and heparin alone. So other than the cost, and there is a financial cost to it, I don't know what it is in India, it's a bit expensive in the US. Other than that, I think it's very useful in cath lab, and I think it's something that every cath lab should have in its armamentarium.
And patient with a recent PCI who has to undergo emergency surgery. Suppose within a month or two.
Sanjeev, let's stick to time. We are running late.
Yes, okay.
Yeah,
can we have question answer later?
Yeah, I think we'll have an opportunity at 7 to come back up, and so if you didn't get your question answered, we'll answer it then. Yeah, thank you all very much.
So next talk is by
Thank you, Dr. Bhatt. You can join us on the stage. To be nice in case you can join us on the dais as well. Thank you.
We will like to call Dr. Rosenson for his talk on lipoprotein A, a multifaceted lipoprotein at the nexus of inflammation and thrombosis.
Okay, so this is a fascinating topic, and I'm going to talk a lot about some new science, new concepts, so a little bit divergence from the types of talks you've heard earlier today. So lipoprotein A is considered an apolipoprotein B containing lipoprotein. We're getting away from the concept that it's an LDL-like particle because it's synthesized differently, the genetics are differently. So it's an ApoB containing lipoprotein. It's involved in many different aspects of atherosclerosis, including immune cell activation, endothelial cell activation, platelet activation, and also plaque destabilization. So in the case that was presented earlier with an extremely high LPA level, I would start aspirin in that individual. And if you have the luxury to actually do a genotype to determine if they have a sensitivity to LPA and aspirin, where the risk is increased 2.5-fold, that even is more compelling evidence to use aspirin in patients with high LPA. In this analysis that was conducted from the Copenhagen General Population Study involving 70,000 white individuals, increasing concentrations of LPA were associated with higher incidence of aortic valve stenosis, ischemic stroke, myocardial infarction, and heart failure. The data showing an association between LPA and coronary disease is stronger than it is for stroke and peripheral arterial disease. The more Kringle repeats that you have from a genetic perspective, the higher the risk of a cardiovascular event with lipoprotein A is shown in this analysis. The question is, how does a high LPA compare to a high LDL cholesterol? This was a very innovative analysis, again, from the Copenhagen investigators. And they compared high levels of LPA against patients who had genotypically confirmed familial hypercholesterolemia. And if you have an LPA between say 70 to 400 milligram per deciliter, that equals the risk of somebody with familial hypercholesterolemia that's clinically diagnosed, or with an LPA level of 180 milligram per deciliter, genetically diagnosed hypercholesterolemia. And the value of this study is that individuals were evaluated in the same geography, the same prospective cohort study. So think about a very high LPA level as having the same risk as somebody who's got familial hypercholesterolemia. In data that was published probably 25 years ago by Genet and Schaefer, they evaluated individuals with coronary atherosclerosis, stenosis of 50% or more in one of the lesions who had with coronary artery disease, and high lipoprotein A levels were found in 18.6% of individuals, the most common lipoprotein A abnormality in men and women with premature onset coronary artery disease. So these studies on classical epidemiology, genetic epidemiology were summarized in the recent European Heart Journal consensus statement showing the increased risk with the diseases that I mentioned. A high LPA is considered greater than 30 milligram per deciliter or 75 nanomole per liter. However, if you adjust for multiple risk factors and background therapy, the risk of a high LPA is seen at about 150 nanomole per liter. So a high level, above 75 nanomole per liter, slightly increased risk, but it's really at 150 nanomole per liter when taking into account the other treatments. So how should one measure LPA? Well, LPA needs to be measured by an assay that is, not affected by the number of Kringle repeats. We recommend measuring it in nanomole per liter, not in milligram per deciliter. Now, in an analysis from the Banting trial that I had the opportunity to lead, we evaluated two approaches to measuring LDL cholesterol in people with high LPA levels. So in this trial, the Banting trial of diabetes patients, we used the PCSK9 inhibitor evolocumab to lower LDL cholesterol. And when I looked at the results, there were some people that had a high LPA level that if you use a standard formula, assuming that 30% of the mass of LPA is due to cholesterol, one would come up with negative numbers for LDL cholesterol. I thought, wow, as this field of LPA is evolving, this is going to result in tremendous confusion. So we developed a formula known as the Rosenson-Markovina formula that looks at the molar ratio of LPA versus ApoB and also LDL cholesterol. And when we use this method, we could see that the LDL cholesterol levels that we're estimating or calculating are actually higher than what the conventional method would state. And we also, of course, had no negative numbers. And the reason that this is important is because LDL cholesterol is still our priority. And the LDL cholesterol level may be higher than you might think it is if, again, you just use this back of the envelope calculation of 30% of the mass of LPA as being due to cholesterol and subtract that from the LDL cholesterol level. Now, lipoprotein A is a major transporter of oxidized phospholipids. And oxidized phospholipids trigger inflammation and also may trigger thrombosis, as I'll share with you some of our original work. There had been a lot of discussion for decades, and it still is, I would say, littering the literature, that LPA, due to its structural homology to plasminogen, interferes with fibrinolysis. But that's actually an artifact of ex vivo studies, which I will now, which I'll review in a moment. So let's talk about oxidized phospholipid and the role of inflammation. In this study that was conducted by Semikis, individuals who had different categories of LPA above and below the median, who had positive LPA genotype, interleukin-1 beta genotype that indicated a more pro-inflammatory profile genetically, had higher rates of cardiovascular events. So the black line versus the green line there. So here versus there. So higher risk if you have an inflammatory genotype based on interleukin-1. And if you have higher LPA versus lower LPA, the risk is also increased. And similar findings were seen for the oxidized phospholipid normalized for the ApoB, again indicating the importance of the oxidized phospholipid. Other studies have shown that the background of inflammation influences LPA-associated risk. The first of these studies was conducted by the Accelerate investigators, a post-ACS study with the CETP inhibitor, evacetrapib. And when the CRP level is less than 2 milligram per liter, no increased risk associated with very high levels of LPA, but in the context of a CRP level greater than or equal to 2 milligram per liter, we can see that the risk associated with a high LPA increases dramatically. Subsequently, the MESA investigators showed something similar, the importance of a high CRP versus a low CRP on LPA-associated risk. Now, LPA is very interesting because at the bone marrow, it actually causes a more pro-inflammatory mononuclear cell. And in mononuclear cells, it actually results in a pro-inflammatory state, resulting in increased synthesis of tumor necrosis factor alpha and interleukin-6. In the study by Stiekema, they reported that individuals with high versus low LPA had different transcriptome with different regulated genes that were more pro-inflammatory in those subjects with high LPA versus low LPA. And those individuals with high LPA had actually more functional inflammatory activation, as indicated by increased transendothelial migration of the mononuclear cells. So again, this relationship between LPA and inflammation. Interleukin-6 activates the promoter for LPA at the level of the liver. And blocking interleukin-6 with either tocilizumab or the interleukin-6 monoclonal antibody, which is a mouthful, sifakimab, lowers LPA levels. Again, blocking interleukin-6 lowers LPA levels. And so again, we've got data showing an interaction between interleukin-6 and interleukin-1 beta that comes before interleukin-6 on an LPA-associated risk, and the easier metric is CRP. Now, what about residual risk? Again, due to the structural homology of the ApoA on the LPA with plasminogen, 77% homology, it was believed that LPA interferes with fibrinolysis and may increase the risk of venous thromboembolism. But that is not the case in classical epidemiology or genetic epidemiology. And it turns out it's an artifact. If you separate the A from the LPA, which a lot of investigators had done in the early stages, we can see that there's, in the black line, there's no impaired separate off the A from the LPA, there's impaired fibrinolysis. But if you look at the intact molecule, the LPA molecule, the catalytic site is actually shielded, and there's no impaired fibrinolysis with the intact molecule. So A protein rarely circulates in the circulation alone. It's part of the lipoprotein A complex. So for decades, people believed that LPA impaired fibrinolysis. But then there was the argument there's more STEMIs than non-STEMIs, and the STEMIs are larger, as indicated by higher CK levels, higher troponin levels. So recently we published data from the REGARD study showing that there's an interaction between high CRP and high factor VIII activity in terms of coronary heart disease events. So here you look at high CRP level, 1.49, high factor VIII over here, 1.54, but having high levels of both, the hazard ratios are increased to 3.84. But let's move this forward to more translational biology. So we identified individuals who had high LPA levels we defined as greater than or equal to 150 nanomole per liter versus less than 75 nanomole per liter. And we employed a multi-omic approach and also did functional biology to evaluate some of the characteristics of people with high LPA. In this study, the median difference in LPA levels were about 13-fold, 229 versus 18 nanomole per liter. And they had similar levels of LDL cholesterol, leukocytes, and monocytes. So actually well matched in this study of 64 individuals. And here's the LDL cholesterol levels. Different, but not significantly different. In this study, we looked at the mononuclear cells, and it turns out that those mononuclear cells for people with high LPA express more tissue factor. And we could see this in the histogram, about 3-fold higher expression of tissue factor. We then asked the question, what about the inflammatory profile of these mononuclear cells? And it turns out that they activated more interleukin-6 and more TNF-alpha, but they also had increased expression of tissue factor, and that tissue factor was active, as shown by the conversion of factor 10 to 10A. So we're able to actually take this inflammatory concept forward and link it to tissue factor activity in humans with high versus low LPA levels, and we're quite excited about those results. So just to summarize the first part of the talk, LPA is genetically determined, but the levels are increased by inflammation, and again, interleukin-6 is key there. Now let's talk about some of the therapies, brief overview. We'll talk about the antisense oligonucleotides, small interfering mRNA, and then gene editing as an option. Pelacarsen is the first in class in ASO that is associated with a dose-dependent reduction in LPA levels up to about 80%. This therapy is being evaluated in the Horizon clinical trial, and this is a study of individuals that are at very high risk based on prior MI, prior stroke, or symptomatic PAD. And in this study, of course, it's a placebo-controlled randomization 1-to-1 to pelacarsen or placebo. 4 years of follow-up has been identified in this trial, and that'll be the first LPA therapy that will, report. We had the opportunity to look at a small interfering RNA therapy known as olpasiran, which is given subcutaneous every 3 weeks, in contrast to pelacarsen, which is given subcutaneous every 4 weeks. And there was a greater reduction in lipoprotein A in excess of about 95%. And this therapy is undergoing a phase 3 clinical trial, and we're one of the core regional sites for this trial, in which individuals who have 2 PCIs in different vessels or an MI are eligible for randomization into this trial of olpasiran versus placebo. But when we think about LPA, there's many things that we don't know. The LPA-associated risk is different by race and ethnicity. In data that I didn't show in the REGARD study, blacks have higher LPA levels, and at those higher levels, the risk is not the same for coronary heart disease events compared to whites. And we know that South Asians, that LPA is a very important risk factor for early onset cardiovascular disease. And whether it's due to more oxidized phospholipid or whether it's due to more inflammation remains to be determined, but there's opportunities for collaboration. Not only looking at the differences in race, ethnicity, and some of the biology, we know that LPA is more strongly related to coronary disease than it is to stroke, and this is why when I had discussions with the TIMI investigators, I encouraged them to look at a coronary heart disease population as the inclusion, but look at a 5-point MACE, for their primary endpoint. So there's a lot of very exciting approaches and therapies that are being developed for LPA. And then in the years to come, you're going to start seeing treatment that's focusing on gene editing, a one-and-done approach for this genetic disorder that can cause very early onset cardiovascular disease in many of our patients. Thank you very much.
Well, thanks, Dr. Robert, for your great talk and and making us aware of the importance of LPA. Really, that it's not the usual lipid profile what we are seeing, but even the LPA in the near future, I think that is one of the causes of the residual problem, and one can tackle it with the new therapies which are going to come. Thank you.
Can I ask one practical question? Can I ask one question?
Yes.
Quick question.
Yeah, please go ahead.
So just want to ask one practical question. I had two patients recently who, one was 28 years of age, the other was 37 years of age, who had no other risk factors for premature coronary artery disease other than high LPA levels of around 226 nanogram and 90 nanograms. Now, British take the cutoff as 70. We probably are discussing 50 here. Is that right? Did I hear that right?
Yes.
The other is, what do we do for patients whom we catch up young? Do we start them on aspirin? Do we give them statins in the beginning? Is there a role of evalucumab, or say, like in India, we have evalucumab available?
Yes.
So, thank you.
So I see many, it's typically young men who have had VF arrest due to an LAD occlusion, typically in the late 20s, maybe early 30s, and that's a tragedy. I definitely put them on aspirin, and of course, they have a stent, so they'll be on DAP. I'm going to put them on a statin because when you look at the molar ratio of LPA versus LDL, there's about 13-fold more LDL particles than LPA particles. So I'm going to reduce the LDL particles. But I recognize that statins may increase the LPA, and in the clinical trials, on the background of statin, LPA becomes even a stronger risk factor for recurrent cardiovascular events. So what do? The only therapy that lowers LPA are PCSK9 inhibitors. And in subgroup analysis of individuals with higher versus lower LPA levels, PCSK9 inhibitor provides a larger absolute and well as relative risk reduction. So if you can get those patients on an LPA inhibitor, that's what I try and do to lower their risk. Keep in mind that the response to PCSK9 inhibitors is quite heterogeneous. The average reduction is 25%. Some people get no reduction. Some people get a 70% reduction. So you need to reevaluate, them. But this is why we need some of these new therapies, and that's why I'm in the business of what I do, is to try and find solutions for people that suffer and there are no other options. But we're on the horizon, as you could say, with the Horizon trial of having a therapy that may become available to reduce LPA-associated risk.
That's all for this session, and we'll start the session 4. The next speaker is Dr. Amit Khandelwal.
Thank you so much to all the members at the panel and also the speakers. Before I'll go ahead and invite the next panelist, may I once again would like to have your all, just give me a moment please. Right, may I request for your attention please, especially our pharma colleagues. Once again, I humbly request you all to please maintain the silence, as we are not able to hear our speakers properly. So once again, very humbly I request our pharma colleagues at the back to please keep the silence. And I would also request Eternal Hospital management team to please look into this and ensure this. So moving on to the next one, may I request Dr. S.K. Kaushik, Dr. V.V. Agarwal, Dr. C.B. Meena, Dr. Sanjeev K. Sharma, Dr. Vivek Mathur, Dr. Kushmendra Parasha, Dr. Lokesh Agrawal, Dr. Avnish, and Dr. Arif to please join us on the stage and take the session ahead. May I once again repeat the names? May I request Dr. S.K. Kaushik, Dr. V.V. Agarwal, Dr. C.B. Meena, Dr. Sanjeev K. Sharma, Dr. Vivek Mathur, Dr. Kushimendra Parashar, Dr. Lokesh Agrawal, Dr. Avnish, and Dr. Arif. Request you all to please take the session forward. Thank you.
Thank you very much. Without wasting time, may I invite Dr. Amit Khandelwal from Udaipur, who is going to speak on Are all NOVAX the same? NOVAX in challenging HBR scenario, post-PCI, elderly hepatic and renal dysfunction. Dr. Amit Khandelwal is a renowned interventional cardiologist from Paras Hospital, Udaipur, Rajasthan.
Good evening, respected chairs, seniors, and dear friends. At the outset, I would love to extend my heartfelt thanks to Dr. Samin Sharma sir, Dr. Sanjeev Sharma sir, Dr. Makkar sir, and entire team of Eternal Hospital for providing me the opportunity to interact with on this very important topic, NOACs. Are all the NOACs the same? Well, if we are talking about NOACs, there must be something worrisome about the other OACs, that is VKAs. Secondly, are there any different indications of NOACs other than the routine ones that we use? Well, the classical indications are for the prevention of stroke in the patients of atrial fibrillation, DVT, and pulmonary embolism. And NOACs are also to be chosen in the best of the manners, especially in some of the subsets who are high bleeding risk in comparison to stroke prevention. So what we are going to discuss is basically comparison between the classical VKAs, NOACs, and aspirin, the randomized controlled trials, meta-analysis, real-world evidences, and specific subsets as well. So if we look at the data and study from Kashoff et al., which was published in European Heart Journal in 2016, for the prevention of stroke in the patients of atrial fibrillation, oral anticoagulant is the standard of care. And if you compare aspirin versus placebo, there was 22% reduction, relative risk reduction. If you compare VKAs with aspirin, there was 38% relative risk reduction. And if you compare head-to-head NOACs versus VKAs, there was 19% relative risk reduction of stroke or systemic embolism in patients of atrial fibrillation. What was more important to, which was highlighted in this study and in ESC 2016 was antiplatelet monotherapy is not recommended for stroke prevention in AF patients irrespective of the risk of stroke. Now, when we are talking about NOACs, there should be something worrisome about the classical OACs, that is VKAs. What are those? Basically, the onset and offset of action and the longer half-life was the worrisome point. When we talk about warfarin or acetylene, there has to be monitoring, regular monitoring, a lot of drug-to-drug and dietary interactions. Then for warfarin to be effective, you have to maintain TTR, that is time in therapeutic range. So that has to be maintained for more than 70% of the times, which was not classically maintained in Asian patients, especially in Indian subsets also. And if you look at the overall, and this was published by Garfield AF registry also, that Asian patients many a times they spend outside the therapeutic range. So how the basic development of NOACs began because of the limitations of the classical VKAs. If we look at the trials, the story started in 2009 and 10 when dabigatran and rivaroxaban started. So there were 6 major trials of warfarin versus placebo. Thereafter, NOAC versus aspirin Everest trial was there, which was in favor of course, apixaban. And there were 4 classical trials of NOACs, taking dabigatran with Rely trial, Rocket AF trial with rivaroxaban, and Engage with edoxaban, and Aristotle with apixaban versus warfarin. So as we have discussed all the limitations of warfarin or VKAs, there were fewer advantages of NOACs as well. Now if you look at the pharmacokinetics, more or less they are similar, except we need to remember few things like renal clearance. So majority of warfarin, that is hepatic clearance, is there, and dabigatran is also classically renal clearance, 85% is there. But if you look at rivaroxaban and apixaban, almost 25 to 30% of drugs is basically renally excreted. So this group of drugs are basically quite effective in renally compromised patients. Now just have a look of the overview of the study, the classical study Aristotle. Apixaban, it was a randomized controlled trial, double-blinded, in AF patients with having CHARAS-2 VASC score of at least 1, was compared with warfarin, keeping in PT-INR between 2 to 3. And if you are having any of the three ABC limitations, age more than 80 years, body weight less than 60 kg or creatinine of more than 1.5, you have to downgrade the dosage to 2.5 BD. So it was compared, and what was to be seen was primary endpoint of efficacy in terms of reduction of stroke or systemic embolism, primary endpoint of safety in terms of major bleeding. So what was seen was there was significant 21% relative risk reduction of stroke or systemic embolism with apixaban in comparison to warfarin, and major bleeding endpoints, primary and secondary, both key outcomes were also in favor of apixaban. What was more important was when we talk about the landmark trials, well, when it is coming from the horse's mouth, like Dr. Jeffrey M. Dresden, in 2019 he said he considered Aristotle trial as one of the most important 12 trials which has changed the shape of the practice and life-saving papers that we have got in last couple of decades. So if we extrapolate those data, NOACs versus warfarin, and if you take in terms of stroke or systemic embolism, all the dosages were more or less favoring NOAC in comparison to warfarin. But the most effective was dabigatran 150 milligram. In terms of efficacy, I'm saying, and apixaban 2.5 or 5 was equally or more borderline was effective. But others were more or less still effective, but they were lesser in comparison to these two drugs. If we consider the other endpoints, primary or secondary of safety, then also it was favoring NOACs in comparison to warfarin. Similar thing was depicted with all-cause mortality. What was interesting to note was rivaroxaban 20 milligram was found to be having slightly more bleeding in comparison to warfarin. But otherwise, all NOACs were being favored in terms of major bleeding in comparison to warfarin. So if you just look at the summary of these 3 or 4 slides, dabigatran was definitely having lesser side effects in terms of ICH or major bleed, but 110 milligram was less efficacious. But if you go for safety and if you go for efficacy, you lose safety with 150 milligram. Apixaban 5 or 2.5 BD was found to be quite effective for both primary and secondary endpoints. When we talk about the entire choice of the drugs, we in Indian subcontinent always talk about we don't have the data. We talk about the drugs which are actually, manufactured in West, and they are having all different subsets of populations, different behavior of the different drugs. Do we have data for this? Yes, we do have Indian data incorporated into this trial as well. Almost 601 patients were incorporated, and the results were more or less consistent in comparison with respect to the primary and secondary endpoints of safety and efficacy. If we look at the real world evidence also, the classical Aristophanes study, it was a retrospective observational study having more than 4 lakhs patients. Since it was a retrospective observational study, the data was taken from the insurance database, and the patients were equally matched according to the propensity score matching in order to avoid the confounding variables, in order to avoid the bias in the observational studies. What was found was, if you look at the incidence rates and hazard ratios of stroke and systemic embolism and major bleeding also, in apixaban warfarin matched scores, it was associated with 36% relative risk reduction of stroke and 40% relative risk reduction of safety major outcomes in terms of the safety and efficacy. Similar thing was depicted with the apixaban and dabigatran cohort as well. Apixaban rivaroxaban was also favored according to this propensity score matched cohorts. Apart from this, now how to manage some of the specific indications, for example, elderly. Now, elderly are the patients who are at higher risk of development of stroke or systemic embolism. The biggest causative, or you can say the risk factor for development of AF is age, hypertension, ischemic heart disease in the West. In addition to these, classical valvular heart disease is also a very important cause in Indian subcontinent. But when we talk about NOACs, valvulars we don't consider and they are not effective. So if you look at all the age groups, whether they are less than 65, 65 to 75 or more than 75 years, apixaban was found to be more efficacious in comparison to warfarin, and also major bleeding was seen to be lesser in comparison to warfarin. If you look at another data of 75 or more than 75 years of age, again NOACs were found to be better in comparison to warfarin, and of course apixaban at all the things that we are discussing, primary and secondary endpoints. The similar thing has been depicted over here as well. Now if you look at the international consensus validation, FOTA, that is fit for the aged classification, it is basically to look for the medication which is regarding the efficacy, safety and age appropriateness, and it has been divided into 4 classical classes. A is indispensable, means the drug is most effective in terms of efficacy and safety, and apixaban falls into that. And other NOACs are falling into, definitely they are beneficial, but they are falling into class B. In renally compromised patients, now renally compromised patients are actually double-edged sword patients. They are at high risk of thrombosis also, they are at high risk of hemorrhage or bleeding also. And if you look at the horizontal bars, the darker blue bars are basically with increasing renal dysfunction, and lighter blue are basically for lesser in comparison to the higher ones. So higher the renal dysfunction, there are more chances of annual stroke rate, ischemic stroke rate and all-cause mortality, and of course bleeding as well. So we need to understand recheck interval. Now what is recheck interval? If the patient is being seen now, when the patient should be called for the next follow-up. This you should calculate with respect to creatinine clearance divided by 10 formula. Now if creatinine clearance is close to 60, if you divide by 10, it comes out to be 6 months. So this patient has to be seen every 6 months minimum. And if creatinine clearance is close to 20, divided by 10 comes out to be 2 months. So this patient should be more aggressively treated and seen. If you compare all the 4 classical NOACs, the renal excretion is least of rivaroxaban and apixaban, and so these drugs are more safe in renal dysfunction patients. Non-end stage renal disease. Non-end stage means you can say creatinine clearance up to 30. Which drug is more effective? Of course, all the 4 drugs, if we see with respect to stroke, with respect to systemic embolism, dabigatran, both the dosages, and apixaban was found to be classically effective. But if you consider the secondary and primary endpoints of safety, apixaban was found to be more effective. What about renal failure? Well, this is the data that we have got from Indian studies. Apixaban is quite effective even in renal failure patients, the patients who are having renal failure and patients are having creatinine clearance of less than 15 and patients who are on dialysis. High risk of GI bleeding. Now, these are the patients who have had past history of high risk of bleeding, and the patients are needed to be given NOAC. How to choose? Major GI bleeding per year, if we calculate according to the studies and data, dabigatran was having close to 1.85, rivaroxaban was having close to 2, and apixaban was most GI bleeding safe with 0.76 events per year. So if you look at the guidelines, European Society of Cardiology 2020 guidelines also, they also say the most effective drugs in terms of bleeding, in terms of GI bleeding are dabigatran 110 milligram BD and apixaban.
Dr. Amit, we are running late, so we can...
Yes, sir. So the similar thing has been shown with respect of other sort of bleeding also. In hepatic dysfunction, patients who are having atrial fibrillation with the background of hepatic dysfunction, what you need to do is child pug classification. You have to understand there are 5 classical parameters on the basis of which we assign the points. If the points are less than 7, it is child pug A, 7 to 9 B, and C is most severe hepatic dysfunction, that is more than 9. So in C, no NOAC is recommended. In A, all NOACs are recommended. But in child pug B classification, you can use dabigatran and apixaban and oxaban, but with caution. So the patients, last couple of slides more. So in patients, now this is most challenging for especially we interventional cardiologists. A patient is already having AF, patient is on NOAC. The patient has come to us with acute MI, now medically managed patients or patients undergoing PCI. How to move ahead? You have to prevent the stent thrombosis, you have to prevent the stroke or systemic embolism, and you have to prevent the bleeding also. Finding the sweet spot is a classical thing, and you have to individualize. Guidelines are to basically guide you, but ultimately it's the patient. You have to calculate for the risk, you have to calculate for the bleeding risk also, and stent thrombosis and stroke risk also. Well, I'll be just skipping this. Augustus trial was a very important and guiding trial to compare apixaban versus VKA with the background of aspirin to be given for minimum 1 month and P2Y12 purinergic receptor blockers for minimum 6 months, and the data was favoring apixaban arm in comparison to VKA in terms of bleeding also and in terms of stent thrombosis reduction and stroke prevention also. Last slide, 2020 ESC guideline. What does it say? What does it say? If the patient of ACS is there, we have to go for intervention, load the patient with aspirin. P2Y12 has to be continued for 6 months. Aspirin has to be preferably continued for minimum 1 week, but if you feel like risk of bleeding is less, for at least 1 month, and lifelong you have to continue for NOAC. So to summarize, whether you consider the meta-analysis, randomized controlled trials, guidelines, or the real-world evidence, apixaban 5 milligram has considered to be the most efficacious and safe NOAC in comparison to the other NOACs. Even in subsets, special subsets like elderly population, renal and hepatic dysfunction, post-PCI patients also, apixaban has found to be more effective. With this, I would love to sum up the presentation. Thank you very much for the patient hearing.
Thank you, Dr. Amit. I think we are getting late, so I think we'll have the discussion later on. So we'll call upon the next speaker, Dr. Kush Bhagat, and he'll be speaking on what's new in AF management, what is the current status.
Thank you so much, sir, for such a wonderful talk. I think you have briefed very nicely which NOAC to use in which subgroup of patients. So before moving to my presentation, I would like to ask a question from everyone actually. So suppose a patient comes, maybe a 40 years of age patient with history of recurrent atrial fibrillation, paroxysmal atrial fibrillation, and we have started him on either flecainide or amidron. And despite medications, he's obviously on NOACs, as Amit sir described. He's on the best NOAC possible. And despite that, he's having episodes of atrial fibrillation, symptomatic AF episodes. So what should we do to that patient? He's on flecainide. Now, what should we advise him? So before moving to my presentation, I'd like to ask this question. Anyone would like to answer? 40-year-old patient with recurrent atrial fibrillation. Sir, please, sir.
Symptomatic is not controlled with the drugs. I think
Yes, sir.
class 2 indication for the AF ablation.
So AF ablation and class 2 recommendation. So I'll come back to the recommendation, sir. Now again, the other question is which ablation strategy. So I'll discuss that in my presentation. The class of recommendation and the various strategy of ablation. So I think we all know about the various types of atrial fibrillation, about the paroxysmal AF, the persistent AF, long-lasting AF, and the permanent AF. So usually we try to target these subgroup of patients, the paroxysmal and the early persistent AF patients for ablation. And as I discussed about the various, the clinical presentations of atrial fibrillation and the AF-related outcomes, which most commonly is the stroke. And it can also lead to LV dysfunction and heart failure if patient has recurrent episodes and persistent AF, which we call it as tachycardia-induced cardiomyopathy. Now coming to the guidelines. So according to the guideline, so if patient is symptomatic atrial fibrillation who is refractory or intolerant to either class 1 or class 3 antiarrhythmic medications, and if he is having paroxysmal AF, then actually he is class 1 with level of evidence A. So it's a very high indication, class 1 with level of evidence A in paroxysmal AF patients. And again in persistent AF, it's class 2A. So I feel that if patient is on medications and despite that he is having atrial fibrillation, he should be given advice of catheter ablation for atrial fibrillation and class 1 with level of evidence A for paroxysmal AF. And as far as the strategy of AF ablation is concerned, so we all know that according to the HRS consensus statements that all the pulmonary veins, all the 4 pulmonary vein isolation is widely accepted as the cornerstone of AF ablation procedure. And because most of the triggers for atrial fibrillation, more than 90% of the AF trigger, it is found near the pulmonary veins. So isolation of all the 4 pulmonary veins is what we actually do in atrial fibrillation. And again, this is class 1 with level of evidence A, that electrical isolation of all PVs is recommended during all AF ablation procedure. And as far as non-ablation strategy is concerned, which is actually very important, is all these lifestyle modifications, weight loss, if patient having obstructive sleep apnea, then overnight CPAP, reduced BMI. So all these are very important non-ablation strategy. ESC guidelines, again, same guidelines and almost same recommendation. Class 1 with catheter ablation and pulmonary vein isolation is recommended for rhythm control strategy. And in fact, it is giving class 1 recommendation to reverse LV dysfunction in AF patients when tachycardia-induced cardiomyopathy is highly probable, independent of the symptom status. So if patient is having LV dysfunction and atrial fibrillation, and if we consider that it's tachycardia-induced cardiomyopathy, then it's basically class 1 indication. Now coming to the strategy. So I think I mean the answer to my question is definitely we have to go for ablation with guideline. According to the guideline, it's class 1 level of evidence A, since my patient was paroxysmal AF patient. Now coming to the strategy, which strategy is recommended? So PVI has to be done, but so pulmonary vein isolation can be done by either radiofrequency ablation or cryoablation. So these are the 2 strategies to control atrial fibrillation. So RFA with 3D mapping, we are doing these since years, and it's a new technology, and in this basically we isolate all the 4 pulmonary veins. So these are the 4 pulmonary veins, the left sided and the right sided veins, and these are the brown dots, the radiofrequency ablation dots, which we give to isolate the pulmonary veins. Now, what is basically cryoablation and how it is different from the radiofrequency ablation? So, needless to say, there are a lot of studies which were done and which has a cryo first trial, stop AF first trial, early AF trial, which has clearly proven that cryoablation is a good, it's a good strategy for pulmonary vein isolation. And in fact, apart from the paroxysmal AF, it has also been approved by US FDA for persistent AF patients. And it has proved that as a first-line therapy, cryoballoon ablation, it is superior to antiarrhythmic drug for prevention of all atrial arrhythmia recurrence. And first-line cryoablation is associated with larger improvements in AF-specific quality of life compared to antiarrhythmic therapy. So, any patient who falls in the guideline should be given advice of ablation. So, coming to the Fire and Ice trial, it was basically a randomized trial, and it was a comparison between cryoballoon and point-to-point radiofrequency ablation. So, basically comparison between radiofrequency ablation and cryoablation. And according to this trial, so cryoablation, it had 33% fewer repeat ablations, 34% fewer cardiovascular hospitalization, and 50% fewer cardioversions, 21% reduction in all-cause rehospitalization. clearly proven that cryoablation is better than radiofrequency ablation as far as these points were concerned. So what is cryoablation and basically what we do in cryoablation? So it's not a new strategy. It's I think it was people are doing since last 10 to 15 years this cryoablation, and this is how what is the system of the components of the cryoablation. So this is the console, this is the balloon, this is the catheter, and this is the mapping catheter. So these four things are required for doing cryoablation. So basically we do that first, this is the pulmonary vein. We go inside the pulmonary vein like this and we inflate this balloon, and after inflating this balloon, so we give cryo energy, and cryo energy is given by nitrous oxide. So after giving cryo energy, this whole area is isolated. So pulmonary vein isolation is done like this in cryo ablation, rather than radiofrequency ablation in which we have to do point by point ablation. So this is how it works. So this catheter is connected to this, and this again this balloon is inside the pulmonary vein like this for isolation. And the cryo console, it controls safe delivery of nitrous oxide to the catheter and return of the warmed vapor. So if we compare, so cryo versus radiofrequency ablation, so this is how it looks. So this is pulmonary vein ostium, and these are the dots we give to burn the tissue by point to point radiofrequency ablation. And in this, we just take the balloon inside the pulmonary vein, inflate the balloon, give cryo energy in the form of nitrous oxide, and this whole vein is isolated. So pulmonary vein isolation we have to do, and these are the two strategies for isolating the pulmonary veins. So what are the advantages of this PVI through cryoablation as compared to radiofrequency ablation? So this is actually technically more challenging because we have to take the catheter from one point, give burn at one point, then again take the catheter to another point. Like this we have to take the catheter around 15-20 times in order to isolate the whole pulmonary vein, which is actually time taking and technically challenging. Also, it is challenging to achieve consistent catheter stability, and therefore it's time consuming, the radiofrequency ablation. Now as far as cryo is concerned, it is simpler, it has got a shorter learning curve, easy to reach the target area within the short span of time. And as far as safety and efficacy is concerned, efficacy I have already discussed, and safety is it's very safe, reduced risk of complications, fewer repeat ablations, and most important thing which is applicable in our cath labs, especially in India, it enables time for additional EP lab procedures or rather interventional procedures because it is very less time taking as compared to the radiofrequency ablation. So this is basically the advantage of cryo balloon ablation over radiofrequency ablation. Less side effects and more effective. So it preserves the extracellular matrix. So this is the radiofrequency lesion at 1 week, and arrow it indicates the thrombus and disrupted endocardium, and this is how it is preserved. This is extracellular matrix which is very well preserved in cryo balloon ablation. So a small case which we did. So she was symptomatic, 43 years old female, having recurrent episodes of atrial fibrillation, and she was already prescribed on antiarrhythmics, still no symptomatic benefit. Echo was normal. So this is actually real time image of the video of the so this is basically cryo balloon. This is pulmonary vein. So our catheter, this is inside the pulmonary vein, and once we localize the pulmonary vein, we inflate this balloon, we give contrast. So this is contrast which is being given in the pulmonary vein just to make sure that this balloon is in quite good contact of the pulmonary vein, and after we have ensured this, we give the cryo energy, and this cryo energy will isolate the pulmonary vein. So we have to do this in all the 4 pulmonary veins, in both LSPV, LIPV, RSPV and RIPV. So this is how it actually happens. So this, we can see the ECG, patient is having atrial fibrillation. So this is all AF ECG, and patient was started giving this cryo energy, cryo ablation, and see, so it has reverted back to normal sinus rhythm. This is all normal sinus rhythm with intermittent APC. So most of the times we see that patient gets converted to normal sinus rhythm on the bedside only in this cryo balloon ablation. So this is LIPV, this is again right superior pulmonary vein. So as told, so this is the balloon which is very well contact with the pulmonary veins, and this is the LIPV. So just to conclude, it is simple, safe, fast and effective catheter ablation procedure, this cryo balloon, predictable and shorter procedure duration, most important in Indian setup, and it creates ideal lesions that are wide, extended and circumferential as compared to radio frequency, fewer repeat ablations, shorter learning curve and strong clinical evidence and consistent results. Thank you so much. So I think we have 2 minutes left. We can go for questions.
Thanks.
Thank you, Dr. Kush. But I think recently we have new technology of PFA, which is going to be on
Yes,
the new
sir.
horizon. As far
But
as
still
I
it's
think.
not being launched in India, sir.
So we can call the next.
The message is very
So
clear.
one more question.
Message is very clear that a paroxysmal AF, the ablation is the preferred strategy, the class 1 indication. Second message is that cryoablation is safest.
Exactly, sir.
And very quick.
In a nutshell.
mapping. So all the
So
cases
paroxysmal AF, class 1, level of evidence A. Yes, sir. Not for rheumatic heart disease. So we never do any sort of ablation for rheumatic heart disease patients, sir.
So any contraindication for such therapy like cryo?
Oh, no contraindication. Just that sometimes we have to do cryoablation as well as radiofrequency ablation because we can isolate only the pulmonary veins with the help of cryoablation. Suppose we have to do ablation for atrial flutter. Left side, we have to give lesions in the LA free wall, LA roof, LA posterior wall. Then we have to combine it with the radiofrequency ablation. But then that is required when we are suspecting it to be a long-lasting persistent AF. That's why we take early persistent AF and paroxysmal AF patients so that we can easily do, and results are also good. The fewer AF episodes, recurrence is there when we take these subgroup of patients, and that is why it's important that we go for the earlier treatment with catheter ablation because this recurrent episodes of AF will beget AF.
Yeah, so it is a good idea to go with hybrid kind of approach because it is good for PV isolation, but lot of substrate modification needs to be done. But that is more in case of persistent AF. In paroxysmal AF, PV isolation is fine, and I believe that it is a very good circumferential ablation and little bit of substrate modification also happens. But sometimes, yes, like the case Kush showed, this young lady had lot of APCs and followed by atrial fibrillation. So during ablation, APCs also disappeared, but after ablation in ICU, premature beats came back, but AF never came back. So those premature beats, we actually had planned that we'll tackle that with the RF ablation later, but if they are not coming from pulmonary vein, but since they disappeared on table, so we couldn't do RF ablation of those.
So thank you, Kush.
Thank you, sir. Thank you, sir.
Let me call the next speaker, Dr. Arvar Kasliwal, sir, from Delhi.
Yeah, Dr. Kasliwal is a big name in the field of clinical and preventive cardiology. And right now he is working as a chairman of clinical and preventive cardiology. And we've been knowing him for more than 25 years now, since our Scots days. He's a big man and is a great interest for the academics. Over to you, sir.
Thank you for the kind words. Thank you, Dr. Samin, for this very kind information. And Sanjeev, I'm really honored to be here, to be back home. Truly nice of you all. And especially to Sanjeev, because by the time this talk is being rendered, much of the controversy about aspirin and from Ascent to Capri have already been done, and also the lipoprotein. So what I've tried to do truly is to look at coronary artery prediction. That's about all that I will talk about. And this has been my journey after DM cardiology from AIMS. I was just trying to always think, how can we actually catch those patients? We have the youngest population in the world. Can we save them from a heart attack? CVD in India, the numbers are huge. Highest burden of ACS and STEMI in the world emanates from South Asia, particularly from India. The current prevalence has increased 7-fold, and as we speak, in the last 2 years, it may have gone even further, 4-fold in rural area. And the burden of CVD, but the burden of CVD varies markedly. So if you look at it, the unique features of CVD in India, ASCVD in India, high mortality rates, increasing burden, regional variation, but the thing that's most important is premature mortality. That is the most important thing. We are one of the youngest nations in the world on the cusp of glory, and we find and we cannot help save our young people from getting ASCVD. CAD in young people aged less than 45 years in men and 50 years in females is strikingly more common in Indians. And in 2016, there was an estimated 62.5 million years of life lost prematurely due to CVD in India. So those are the figures. And mind you, this 2016 to 2023, things may have changed dramatically. So how do you assess risk? Behavioral risk factors, metabolic risk factors, very well known. From the time President Truman in 1945 started the Framingham study, we all know the risk factors. Dietary risks, tobacco use, low physical activity, hypertension, dyslipidemia, fasting blood glucose levels. To that, we have added ambient air pollution, persistent organic pollutants, exposure to solid fluids. These are but can you actually pick up a person and say, look, just because you have these, you're going to get an ACVD. So how to assess the CVD risk? From Framingham score to JBS and to Mayo Clinic and to Q risk, there are lots of scores, but none of them have been derived for Indians, and therefore none is applicable to Indians in that sense of the word. So many years ago, we did a comparative accuracy of different risk scores in assessing cardiovascular risk in India. This is a small study. De novo 149 patients with no previous CVD. Look at the average age, 59 plus minus 10, plus minus 10.6. And we applied 4 risk scores to them. So the FRS, the new ACC AHA pooled cohort equation, JBS3 and WHO predictions charts. But see, this is what we found. There was actually no great correlation, except to say that yes, undoubtedly, these people are more predisposed. So you may be doing an evening consult with a young 35, 40 years old gentleman, and then your resident rings you up at 3 o'clock saying, sir, he's got chest pain. And this work has shown that possibly the only marker the only risk score that actually comes close by is the JBS3 risk scores, and that is probably better for us. So we thought of a paradigm shift. We know that atherosclerosis begins in childhood, from cellular infiltration to plaque rupture. And Dr. Deepak Bhatt is sitting right here. This is a couple of sentences taken from one of his articles on premature CAD in the US. Atherosclerosis is a progressive disease that starts during the early years of life, and it can be considered even a childhood disease with an incubation period of a few decades. Well, this is what we started with. Today is the 20th year of our first publication on preclinical atherosclerosis. The first paper was published in 20 years ago. Now, Ahmadi et al. Said about preclinical atherosclerosis that until the later stages of obstructive disease or plaque rupture, coronary artery disease remains clinically silent. So typically our patients will come and tell us that, look, I'm sorry, I didn't come to you because I had no symptoms. And the other national disease that we have is gas. So they thought it was all gas. So on their way to developing obstructive disease or a first event, patients are not only asymptomatic, but usually also have a normal functional test. That's important. And I've always been impressed by Dr. Valentine Fuster, the PISA study that he has started in Spain. Progression of early subclinical atherosclerosis. Just see the very terminology. Progression of early subclinical atherosclerosis demonstrated that 50% of asymptomatic individuals had atherosclerotic changes despite being considered low risk. So many years ago, we said that people have risk factors, they have endothelial dysfunction, they have atherosclerosis, but we never look at it. We wait till they develop obstructive coronary artery disease, we put them on a treadmill, and if more than 2 vessels are more than 70% blocked, we say, well, you have a positive test. And so the patient says, look, is that good for me or bad for me? But obviously, we have not detected atherosclerosis, but we've actually detected disease, because then he goes into the loop of coronary artery disease, myocardial ischemia, coronary thrombosis, infarction, arrhythmias, cardiac remodeling,
and of course, CRTD and everything else. So we started this many years ago in a very simple way, that we were wanting to find out the missing link between the risk factors and clinically evident CVD, and we started with carotid intermedial thickness. I know that if you talk of CIMT in 2023, it's an outdated modality, but plaques still function. So arterial pulse wave velocity, ankle brachial index, CIMT, carotid plaques, epicardial fat, coronary calcium, these were the elements that we took for detection of preclinical atherosclerosis. This was our first paper, published in 2003, and after that we also published normative data for Indians. So people can't say that, look, I didn't know this guy was only 35 years old. But of course the concept is there, but nobody uses IMT independently because that age is over. It is a plaque that matters now. Carotid intermedial thickness and coronary artery disease in Indian perspective, small cross-sectional study that we did, had difficulties for Indian Heart Journal, but was published in a journal from Singapore, but demonstrated that yes, there was a correlation. This rapid screening for subclinical atherosclerosis by cardiac ultrasound examination was again by Partho Sen Gupta, myself, and Dr. Valentine Fuster. The heart attack prevention program for you, the HAPPY study, and rapid community screening of subclinical atherosclerosis we found was feasible with automated carotid ultrasound examination. So we started at that level, and then my friend Roxy Senior from King's College said that simultaneous assessment of atherosclerosis and ischemia in patients with suspected angina probably gave more information. So atherosclerosis predicted hard events beyond myocardial ischemia, particularly in patients with a normal SE. So the bandwagon moved, and from atherosclerosis of the carotid arteries, the femoral arteries, we moved on to coronary calcium score, and we found that the diagnostic accuracy of coronary artery calcium, this is published in our Journal of Clinical Preventive Cardiology, a total of 380 subjects undergoing comprehensive health checkup, included computed tomography, coronary angiography, CTCA, in our center, and we found that the distribution of CACs was correlated with coronary plaque burden, and that the clinical and laboratory investigation findings. And you'll see that 5.9% subjects with zero CAC had any coronary plaque, and only 1.2% had obstructive plaque. So definitely, in a poor nation like us, if we can just do a coronary calcium score, 98.8% negative predictive value is huge, in a country where hypertension, diabetes, cigarette smoking, nicotine, and dyslipidemia is so common. So diagnostic accuracy of coronary artery calcium score for excluding obstructive coronary artery disease is something that we use very routinely. Plaque definition, we know type 1, type 2, these are various kinds of plaques. Basically, it depends upon how much is the fibrous structure and how much is the plaque burden. If the fibrous structure is, as Steve Nissen's study showed, were much more than the plaque, then the plaque is not vulnerable. But if the plaque is more and the surface is smooth, then of course there are more chances of rupture. People always ask that, look, I've got this test done, am I okay for the rest of my life? Well, CACs, coronary artery calcium score increases at a rate of approximately 20 to 25% per year, with almost 20% subjects with initially zero CACs developing CAC 0 within 4 to 5 years, more than 0 within 4 to 5 years. And I must say that Khurram Nasir and their group have greatly influenced our thinking about early detection and prediction of coronary artery disease. And as they say, the lowest risk is seen in those who have a double zero. That means CACS 0 at 2 scans performed approximately 5 years apart. So in a serial CTA study, 423 patients with stable CAD, high-risk plaques with progression over time, and that's what Dr. Deepak Bhatt also said, that, we're moving into that era that we will have to look at high-risk plaques, low attenuated plaques, and these will tell us that this individual has a higher chance and this has lower chance. of getting an acute coronary syndrome, even though they both may be having the same calcium score. So stop plaque progression to reduce acute coronary events is a question Ahmadi et al. Tried to answer in JAC 2019. Acute coronary syndrome and sudden cardiac death are the first manifestations, and that's what we are facing with, that we have the highest incidence of STEMI in our country. 20%, 15 to 20% won't even get a chance to get up from the floor and say, guys, can you help me? I'm having a chest pain, but they're not even there to say that. So this highlights that the notion of defining primary prevention by the absence of historical coronary events or even functionally obstructive CAD has limited overall prognostic value compared to the detection of atherosclerosis. So as people say, is everything secondary prevention? So it seems. So detection of subclinical atherosclerosis, something that we lived with for last 20 years, has now become correct, and many people believe in it. The detection of subclinical atherosclerosis could allow a shift from the traditional before the event primary prevention to primary prevention in subjects with subclinical atherosclerosis. And then of course the genetic risk factors, we entered this field late, we're now just beginning to understand it, the polygenic risk scores, and we were greatly influenced by Dr. Khera's work from the British Biobank, but our work is still going on, and this is derived from genome-wide analysis looking at 6.6 million common DNA variants. So, ladies and gentlemen, for me, a genetic history, more important is the family history. The importance of family history of MI in younger patients is an important predictor of risk and underemphasized in the classic risk scores. Family history may also refer to exposure to shared environmental factors, including socioeconomic status, dietary intake, physical inactivity, sedentary behavior patterns that tend to be similar within families. I give a lot of stress to this kind of family history. So I think the missing link is atherosclerosis or plaque formation. And so what we need is a diagram like this where we define low-risk patients, high-risk individuals, and those who have, the biggest burden is those who have intermediate risk, so-called intermediate risk. If we find evidence of calcium score increased, then we know that they fall into the high-risk category. So personalized risk assessment is already there with coronary artery calcium, arterial ultrasound, polygenic risk scores, and integration of these tools promises a highly dimensional approach to individual risk evaluation. So in conclusion, ladies and gentlemen, evolving strategies for the imaging of atherosclerosis suggest the feasibility of a personalized approach to atherosclerotic cardiovascular disease beyond the use of traditional risk factors. The traditional risk factors will not go out of fashion anytime soon. They will be there to guide us. But at least this approach offers to treat the disease rather than the likelihood of disease. So cliched but true, prevention is better than cure, and this is the life's essential aid, which was AHA's simple 7: predict, prevent, predict, preempt, and prevent. Thank you, ladies and gentlemen. Thank you for your attention. Thank you.
Thank you very much, sir, for very comprehensive presentation of right from the pathogenesis of the starting of disease and how to scan them by various modality and manage them at an early stage. Thank you very much, sir.
Thank you very much, sir.
Thank you to the entire panel and all the speakers. Now, moving on to the next one now. May I request Dr. R. Kasliwal, Dr. D.S. Chadda, Dr. Amit Khandelwal, Dr. Deependra Bhatnagar, Dr. Vivek Mathur, Dr. Bhavar, and Dr. Prashant Dwivedi for chairing this session and to take this session forward. I am once again repeating the names: Dr. R. Kasliwal, Dr. D.S. Chadda, Dr. Amit Khandelwal, Dr. Deependra Bhatnagar, Dr. Vivek Mathur, Dr. Bhavar and Dr. Prashant Devedi.
Thank you very much. And without wasting much of the time, I will invite the big man himself, Dr. Sameen Sharma, for his topic. Obviously, now he'll be talking on stable CAD, but I remember him as the greatest man almost 20 years back when I learned basics of rota, probably in 2003 in US. Now he has done a new case of orbital atherectomy today. So we don't have a better man to talk about all these interventions as well as stable CAD, Dr. Sameen Sharma. Now he'll be discussing the stable CAD, medical management versus PCI versus CABG.
All right. Have been a wonderful session, and I'm sure you all getting very enriched with the knowledge. And I'll try, my goal now will be in 20 minutes, is to show where we decide who get PCI, who is okay for medical management, and who are ideal or good candidate for cabbage, which we all know is a big struggle. You tell any patient you need a bypass surgery, they take 10 opinions to find someone who can do the PCI. But that's the real life. But what are the data to support? I'm going to show that here today. And then we have a live case of orbital atherectomy. So basically in two parts. One is simple, that which patient we call appropriate use criteria of American College of Cardiology, the PCI versus optimal medical therapy. So that's where the one decision is. Second decision, if you have complex disease, should you do cabbage, PCI or hybrid approach? So basically we know in the CAD, in the stable CAD, we are talking about not MI. We are not talking about arrhythmia, death and so stable CAD. So our goal basically is to reduce patient symptoms, ischemia, and of course what we do is based on how the patient present and the medical therapy. Our goal is simple, to make patients feel better. We are not going to decrease most of the time another heart attack or MI, or we prolong their life. Patient treatment for the stable angina is basically to make them feel better. Now I'll show you one case. This is back in 2010. This is a 61-year-old patient, came with angina, positive stress test, first time, was on just some medication, and we did the angiogram. You see here the LPL, which is the branch of the circumflex, everybody can see here, long about 85% lesion in the branch of the circumflex, other arteries are fine. And a patient has a normal ejection fraction. So what you do? In the past, when you have that kind of lesion, you used to put a stent. Question is, was that the right approach? So we know that majority of patients with stable CAD are treated by medication. And who goes breakthrough on the medicine or very unstable, they come to the cath lab to get a PCI or cabbage. The ratio PCI cabbage changes in every country. In America, it's a 3-to-1, PCI versus cabbage. In India, at one time cabbage used to be high. Now even PCI to cabbage is also about 2 to 3 to 1 here also. So basically, and then of course patients are on medical therapy. We have done a lot of trials to answer this question, that is PCI is advantageous over medical therapy in these stable patients. These are the few trials in the past and showed basically no difference in terms of death or MI. But yes, patient with the PCI felt better. Angina relief and better exercise tolerance. Then everybody remembers the COURAGE trial, which basically was maximum medical therapy against PCI, and basically you can say PCI almost lost it. Why? There was no difference in death or MI. Yes, it was repeat revascularization was better in the PCI group. And of course, they found within in subgroup, patients who have ischemia on the nuclear, they had the baseline and follow-up, PCI did a better job. So if you have ischemia, compared to medical therapy, PCI did a better job, lower revascularization, those were the findings. Since then, there are multiple trials have done, whether you have silent ischemia, manifest ischemia, all data are supporting PCI in some and others medical therapy, and many of them have shown that overall risk of death or MI not different. It's only the patients who live the more comfortable, less medication, and better exercise tolerance. Now you say, well, we have two syndromes, ACS and MI on the left side and stable CAD on the right side. Clearly, what we do is, because the mechanism are different, plaque rupture and MI, And death occurs patients with acute coronary syndrome. What happens in stable CAD? There's a supply and mismatched demand. And what you do in these cases, patient has chest pain or angina, rarely die. And of course, what we do with medical therapy first, while in the acute coronary syndrome, PCI first. And we also know that many patients with the stable CAD, medical therapy will fail and will require PCI. So they, to kind of guide us, the American College of Cardiology back in 2009-10, and then by Manish Patel, and then they have second edition 2012, and then there is another one in 2018, which I won't show you, but this basically gave us some guidelines. Which patient should get PCI? Everybody, otherwise you have a lesion. You say, well, it's an 80% lesion. How can we not do it? Because common feeling was that if now that lesion closes, patient will die. So that was the concept. So literature, all the trials, lot of experts sat down and came up with a simple, let's take the 4 factors. Patient symptoms, what angina class patient is, non-invasive risk factor assessment, low, intermediate, or high. Is patient taking medical therapy? They call 2 drugs, nitrate, calcium blocker, beta blocker, or renologine, and based on the coronary anatomy finding. To make it simple, we say let's give the color coding, right? The red, blue, orange, and green light. Simple. We put your patient in equation, whether patient has 1 vessel, 2 vessel, patient has what type of syndrome, whether patient is a medical therapy, ischemia, you say A is appropriate, U is uncertain, I is inappropriate. Don't do PCI in I. Basically means you have 1 vessel, patient has little symptoms, not on much medication, slight ischemia, even 80-90% lesion is not appropriate. Now you go to little more, patients have intermediate risk findings, then you see I become less. But then patients with the classical 4 angina, class 4 angina or severe ischemia, almost everything is appropriate or uncertain. So this was basically the start and some guidance that which patient should get PCI. So let's say this case. Remember this patient, mild symptoms, mild ischemia, not on anti-ischemic therapy, 2 of them. So this was inappropriate. While we are doing those PCI, why? Because data have shown you can leave these patients alone on medical therapy. We learned from the COURAGE trial. These patients do not die, do not develop myocardial infarction. What will happen? Angina may get a repeat PCI. So this was basically, so coming back to this patient, no PCI was done. My heart was broken back in 2010 because that's what we were doing until then. And of course, patients were discharged on medical therapy. We also learned from the COURAGE trial, 1/3 will break through on the medical therapy. So that patient will come back with angina and then you do the PCI. This, of course, as I said, a lot of patient, family, or everybody used to be upset on that. And then patient came back after the 2-3 months and then we did the PCI. That time symptoms were there, put 1 stent and patient was discharged home same day. So this is basically the, for which patient should get medical therapy versus PCI. And of course, aggressive medical therapy has been spoken quite a bit and so at that time they looked into the data. These were the data from the United States, ACC, all registry which we are part at our Eternal Hospital. The 12% PCIs were in I category of that red. And of course in New York, that number was about 13%, about the same. At Sinai, back then we were 3.7%. So since then, by education, this tells you that how we adopt and learn, become better. So then they have subsequent, those data came from various centers. So what happened is the inappropriate use of PCI continues to decline. So yes, some intervention came, suggested by the ACCHA, people followed it, inappropriate PCI numbers started going down significantly and so. So then, in addition to just looking at the angiogram, we have additional tools. IVUS, which is the angiogram here, then the intravascular ultrasound, then OCT, little more precise IVUS, then yellow plaque, which is the nearest, and more importantly, physiological test. What is the physiological test? You have some blockage. Can you predict, is it 50% or 80%, will it going to close and cause the trouble? And what we do is we give intravenous adenosine and look at the gradient across the blockage called fractional flow reserve. if the number is less than 0.8, means the lesion is troublesome, will give trouble, do the PCI. If more than 0.8, it assures that nothing will happen, leave the lesion alone on medical therapy. So this is done by various trials, FAME1, FAME2, and there are some data also that you do better with the FFR guided PCI because you put less stents. You put stent only which is necessary. Then second trial was that, you know what, since medical therapy is so good, what if the FFR of less than 0.8, we want to just give the medication and don't put the stent? Guess what? The trial was stopped after 6 months because FFR less than 0.8 have a trouble, unstable angina, in some cases non-QMI of 13% at 6 months on medical therapy compared to if you put a stent, that number was 3%. So big difference. So trial was stopped, FAME2 trial. So if your FFR is less than 0.8, medical therapy alone will not work. More than 0.8 is completely fine, and this actually a long-term data up to 5 years. The PCI, see the blue bar versus the red bar, the PCI better than medical therapy once your FFR is less than 0.8. Then we say, you know what, we're giving adenosine. Science keep going further to make it simple, which is how can we make this FFR simpler test? And that came up with the instantaneous wave-free ratio, that why not within that cardiac cycle of the contraction. So we have an area, is there a gradient somewhere which we can identify which will correlate to FFR? So IFR is the new kid on the block. So FFR we learned over the 10 years, for last few years, we have done the IFR, and there are multiple trials which have looked into IFR and FFR, both are equal. Advantage of IFR is no need for adenosine, very quick. And FFR number is 0.8, IFR number is 0.89. Less than 0.89, stented or surgery, whatever based on the disease, more than 0.89 medical therapy. So now, so basically as I mentioned, the goal of our medical therapy is basically, PCI is over the medical therapy that will clearly decrease angina and live better. So always there is a controversy, and I just want to show this slide. So they did Orbiter trial in Europe. Half of the patient who needed, who has a significant lesion, we say, you know what, we do the stent. And other half they brought to the cath lab, punctured the groin, but did not do the PCI. So it's the sham controlled PCI. So patient did not know whether they got the stent or not. And the trial was Orbiter and showed the primary endpoint was change in exercise time. And it did increase. So placebo had 11.8, 28.4 in the PCI group, although they needed about 26. So only improvement was 16.6. So clearly said that the PCI didn't work compared to placebo. So means this is just to say that what is the mental power, but it did make a difference in terms of the stress test, and so there's some positive, but then there were a lot of criticism of the trial. Why? Because after 6 weeks, after 3 months, every patient in the placebo group got the PCI. So we'll never know what could have been the long term. Maybe those patients who didn't get the PCI initially would have required PCI at 4 or 5 months later. Lot of data have shown that PCI does improve your functional parameters, circulation, and of course microvasculature, and increase the vasodilatory result. Now, same, the medical therapy comes back. The courage in the new role, and that is, let's take the patients who are ischemia on the stress test, moderate to severe ischemia, and now randomize them to the medical therapy or revascularization, PCI or cabbage. This was the ischemia trial by Judith Hockman, and these are truly the patients who have moderate to severe ischemia. And of course, invasive versus conservative, we always know there is a crossover happens in 25-30% of cases. Invasive, even in the conservative arm, and basically showed in this group, about 74 got the PCI, 26 got the cabbage, and outcome basically was the slightly better but non-significant. So overall negative trial. Again, another negative trial of the medical therapy compared to PCI. Means PCI lost again to the medical therapy. But then we always try to find something better. So say what we found basically, that patients who got the PCI had a less spontaneous MI. Total MI was not different. But key, that lesions which were probably significant, there was no FFR or IFR done in the trial. So probably those lesions which can create trouble, and those will do better with the PCI because less spontaneous MI, but overall trial was negative. And of course, Patient felt better in terms of angina class and so. Now there's another trial. So I'm saying that I'm an interventionalist, but I have to update you where we are. So we say, well, do one more trial. Patients who have poor ejection fraction, those who are ischemic but viable myocardium. This is the BCIS trial, revived, done just last year. Low ejection fraction 35, viable myocardium, randomized to medical therapy and PCI. You said this is the classical substrate we taught everybody. Your low ejection fraction is low, you did a stress test, viable myocardium, you did a functional test, and you can fix that lesion. Why not this patient will do better with the PCI versus medical therapy? And guess what? In this about 700 plus trial, patient trial, again, about 5-year follow-up, no difference medical therapy versus PCI. This completely changes the whole philosophy that where PCI should work. We are trying to analyze that what it basically is. Maybe very tough cases were sent for surgery, whatever it is. But overall, ideal substrate, ideal patient for PCI lost against the medical therapy, and these are the individual endpoints. We thought maybe the EF will improve. That also didn't happen. But definitely the patients have less MI, same, just like a ischemia trial. So now let's go to the second point. So we understood quite a bit, some controversy that where PCI really helps, but we know the PCI helps basically to improve symptoms and the quality of life and less medication. So this is another patient with a multivessel disease, 73-year-old, diabetic, multiple risk factor, ischemia, good medical therapy, and now has angiogram, which showing basically moderate left main disease and the trifurcation, and you see the disease in the LAD, and disease in the left main right here, then disease of the right coronary, so 3-vessel disease, and syntax score is 34, and I'll tell you what syntax score is. So question is what to do in this case, normal ejection fraction. Can you do PCI or you do cabbage? We have done many trials to answer this question. Now it's a complex case, medical therapy. It has gone beyond the medical therapy. There has not been trial of the medical therapy in these group of patients. And major trial was the syntax, and the trial basically looked into it. Every lesion which you have in the coronary gave a number. And they came with a syntax score of the low, intermediate, or high, 22, 23 to 32, and more than 32. And basically came up that if you have high syntax score, cabbage is better. Low syntax score, probably both were identical. And then we have the data up to the 5 years overall showing that in high syntax score, in the low syntax score, cabbage and PCI is equal, but in the high syntax score, cabbage starts getting better than PCI. So this was basically the syntax trial, which then became part of the recommendation. Then we did another trial with Dr. Fuster, the freedom, diabetic, multivessel disease, also show the same thing, mortality benefit at 5 years. So now questions say, these all trials were done with the old stents, and so what about the newest stents? We have the trial called Excel in the patients with the left main disease, the trial of the cabbage versus PCI. There was no difference in overall outcome, but slightly higher mortality in the PCI group versus cabbage. Then there's another trial which all the trials put together for the left main overall showed that the difference of mortality is about 0.2% higher with PCI per year. So in 10 years, difference will be 2% higher mortality, which is not significant. Rest of the, therefore, many patients with a less complex left main do equally well with the PCI versus cabbage. So where do we do cabbage nowadays? 3-vessel disease, syntax score high. 3-vessel disease, and there is a proximal LAD involvement if the score is 22. 3-vessel CAD in diabetic patients, and diabetic patient with proximal to mid LAD, and left main with high syntax score. These are the 5 group of patients which have shown by the data benefit of PCI, cabbage versus PCI. Hybrid, of course, you can do in some cases. So basically now gap has decreased significantly. So this particular case with the multivessel disease, high syntax score, was sent for bypass. I did the IVAS also, and the patient did cabbage times 4 and did well. So key remain, last trial basically again, I was now the FFR guided PCI versus cabbage, FAME3 trial, again disappointment. FFR guided PCI lost to the cabbage. Now question is why? We are trying to analyze again. So in earlier trials, we compared with the medical therapy, we did better. But once you did with the cabbage, data were the same. If your low syntax score, PCI was better. If your high syntax score, cabbage was better. So let me just sum up with my last slide. Basically, patient comes in, stable angina. We do some non-invasive testings. They're negative, patient get medical therapy. Positive, you did coronary angiography, less than 50%, you leave it alone. If tight lesion, patient get PCI. 40 to 80% lesion, you do FFR or IFR to decide. Patient who already have PCI, probably angiography, then go to the FFR decision making. Now, these patients, you did the angiogram, significant disease, high syntax score, multivessel disease, left main, goes for cabbage. Those otherwise, you do FFR guided PCI, those based on 0.8 or 0.89 PCI using the, and if it is less than, you do a medical therapy. If high, gets the PCI with IVUS and OCT guided stent optimization, particularly patients with complex CAD. The case which we are going to show today also will incorporate in that complex case with the, we're going to do orbital atherectomy. And thank you very much.
Thank you very much.
What we'll do it, as I mentioned earlier, that we'll have a time after the, I will come back, all three, our speaker faculty will be here, and I'll join them after we do the live case, and you will have enough time to ask. I'm sure there must be a lot of questions because we have a lot of students and of course many expert senior cardiologists here, but you'll have answer to the chance to ask your questions with the faculty.
So thank you very much, sir, for the excellent talk. And now we move to our next speaker, Dr. D.S. Chadda, and he'll be speaking on something different, that is cardiac rehabilitation. What's our knowledge, awareness, and practice among cardiologists in India? Dr. Chadda, sir.
Good evening, everyone. I, at the outset, would like to thank the organizers, Dr. Sanjeev, the dear friend. I'm going to talk about something which is very different. We are all, you know, a mixed crowd of interventionists and non-interventionists, but this, I felt, was a topic which is quite neglected, so I would like to draw your attention to it. Now, we talked about, Dr. Samin spoke at length about PCI versus medical therapy and why PCI is losing out. We get to see a lot of stent failure. And stent failure is very devastating for any interventionist. I'll show you a couple of cases. One is a 57-year-old male diabetic who had anterior wall MI, and he had regional wall motion. He had MPI, which was positive. We did the angiogram. It was a CTO LAD, two major branches coming out, diagonal and the septal from the site. RC had intermediate disease. We went ahead, crossed and stented this vessel. So we felt happy because there were two branches coming out. They did a good job. And see, 6 weeks later, the stent has closed down. You know, this is pretty a very unpleasant sight for anyone who's worked hard to open a chronic total occlusion. So we analyzed, you know, there are multiple factors you can put forward to analyze as to why the stent has failed. So these are broad factors which I thought I will apply to the given patient, and I added to this the column which is to the right of your screen called the discharge document. You know, the patient was a diabetic, he had chronic occlusion, he had long lesion, he had type C lesion, and there was a missing drug. Most importantly, what happens is that when the patient gets discharged in our setup, we don't see the discharge document, you know, and patient was discharged on a single antiplatelet agent. And this is what was responsible for the stent failure. I'll show you another case. So we finally optimized, we did a drug-eluting balloon and we salvaged the patient. Second was a 62-year-old female who was a diabetic again, had undergone a PCI to RC in 2019. And she had class 2 symptoms when she came back. MPI again done for class 2 angina was positive. RC angiogram in 2019, which was stented with a 3.533 with fairly good result. So we thought a good job has been done. And this was what was seen in 2020. There was an ISR and the stent
in the mid segment had failed. We apply again the same factors. She was a diabetic, female gender, medication, query under expansion, can't say whether stent was optimized or not. But yes, patient stopped the antiplatelet medication on her own at the end of 3 months. A very common scenario in our setup, because most of the patients feel that this is end of therapy. I have been stented, I have been given medication. Now when I go back, we have patients coming from different walks of life, so-called literate and illiterate both. I'm calling so-called literate because they know quite a lot and they have a lot of advisors available. So that's the problem. We anyway went ahead, debbed it. So I've given you 2 stent failure patients. There are multiple such patients which we encounter in our clinical practice. So what are the lacunae of the hospital discharge document? Well, the treating doctor very rarely sees or signs this document, and I can vouch for it. Each one sitting in this auditorium will agree with me that when you're working as an interventionist, you're most of the time in the lab and your assistants are signing these documents. What are the omissions and commissions which happen in this document? Listing of disabilities is wrong, you know. Many a times I get to see patients asking me, I have been labeled as a diabetic, but I don't have diabetes. You know, prescriptions are wrong. The dosages mentioned are wrong. If you've not written the correct prescription, you will obviously be giving an inappropriate disability-related prescription. Periodicity of review, not mentioned at all as to when the patient has to come back. So the patient is lost and so are the relatives. Drug interaction, and God forbid if he's got multiple comorbidities, drug interactions have not been considered. The relative importance of each drug has not been explained, and I can tell you that we must speak to them. If you put a stent, I think some of the cardiologists have a habit of calling the patient and telling them that you can skip a meal, but don't skip your antiplatelets. Duration of therapy and lifestyle modification is a distant thought. You know, you will not come to this level at all because you've not seen the discharge document, not met the patient, and how can you be explaining about lifestyle modification? Well, there are causes of poor results in practice. We keep comparing PCI versus medical therapy versus CABG, but these are certain things which you need to apply. You know, non-adherence to instructions. You know, you have to go back to the patient and tell him over a period of time again and again that this is important, this is what you have to do. But we don't do that. There is a lot of misinformation. You know, patient gets fed with a lot of information from Dr. Google, from the neighbors, from his fruit vendor or the general merchant whose store he visits. So there is a problem there. You know, he has to kind of brave and he has to come back to the doctor and ask him whether the information provided is correct or not. There is certainly communication gap, which stems from the fact that you kind of are not able to meet your treating doctor. Once the therapy is over and you're discharged, you cannot call back the doctor because the doctor is very busy. And you absolutely don't know when is my next review happening. And counseling, you know, there's supposed to be counseling in the hospital. And this is how the counseling goes. Counseling happens at 2 stages. And in most of the cases, it's ineffective. At admission, you know, the energy and everything is focused onto the patient. You will catch hold of the patient and his relatives because you've seen something that he needs to undergo an angiogram and I need to find out a lesion which I would like to stent. So you put in all your effort. So the counseling at the admission is pretty strong. It is long. It is multi-individual centric because a lot of people will get together and see what happens at discharge. We are supposed to meet this patient, tell him about the drugs, the compliance, how he has to handle his rest of life in terms of diet, exercise, mental health, smoking cessation. No, nothing happens. Counseling at the time of discharge is a morning visit by the treating doctor who tells him everything is fine, I put a stent, it's going to work absolutely fine. So it's as brief as this. Dr. X will sign your discharge document and then I'll see you in the OPD. Over. So, I mean, this I'm telling you, I'm honestly admitting that I also was doing this till recently, a couple of years back, and that's how our results are so pathetic. Can we improve? Yes, we can improve. You need to have a cardiac rehabilitation program. Now, what is a cardiac rehabilitation? It basically is a model which is designed to mitigate the great burden of cardiovascular disease. It's a multi-pronged attack on the patient where you have to evaluate the risk, educate him, You have to get him back to his normal life in terms of educating him, how much he has to exercise. It talks about drug compliance, smoking cessation. So it plays a very vital role. So the components of the cardiac rehabilitation are as given on this slide. There are certain additional components. You know, when a patient gets heart attack, the first question which comes to his mind is, why me? Yes, this has to be addressed. Why me has to be addressed. So he needs some psychological counseling. He has to be spoken to. Yes, it has happened. You were probably genetically loaded, or there were risk factors. You were neglecting yourself. So you have to overcome this. Now, if one enrolls in cardiac rehabilitation, I'm reasonably sure it will bring down the cardiovascular mortality. It will reduce the hospital readmissions. It improves, makes you mentally stronger. And it improves your metabolic profile because you will be compliant with medication. And this is what clinical studies have shown, that if you implement this is going to be effective, but world over the participation rates in these programs are very, very low. Let's talk about India. You know, in India, there is only one CR spot available for every 360 IHD patients. There's need for many more. I can't read the figure. It's in lakhs. You need so many. There are about 23 CR centers in the country. And when I started this program back in Bangalore, when I went to the director of the hospital, he says, I have a state-of-art cardiac rehab center. My only question to him was that, can you take out the data for the last 6 months? How many cardiology patients have visited this cardiac rehab center? The answer was 0. Nobody goes. Even I was not referring for that matter. So there is a lot of lacunae on the front of treatment, or in terms of holistically treating our patients. What are the barriers? None of the centers works to its full capacity. There are major gaps which are available, and especially in the northeast and the western region of our country. Of course, we are a developing nation, so we have lack of resources. There are certain areas where there is poor adherence to the therapy, and there are multiple other challenges. Some of them are listed on this slide. Poor referral, I think this is on part of the treating doctors. They don't refer the patients because they feel that they've reached the end point of therapy, and we probably don't realize that the disease is continuum and it's going to continue. There is limited availability also of these programs, and that is what translates into poor uptake as well as suboptimal benefits which patients draw out of these programs. So can we overcome all these barriers? I've listed a lot of barriers which come in the way of implementing a good cardiac rehab program. Yes, we can, by incorporating a cardiac rehab program in the discharge document. You tell the patient that, yes, you are being discharged, we've worked hard on you, we've done a complex coronary intervention, you get enrolled, at least you will be in our site and we'll manage you. We have to sensitize the patient much before the discharge. By just writing it in the discharge document will not happen. Someone has to sit with the patient and speak to him that the disease is a continuum. You need kind of modification of your lifestyle. And it has to be made taking his disabilities into consideration. You know, in India, we have very complex CAD, we have diabetes, we have CKD, we have young patients coming with multiple comorbidities. So, and the programs, we have multiple languages here, so it has to be communicated in the language in which the patient understands. There are multiple factors, but these are few things which I personally feel should be incorporated in any rehab program. Most importantly, if one can have a home-based rehab program, it will work wonders. No patient is going to come back to the hospital. So we kind of devised a home-based program, thinking that we are going to prevent a lot of comorbidities, or we are going to do a lot of good to the patient. It was doctor-led, and we introduced kind of home monitoring. It was a multidisciplinary team which started this. We focused on exercise, yoga. We gave a personalized diet to each patient after 24-hour dietary recall, rather than giving a printout of a stereotyped diet from the hospital which is available. Okay, you have CKD, okay, eat this diet. You know, patient doesn't know half the things which are listed on that diet, so you have to give a personalized diet to the patient. Habit cessation, very, very important. If someone is a smoker, you have to tell him at least 10 times in a month that, are you smoking? Please don't smoke. just at the time of discharge, telling him that don't smoke is not going to work. Psychological support, you know, if you've had a young MI, you would realize how devastated the individual is. He needs support, medication adherence for antiplatelets. We keep reminding them, and so is it important for diabetes, for hypertension. You know, if you're a diabetic, if you're not controlling your sugars, the game is lost. And certainly you need to educate the individual and more importantly the family. So if the family is not educated as to what the individual has suffered, the job is lost. So we've had the Eternal Hospital enrolled in this program, which was initiated by Newman Health. I was there right from the beginning when this program was initiated in Bangalore. So we introduced this program in the Eternal Hospital. And they have enrolled about 55% of the intervention patients. The accessibility has been good and it's been working. Now over the last 3 months, they have 95% complete enrollments which are happening. And 23 average number of rehab sessions in 3 months are being executed. A total of 473 patients have been enrolled from the Eternal Hospital. Now, what has it translated into? It has translated into 94% medication adherence. 37 cases of early symptom identification and correction have been done. So it gives an absolute ready access to the doctor. And 4.9 METs equivalent physical activity each patient has been. This is the average physical activity which each patient has achieved with 96% follow-up and less than 1% of acute hospitalization. Now, this is essentially a digital program which runs from the Bangalore. You have a software which can be downloaded in the patient's mobile, and the patient as well as the treating doctor gets to know as to what is happening. None of the medications is changed without the consent of the treating doctor, and the patient can send an SOS at any time which will be attended by the team which is based out of Bangalore. Well, the success story of Eternal Hospital, there has been an average decline of 0.6% of HbA1c with a blood pressure decline of 4.5 millimeters of mercury. So overall, what the profile tells us is that the patients are under close follow-up, their sugars and blood pressures are pretty well controlled or getting well controlled. They know what to eat, they know how much to exercise, when to exercise, and how they have to get back to the activity. Ladies and gentlemen, changing lifestyle is not easy. You know, it's easy said than done. You can just tell someone that stop smoking, stop eating, try implementing any one of the things which you like, that from tomorrow I'm not going to do that. So it needs a hard work. You need to work hard. And I must tell you that we must, as interventionists or as non-interventionists, rehabilitate our patients, which is very, very important. The hospital might have a rehabilitation center, but it is absolutely not attended to by any of the patients. And to conclude, I would say that we have a tremendous burden of cardiovascular disease, and putting stents or sending them for bypass surgery is not good enough if they are not eating the kind of medicines which they are supposed to eat, if they are not controlling their risk factors. So the missing link between the evidence, guidelines and practice probably can be filled up by cardiac rehab, which is very, very important, because you get to know your patient, you will be able to control your patient, and you will be able to see that the risk factors are well controlled, and it is a very, very cost-effective tool. The cost of coming back to the hospital for a re-intervention is definitely very, very expensive. So if one gets into a rehab program and implements it properly, you can reduce considerable morbidity and mortality of coronary artery disease. Thank you so much for your patient hearing.
Thank you very much, sir, for the excellent talk. And I would like to just add on this thing that DAPT combination and adequate doses of the drugs as well as the selection of the drug is also very important in rehabilitation, because we have seen even when we give patients on, we discharge them on ticagrelor, sometimes they are replaced by clopidogrel. Even we don't know what kind of brand and what kind of combinations they are getting. So please always educate your patient that they should be getting adequate drugs in adequate doses, and important importantly, good brands. That's again important. Probably ticagrelor and other important drugs are life-saving drugs. So we move to our next topic that will be covered by Dr. Makkar, that is leadless pacemaker. And as we will be heading for live case after this, I would like to invite my friend Dr. Jindal here because he'll be anyway chairing the next session. So Dr. Jindal, would you like to come here and take us to the next session, this as well as next session? Welcome.
Good evening. We know we are running late by 1 hour. So just a live inbox case. I think it was first case in India where a tower was done and followed by a leadless pacemaker implant in the same sitting. So we have recorded that case yesterday only. So first Dr. Prashant will take you through the tower process and then I'll brief you about the leadless implant. Over to Prashant.
Thank you, sir. Good evening, everyone. So, as we are already running late, so I will not take much time. So we will let's start with the case.
Eternal Hospital Jaipur is the most preferred healthcare center. Eternal Hospital Jaipur, where good care leads, good health follows.
PDA. Patient presented with recurrent acute decompensated heart failure, hospitalization. Patient had a 3 admission in last 1 month. Patient is in NYC class 3, class 4, and patient also had symptoms of exertional presyncope. Echo shows a critical aortic stenosis with a peak gradient of 88, mean gradient of 62, aortic wall area is only 0.3, and the EF is 50%. ECG shows baseline right bundle branch block with a LAHP, that is bifascicular block, with a PR interval is 0.20, and Holter also showed an intermittent type 2 2:1 AB block. Investigation showed hemoglobin of 11.6, creatinine is 1, ultrasound and LFT were normal. This is the ECG showing a right bundle branch block and the left anterior hemi block with a full PR. This is a Holter monitoring which shows a type 2 2:1 AB block. This is again type 2 2:1 AB block. So this is the prior graft anatomy. So Lima to diagonal and LAD and Lima to OM, PLV and PDA. So this is the CT analysis which showed annulus area is 288 with a perimeter of 61 millimeter, and the minimum dimension across the annulus is 17.6 and the average dimension is around 19.5 millimeter. If we look at the annulus and LVOT, The LVOT is, looks relatively large. It's a 65.4 23 millimeter evolute pro plus valve, and as the valve area, so these are the coronary heights. So left main height is 9.8 and right coronary height is 12.3, but not of much concern in the cuspal overlap view. These are the calcifications. This is a moderate to severe calcification. So we are planning to go with the right side axis. These are the arch and abdominal aorta, showing the significant calcium at the level of arch as well as the distal abdominal aorta. These are the challenges. Patient is had advanced age, that is 84 year, non-CAD, prior bypass, area of 0.3, bifascicular block, intermittent 2:1 AV block, which requires a pacemaker. Patient has a small annulus, relatively large LVOT. On the CT analysis, our 23 evolute pro plus valve looks fit, which will be 19% oversized. So our plan will be, we will do the procedure under conscious sedation. Our main axis will be the right femoral artery with 2 proglide. We will take other 2 axis, left femoral artery 7 French, 5 French. For the left femoral vein 6 French. We'll do the CAG to assess the graft vessel. We'll do the pre-dilatation with 16 millimeter balloon, and we'll deploy 23 millimeter evolute pro plus. And will after the tower ball deployment, we will go with a leadless pacemaker implantation in the same setting as the patient has a baseline indication for the pacemaker. So we took the left-sided femoral vein with of 6 French venous sheath, and then we took a left femoral artery 7 French long sheath. So and then we advanced the sheath, and then we went the up and over and to delineate the iliofemoral on the right side. Then we advanced the 018 wire, which will be our safety wire as well as a landmark wire for the procedure, which will gives us an idea where exactly is the femoral artery, and in case if there is any catastrophe after the procedure, if there is any dissection or any bleeding, we can easily manage it later on this wire. So this is the temporary pacemaker, balloon tip pacemaker, and for the leadless pacemaker with this sheath after the upgradation. So this is the axis we were taking. So for the axis point of view, we always need to take the axis at the mid femur head or the femoral artery. Next, please. Then we took a coronary angiogram. This is the left coronary angiogram, which shows a significant disease on the left system. Next, please. This is the right coronary angiogram. Next, please. And these are the this is the graft vessel angiogram, which shows the patent lima to diagonal LAD, OM, PLV, and PDA. So we are here now.
And these views basically are selected after the CT angio. CT, yes. You get the direction that what should be your view. So okay, so we are ready to start now. Now we are going to the AR2 and to cross the valve, and then of course to the balloon valvuloplasty. You want to go to little LAO view?
Yes, sir. Go to LAO. Now,
okay. Okay, step tripterumo. And usually go with the AR2, and of course, if the dilated aorta, if you are trying to use a large, if you are trying to use the large valve, then you go with the AL, but otherwise AR2 works very well.
Go to RO.
Yeah.
See, that was very easy.
Yeah. So basically, goal will be now first the exchange length wire, get to the apex, and then bring the pigtail, then change to the confida. Right?
Yes. Little more RO, please.
Very good. At the apex. Good. Very good. Yep. You want to just show the hemodynamics?
Yes, sir.
Based on the echo should be more than 60. Yep. Look at that. It's an 80 millimeter gradient. Good.
Yes. Flow safe. This.
Yep.
Hemodynamic safe.
Yeah. Mm. Now we are changing this confida wire, which comes with a pre-shaped, good stiff. There are two of them, safari and confida. If the LV is very small cavity, you go with the safari, otherwise confida. Those are the two pre-shaped wire. There are many other advances happening. Good. Okay.
Pacing 150. Now LO. Come to LO. We need to see the arch, because we don't want that our valve erode the outer curvature of the aortic arch.
Keep going. Good. Okay. Magnify. Good.
RO 16 cranial 4.
come back to the non-coronary transfer.
Inject.
Okay.
Okay, I'm giving tension.
Yeah.
Looks good. No effusion. Look at any paravalvular leak. No leak. No, nothing to do. Wire.
It's okay. So depth is also okay. Yeah.
Oh,
This is
very good position.
Yeah.
Yeah. Go. Good.
Going to follow this up. Hello. Yeah.
1 second. Yes.
क्या हुआ?
Inject.
सर को लगाओ जल्दी से. सर के लिए एक.
Very good.
Yes. हाँ.
Good. The case has
You
been
can have
completed now,
filter pine cross
and
दे दो.
we had both sides
No pine cross.
devices deployed, no bleeding at all, and was very exciting. Case no gradient, no paravalvular leak, and patient is responsive at present, and of course we need to watch another 24 hours. There is a part 2, knowing this patient
we have to make a big
set up for the heart block, because already had 2-to-1 heart block on the Holter monitor, will undergo now the micra by Dr. Jitendra Makka.
Yeah.
And thank you very much. Hopefully, a lot of points will be made in this case from educational point of view. And so I really.
Now I would like to ask Dr. Makka to proceed. Thank you.
मैंने सर एस्कॉर्ट्स का भी जो ग्रुप है ना उसमें भी डाल दी.
So this is a recorded video of what we did yesterday, the micra implant after tower.
Yeah.
Here and to this patient who has undergone beautifully the tower implant by our structural heart disease team led by Dr. Sameen Sharma and Dr. Prashant, Dr. Sanjeev and Dr. Prem. This patient had 2:1 AV block on the Holter beforehand, before we planned for the tower. And now after tower, she is completely dependent on temporary pacemaker. So there is no doubt about the indication of a pacemaker
okay.
here. But now the question is why micra and why not a dual chamber?
Don't save it.
So we are implanting micra AV, which ensures sequential rhythm, atrial sensing and ventricular pacing. And micra we are implanting because the same indication as tower. Patient is a very old lady, fragile, low weight, very sick patient, high risk for the lead-related complications like pneumothorax, hemothorax, and lead-related infection. So after discussing with the family, we decided for the leadless implant, and we decided for sequential AV, sequential micra in this case. So right now, till now, what we have done is we just taken an 8 French sheath access to the right femoral. Right femoral is my favorite to do the micra, but it can be done from left femoral and upper extremities also. But right femoral being directly aligned with the SVC, that becomes the most easily approached access. So what we have done right now, we have put a hard wire, emplaza hard wire here, and dilate the femoral access. The arterial access just taken from the same side has been closed by ProGlide, and now we are taking, so this is basically a 27 French outer diameter sheath of the micra delivery system, so for which we have to dilate this femoral access. So right now we have taken this 12 French, and I'll dilate the femoral access, which is a very simple procedure done for many cases here.
Yeah, sure.
So it is always best done under fluoroscopy.
There's a lot of calcium.
So that you are not end up damaging the vein in an old lady. So once we are
little bit on side
done with the 12
calcium in a bit part, and
now we'll take the
या
Now
कैमरा करना पड़ेगा इनको
big procedures are being done
because
without any major cuts on big.
आपको जब बोले ना तो ये
So it
आईवस
is
पे
good,
फोकस करना है ना
tough
कैमरा को
and
हम जब बोलेंगे
easy.
आईवस तो then you have to show this है ना pull back
This is the sheath for micro delivery. So this sheath
yeah
will
I'm
take
going
up to
oh
IVC-RA junction, and
okay
this is very hydrophilic. So we have to wet it
yeah
and then hold with it a piece of
body weight is
gauze.
47 kgs so which we
Hold
have
the
given a
wire.
5000 heparin
Yeah, under
ACT
fluoro. Yeah.
okay good if we loaded the
So
Plavix and just because
yeah, fairly easy. Show me the wire up in the SVC.
slides display होगा
Yeah,
वो
it's
screen
okay.
का where is the screen so slides will be visible here no
So
initial
it is
slides
easy to take back the sheet, so we can little bit advance
आईवस
in
तो आ
the
रहा है
RA
हाँ तो उसमें पहले
because it is
वही लगा दूँ
difficult to advance without a
initial
dilator.
slides
So even if it is in the RA, we can always take it back. So I'll keep it here at the IVC RA junction. So
कहाँ से आ
now
रहा है
we'll connect
क्या बात
heparin.
कर रहे हो लाइव इसमें तीन कम से
So
कम
we have
तीन
to
से चार
flush this slowly so that there is no air bubble left in the system.
नहीं तो राकेश से पूछो
So as you can see, there are three knobs here on our delivery catheter. So one knob is to retrieve or to push the leadless pacemaker out of the
कहाँ से ला
sheath.
रहा है
So I am right now I'm retrieving into it and will release once it is inside. And second is to flex and
this
extend the guiding catheter so that we can proceed into the right ventricle towards septum. And
हाँ
then there is
उज्जवल चोपड़ा
locking and unlocking
उज्जवल
system
भाटिया
for the thread which is
उनको
attached
नीतीश
to
को बोल दो
this
इमीडिएटली इसको
micra.
फोन करें
So
और टीम
this
अभी रवाना हो जाए ताकि सुबह सुबह तक पहुंच
lock,
जाए अभी बोलना पड़ेगा
it unlocks or locks the thread to make it stable. So we keep it in the lock position until we deliver the catheter. So
ऑन द वे
these
जल्दी
three
बुलाओ
knobs are out, these are used. So once micra is inside the guiding catheter, I am again de-airing it by flushing with normal saline. So it's come in the RA now. So what we'll do is, we'll flex this.
11 box is going on
Yeah, we flex
11 box
this
yeah
and go
I'm
to
hearing
the
with a faint voice
RV. So now it
not
is
clear
going towards RVOT. But the ideal location is to implant it on the mid septum
they've reduced the
because on
volume
apex, so we'll have to do full left lateral.
हाँ
We'll
जल्दी
try to go
please बात
towards
करें
mid septum here. So this is RVOT, little bit flexion. Here like this. Yeah. So this is septum, and you can see that
now
this
we can have
sheath has taken a little bit upper mid septum. That's a
कितनी
fine,
देर
good
की दवाई है
location. So now we'll check it
अभी तक क्या
with
करेंगे
contrast. Meanwhile, we can check LAO position, LAO 30. So in RAO, you see a gooseneck, and LAO, it is pointing towards spine. So that looks like a septal location. But we have to confirm this with
ऑडियो इज
left
देयर ना
lateral position
सुनने में आ रहा है
also.
आप सब सुन रहे हो
So the only issue
आ रहा है ना
here in implanting micra is to avoid cardiac perforation, and you have to be very gentle when you are inside the RV. So now, so thing to look at is that in left lateral position, the micra will look towards you anteriorly. So that's fine. I think we can go to LAO now. So you can see that this is well embedded into the endocardium. Similarly, we can take contrast shot in RAO. So there should be little bit pullback sign when we inject the contrast. The micra should come
first
little
we'll have
bit
our
back.
hospital video
Okay, so I think this is fine
and
location.
then in between if we have
Yeah,
time
so
then we'll
now
do
we
run the
can,
orbital
we should unlock this
atherectomy video first or first we
and
connect
then
and show the
release
case
the micra.
hospital video होगा
Yeah. So this is
Yes.
how we release. What we do is we'll just
and then we'll do
pull
yeah
this back,
yes
the blue button to release the micra and pull the sheath back. So now we'll do the tuck test. So tuck test is done in maximum magnification just to see how many tethers you see moving.
basically
So I think all four
डिसाइड नहीं किया सर
are
पहले
moving here.
जो जेटेक जब
Go
आया
to
था तो उन्होंने
LAO.
मुझे तीनों से
So you
कराना है
can see the
उसने बोला कि मीटिंग आई एम
fanning
डूइंग होल
away
मीटिंग आई एम
movement
डूइंग
of these
आई डू द लाइव ट्रांसमिशन
retinol times.
we don't know already the
Yeah,
professional
this
people are
again
there
in LAO
उन्होंने कहा I
position
will do
will
it I
check.
have done in the past
Yeah,
समीन
so
सर ने
you
भी कहा था
can
कि वर्ल्ड क्लास
clearly
ट्रांसमिशन
see
होना चाहिए earlier we have
because
transmitted
of this
with
tower
his
well, maybe you can go
logistics
little bit
to one
less
of the
LAO
meeting structural we have done it
or
so
maybe okay.
Dr. Samin
Yeah,
also
that's fine.
approves for
That's
it
fine.
and because they
So
gave your
yeah,
name
see
कि
you.
बोले मैं
So
पहले
you
कर
can
चुके
see
हैं
at least
मैं
3 of them
it's okay
moving very well. So now we'll check the.
now it's very clear we
You're
will not
okay,
allow
satisfied?
them to do anything
Okay, now you check the threshold. You're okay gently so that we do not pull it out. So right now there gently TPI rate, where is temporary pacemaker? Yeah, reduce the rate to 70. So that is the advantage of putting it on the septum, it on the second 0.4. Then it would be second 5. We have to cut this thread. So we have to cut this thread here. So once I have
little
cut
bit
this
of
thread,
nitro
then micra is not
slow
in
flow
my hand now. So once I start pulling it,
because of wire there is slow flow
so this
nitro
will
nitro
slowly we have to pull it because it can, and ideally should be done under fluoro, that you don't end up pulling the
fluid is going
micra.
on
So very slowly
fluid चलने
we
दो
have to pull this thread. Once the other end crosses the tip of micra, then it will be free movement. But till then, we have to be very slow. Yeah, because this can actually sometime cut the papillary muscles of tricuspid valve. So we have to, that sheath should be as close to right. We have to slowly. So that's what we wanted to show you here, that how simple and convenient it is to put a leadless pacemaker without any mark on the chest, without use of any leads. And to my
अगर
surprise
टाइम लगता
also,
है
when
तो
I
मेरा खोल
started
के सर्कल लगा दो
implanting,
और
I
मेरे
didn't
को यहाँ
believe
पे माइक
that
रख लेंगे
it
वो
is, it can
स्पीक
last
में
up
माइक
to
हो
10 years, but
अगर
now since my oldest patient has spent 6 years on micra, it is still showing battery of 5-6 more years. So I think that's a very good news that battery is not an issue, and threshold is also not an issue in chronic time, in long term, and also in good contact with the endocardium. This is our feedback, and thank you all my colleagues here. I think the team has been introduced earlier also by the structural heart disease team. Thank you very much once again.
All right, ready?
So
Bye.
greetings to everyone from Eternal. Thank you very much. So that was about it. So maybe
Yeah, it's
me and Prashant are ready for any quick question, because I think live case is ready there.
हाँ
Back
ये
at
तो रेडी ये तो सर कैन
it's a
हियर
very good
सर को एक
case
माइक दे
for
दो
demonstration of how we follow it. Thank you.
अरे क्या नाम है आपका
This is a
माइक
well
लगा
sense. It's a it
ये वो माइक ला दो हाँ ये माइक तुम यहाँ पे देख खड़े
So this is AV
इधर आ जाना
sequential
क्या देख रहे हैं
micra, which basically the structure is same. The only thing is that it senses the atrial mechanical contraction. So when we check this, the sensor gives different phases of atrial contraction, and we have to find the best the sensing that you can't say it is electrogram, but it is a mechanical sensing. So we have to best take the best indicator and coordinate it with ventricular pacing. So I think 60-70% of the time it gives sequential pacing, 30-40% of the time not. And on higher heart rates, sequential pacing is not possible. More than 100 heart rate chances are very less, because it is not an electrogram sensing.
Very nice implant.
Hello.
In my experience, if you do a lot of pull and hold and then check the thresholds, they shoot up.
Yeah.
So I generally avoid too much of pull and hold, because in the early implant days, we would do check in different
All right,
intervals.
guys,
You see the
we
time
are already here.
on the body. You are reasonably
Hello.
Once or twice.
Yeah, can you
Once or
hear us?
twice, not more than.
And how about the threshold? I mean,
Hello?
there are instances when I've left the thresholds of 2 to 2.5. The very next day they come down to 0.2.
Yeah,
So
so
that is another important
Hari?
what's your experience in this?
Yeah, so you're right. If there is increase in threshold because of the myocardial injury, it
No,
takes
that is
more
okay.
time than a
But-
screwing lead. So you can't wait there for 1 hour. But if you are satisfied with the
Chennai to-
position, but I think more than 2 is little bit
They should be
risky
able
to
to hear
keep.
us, only
So
sometimes.
we can take one more chance, retrieve it and implant it elsewhere. But generally we
they are
get
not connecting
threshold
us
of less
to-
than 1.
So
They need to connect us
on
to
one
the
of the
Marriott, no?
patient, I suffered
Oh,
this
oh.
because in the early stages, I did a lot of pull and hold. And I
Yes.
kept re-implanting from apex down this, that, and I kept changing sites. Threshold just won't come. And there's a very nice paper which talks about this, that you can safely leave thresholds up to 2 and they will climb down. The more you do pull and hold, the more you traumatize. The
Yes,
more
it acute rise in threshold is there. Of course.
Nice case.
Okay. All right, Jitendra, can you hear us here?
So we can invite the live case में है.
Hello? Yeah, you can hear us?
Right, so this is going to be a live one. We request Dr. Deepak Bhatt, Dr. Ajit Bana, Dr. C.B. Meena, Dr. Rakesh Jindal, Dr. Ankush Gupta, Dr. Milendra Srivastava, Dr. Deependra Bhatnagar, Dr. Vivek Tandon, Dr. Atul Kasliwal, and Dr. Prashant Devedi for chairing this session, which is going to be a live case on orbital atherectomy.
Okay. We can ask Dr. Deepak Bhatt also there.
Yeah, he's there. So Dr. Bhatt is there on the panel. Hello everyone, can you hear us?
Yes, Dr. Sanjeev sir, we can hear you very well.
Let's make a little loud volume.
Yeah.
So I know we are quite slightly late, but I call it when you are having fun, who counts the time, and has been a phenomenal day, and it's just kind of grand finale of the day. Before you have some question answers with the faculty. I hope can you hear me very well, because I know we are very primitive. We are using the microphone, and so, but we are ready to show this live case of orbital atherectomy. So can you hear us? And I know Dr. Deepak Bhatt is on the panelist also.
Good evening, sir. Sir, I think volume is not enough. So
Sir,
please.
Dr. Milan.
We are not.
Yeah, now you can hear me?
Yeah.
Hello, Dr. Milan. Hello, Milan.
Yeah.
So
now it
your
is some.
Audio is okay? Are you able to hear us?
Now you are audible.
Good. So let him speak. I'll be the silent partner.
Sir, it is always privilege to see you working live.
All right.
There is a lot
So
of
our
learning for
cath
all
lab
of
staff,
us.
we welcome everyone from the cath lab of Eternal Hospital, and we are ready to showcase a very exciting, remarkable device, which will be done 5th case today. We did the first one. 3 others have been done other places today, and this will be the 5th one. We can show our slide, please.
Sorry, the hospital video.
Yeah.
EFCC
Start.
video.
Let's start playing. Good. Okay, playing. Go.
Video is playing?
No, not visible yet.
EFCC video, please.
No, not CSA.
Not the diamond band.
Not yet. No.
Not this one.
Not this one yet. No. Okay. If not, that's fine. Okay, let's go to the case now. Can we show the slide?
Right.
Okay, can you show the slide, please? Okay, now
Yeah,
we're
now.
playing.
Yeah, okay.
Okay, good. All right, so this is the case. Myself and Sanjeev will be doing it. Next slide. You have the patient history or not?
Yeah, this is the history. So go to the next slide.
Good.
Yeah, the case is a 75 years old male who is a non-diabetic, non-normotensive, higher lipids, and non-smoker. He presented to us with a history of progressive angina on exertion for last 2 months and more so for last 5 to 7 days time, last 3 symptoms. On the basis of his symptomatic status, he underwent angiogram. And next slide, please. Limits, no significant SCT changes. Echo showed no regional wall motion, nominally function, normal PA pressures, no matter regurg. So treadmill test was positive. On the basis of symptoms and the positive treadmill test, he underwent diagnostic angiography. Next, please. Yeah. Yeah, run. Yeah. Click the angio. This is the LO. Yeah, this is the AP caudal view, which shows us a tight disease in the circumflex and the epicranial. There is a long segment proximal to mid-LED calcified lesion, and there is a band also in the mid segment for the LED. And we have to consider band when you go for the orbital atherectomy. You have to be careful. And RCA also has a moderate disease in the mid segment, close to 70–80%. So on the basis of this angiogram, we discussed with the family about the reverse strategies. But because patient is just 45 kgs and age is around 76 years, so it's a very high risk for surgery. The family refused for the cabbage. So we have planned for the imaging guided orbital atherectomy for the LED as a first stage, and then we'll be doing the circumflex and RC as a second stage.
Okay, show the angio of today.
Yeah.
Okay.
Angio of today?
Yeah.
We will show you.
Yeah.
This is the AP caudal view, and go to the cranial view.
It now.
Connected to the, our cath lab. Audiovisual is connected to our cath lab.
Good. Yeah.
So we want to see the cine on that screen. What we are doing now. Yeah.
Okay.
So this is the AP caudal view, which shows the circumflex disease close to 70–80% in the proximal and also in the OM. And already has a mid to proximal segment tight disease. Go to the cranial. Next view, please.
Yeah.
This is the epicranial view where a tight disease close to 90–95% in the proximal segment and also in the mid segment after diagonal and with acute band.
Okay.
So it's a calcified proximal to mid LED.
And show the IVUS also now.
Yeah, after
Why am
diagnostic
I
angio, we did the IVUS pullback. So you can see the IVUS pullback in the small window. This is the mid LED now. This is a plaque, fibrotic plaque. The calcium from 9 to 12 o'clock, the heavy plaque burden. There is a echo dropout, now close to 180–270 arc of calcium. And here from 11 to 3 o'clock, 4 o'clock, there is a calcium bar and there is a drop in the echo. And we are coming to the proximal segment. Now it's a close to 270 arc of calcium, tight lesion. And then there is a fibrotic lesion in the proximal segment. As we come to the proximal, this is a tight lesion and there is echo dropout, close to 270 calcium again.
So very calcified, long segmental, proximal to mid LED disease. So let's go back to, now we have the video. So question is what you do with this calcific lesion. We always have been doing the rotational atherectomy, but now we have the new device just introduced today in India. That's the orbital atherectomy. Actually, we call it a rebirth of orbital atherectomy because first 50 cases of orbital atherectomy were done in India back in 2004, 5, 6. And that was the Orbit 1 trial. So, but now after the clinical launch, it's the first time here, and we can show the mechanism of this device, which will be a little different than what we do with the rotational atherectomy. So, please show the orbital atherectomy video. Yeah.
Run it. Yeah, audio is not there.
No, that's okay. Yeah. So basically, just rather than on the horizontal axis, also on the vertical axis, it goes into the entire, you can say, sphere of the vessel. And it's a speed dependent. Higher the speed, there are two speeds, 80,000, 120,000, and do a more better ablation. So with that note, start the flow. So we are ready to show this device now. We can go back to the live fluoro. We are doing the procedure now. We can stop the video. Good. So you see this, we advance the wire over using the feet because the wire is 0.012. So it's a not exact advanced, but otherwise in a complex case like this, we will go with your over the wire system, your workhorse wire, and change it to the orbital wire. And this is what a little the Viper wire flex. So which is basically is a little softer wire, but hydrophilic and better takes away the tortuosity. So earlier Viper wire has a trouble because of the stiffness, making the pseudo lesions and wire bias, and this one is a better wire. So that's the only wire. There are 2 or 3 different wires, but this is the only wire being introduced here in India. So now this is you're seeing our on one side. Yeah, good. So this is the basically the whole assembly, and all the knobs are right here. Basically the brake, speed, and this is advancer, and wire comes out from the back, which is 0.012. So these are the speed, 80,000, 120,000, and we are already prime it. It comes with a Viper slide, and basically we are ready to start push and pull, because it's a long 325 centimeter wire. Yeah, so we check the speed again. So basically before going in, you check the speed. Sorry, yeah. The motor will only run when the brake is on. Good. We are ready to start. So basically just had to check the speed. The device is functional, and we are going in. Sanjeev will be advancing and push and pull. Yeah, keep going. If the wire comes back, you just slow down. So basically it's a two-man, it's not a monorail. So it has to be a coordination of the two people. So back and forth. If the guide comes out, that means he is going too fast. And if wire comes back, that I am pulling too fast.
Very easy with the coordination. They're going in.
And we'll go through the technique issues, which are a little different. What I know many of you have seen the rotational atherectomy. That was the only device available until now. And actually,
lesions.
Good.
Now we are going in.
So once you are here, so this now we are ready to start brake, press again, and then this is the advancer, and Sanjeev will start now. Okay?
Yeah.
Start. It's a very slow speed, 1 millimeter per second. Slow advancement, but you can continue, go forward. Different than rotational atherectomy, where you do a packing. Go, come back, go. Here you can constantly go, as long as your vitals are good, no hypotension, no arrhythmia. You can gradually go, and it's a 25-second cycle. So you need to have time that. Start pulling back, because it's going to make a beep. Yeah, see, pull back now. Good. So as you saw, that eccentric crown, so it will basically ablate the plaque. They call it sanding. The device, compared to the drill or burr we call, here they call it a crown. And it's an eccentric, so on both sides. So going forward and backward, it will cause the sanding of the plaque. Basically, that's what is happening now. And even if you cross it completely, you can do 2, 3, because then it will go into a different part of the vessel wall. Basically, arc of the vessel. Yep. You start pulling back. So it will always happen anytime you don't push, you come out of the lesion, it will little jump. But that's a normal process, but has to be 1 millimeter per second. Yes. And try not to leave the crown in the lesion, because we all learn that causes spasm, blocks the vessel. So it should be proximal. And now when you're and now start here, same 1 millimeter.
Hemodynamics are stable, patient is pain free, and this is the advantage. You don't impede the flow. So that is
Good.
keep on playing with the
Keep pulling back.
orbital.
Yeah.
So going forward and coming backward. Stay forward.
So now everything is good. So do two more. So we have crossed the lesion. Now you don't need to go after that. Just proximal to until there. Just do a back and forth. You call it a polish run. Good.
And we have to be careful on the band part. Huh?
Yeah. So there are a few techniques which are being promoted. So I'll not confuse at this time, but basically just go forward, continue, go all the way back. Come all the way back first. Yeah, good, good. More back. Yeah, good. And do last one. One more. Patient tolerating hemodynamically quite well. All the trials data has shown that compared to the rota which caused lot of slow flow, the slow flow incidence is less than 1% in orbital trial, orbit 2 trial, which made the approval of the device. So once we are done, once we are done, brake release, and it's 80,000 RPM. Now, there is another 120,000 RPM which I suggest not to use it because that's because at 80, even in the vessel size of 4 millimeter, it's a very effective device because quite a bit of deep plaque. Start pulling. You pull. Yeah, yeah. So 1.25 is good enough. Very rarely you go to 120. So I can tell you at Sinai we had not used 120 probably in last 4 or 5 years. In the beginning we used to, but we learned that little more trouble happens with the 120, which is the fast speed and yes, more effective. But the 80,000 gives you lumen about 1.7. It's a 1.25 crown, but gives the lumen about 1.7, and that's good enough. So with that note, while we are taking some pictures, we can ask some questions from the panelists, and I know Deepak is there. He can tell his experience of rotational and orbital atherectomy in Boston. Yeah.
Yes, Samin, are you able to hear me?
Yes, we can hear it.
Terrific.
Yeah.
Well, first, before commenting on this case, I have to congratulate you and the whole team at Eternal Heart Care to have done the first case of orbital atherectomy in India. I think it's really a great day for not just interventional cardiology or even cardiology, but for medicine in India to have brought this important technology here. So congratulations to you and your entire team on achieving that really important milestone. As far as this case goes, really this is an excellent case, I think, to choose to do orbital atherectomy. The intravascular ultrasound, which I think is quite useful to confirm the specific location of the calcium, the degrees and arc of calcification, whether it's intimal or adventitial calcification. So I think imaging is really useful preceding any sort of consideration of atherectomy. And here, clearly, the IVUS showed very severe calcification. I think to try to do this sort of procedure without rotablation or orbital atherectomy or shockwave would just make it a much longer, more complex procedure. So I think some sort of technique to deal with the calcium here is warranted. And historically, you're right, it would have been rotablation. But I found that orbital atherectomy really, in the vast majority of cases, has replaced rotablation. About the only exceptions I can think of are maybe for ostial left main or ostial right, I will still use a rotablator because there's a slightly higher risk of aortic dissection from using orbital atherectomy. But other than that, I pretty much have abandoned roto and gone with orbital atherectomy.
Dissection.
Some important differences that you mentioned, I'll just emphasize again for the audience. Rotablation, you just can ablate as you're moving it forward. Here with orbital atherectomy, it is cutting as one is going forward or sanding as one is going forward, but also coming back. And I think that makes it less likely that the device will get entrapped. You know, with the rotablation burr, every now and then, if you're unlucky, especially if you haven't done a lot of cases, it'll pop through a very tight lesion and then be trapped, which is really a very difficult situation then to deal with. That's much, much less likely with orbital atherectomy because it's sanding going in and it's sanding as it's coming out as well. Though still, as Dr. Sharma said, very important to not just leave it parked in the lesion. That is, go through the lesion and then come back to an area that is safe to park the device in. So really a great example here of where orbital atherectomy can be so useful. The other thing I'll mention too, and I'll be interested, Samin, to see if you agree, with rotablation, oftentimes, say in a circumflex, a wire bias sort of biases the rotoburr away from the area you might want to actually perform the atherectomy. Here, I think wire bias is less of a concern because of the elliptical cutting motion of the orbital atherectomy. Would you agree with that point?
Absolutely, yes. And one of the, actually they interviewed me today, knowing that you are the great rotablator guy, what's the difference with this device? Knowing that having used both, we do about 65, 70 cases of atherectomy at Sinai. It's 75-25 split, 75 rota, because that's what a lot of people are tuned to and using it.
Yeah, I think for people that
the simple.
For people that like to use the rotablator and are comfortable with it, it'll be very comfortable to transition to orbital atherectomy. And for people that haven't done rotablator, I think orbital atherectomy is much simpler in terms of the setup. That is the cath lab staff, your techs, for example, it's much, much easier to set up the orbital atherectomy. I think also from the operator's perspective, the interventionist's perspective, it also is nice because you don't have to hook it up to a tank. You're not really dependent on your cath lab staff knowing how to set up the rotablator, where, it's not difficult to do, but they do need to connect it to the tank and know which line goes where. With orbital atherectomy, essentially the device is entirely on the cath lab table, and there is tubing that goes to the console, obviously, but I find it much quicker and easier to set up than the rotablator, especially for labs that may not be as comfortable with atherectomy to begin with. So really, other than the caveat I provided about left main or RCA osteal lesions, I think the vast majority of cases that one had been doing with rotablation can now be done easier and more safely with the orbital atherectomy.
Absolutely. So key is the simplicity and two important things. One, of course, simplicity, and second, the slow flow. Anyone with a long lesion, hemodynamic compromise, borderline hemodynamics, OA. But as Deepak pointed out, the majority of time, you can combine both of them except the aortosteal lesions. You prefer rota, but otherwise both could be. But simplicity of the device, the technique compared to rota, it requires a lot of learning curve and technically challenging. So this is one of the good advantage. Good. Further. Good.
Sir, what about the tortuosity? If you have a tortuous vessel, can you go for this?
It will be the both of them with this new wire now, even in
Yeah.
tortuosity. Means yes, tortuous lesion will give rise to 12. No, 12, 14, 12. Yeah. So basically, tortuosities are, even with the rota, 14, negative. So see that the rota score, that which case you'll fail with the PTCA, and that came from both prepare calcium and the Texas, the trial. So key is that tortuosity is a trouble for both, but now with this Viper wire flex, it is a very, I would say, hydrophilic. Of course, you trade off the stiffness, the support, but advantages, those which we used to see in the tortuous using the old Viper wire 0.012, it happens less. So this is where key is the tortuosity. Yes, if you want to avoid using any of the device, if possible, but if you have to use it, I would say now with the Viper wire flex has become the choice. And of course, in the past, it used to be our the rota on the tortuosities now. Go. Okay, this now we are taking the picture now. Good. Go epicranial. Yeah, there is a little slow flow.
Slow flow, just down.
Yeah. So let's get a diagram. Pull back the.
Go to the cranial.
Yeah. Our camera is giving a little tough time. 10 years. This lab has been 10 years. Yeah. So key is that once you develop slow flow, which will happen in the long lesions, but comparatively lower with the orbital versus rotational atherectomy. So this particular case, and now also always, if it happens, you can use a stronger antiplatelet therapy. Let's dilate first. Yeah.
Yeah, as you're thinking, I think that is a
Take a
great
picture.
point.
Yeah.
You know, if you
Yeah, go.
remember from Cleveland Clinic, Dr. Pat Whitlow, unfortunately, he
Good.
has died.
This is the wire application, yeah.
But he had done a lot of rotablation and work on how, especially with the higher burst speeds with roto, it activates platelets. So it is something to consider.
Stop. Go floor.
Distally, still there is no fluid.
Sorry, we did not hear.
Distal LED is still not flowing.
There is a distal embolization. It looks like it is slow flow.
Or the wire, actually, the wire is a little curled up. We are going to look into that aspect. Let's just dilate here. Patient EKG is fine.
In three.
And good. Yeah, go. Yeah.
16, 18.
Because it was wiring was difficult earlier. We had the wire actually curled up that time. Negative. Yeah. We ready with the IVUS? We want to show that IVUS little. Yeah.
Go again.
Go.
Yep.
18. This was a 3.0.
3.5.
No, original was 3.0, 48 synergy. And now we are dilating with the 3.25 at 15 at 20 plus atmosphere. Go. Yep. 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 Negative. Yep. And we'll do the ostium and then we do the IVUS. And I think with that, we have shown this device performance quite easy, simple, and will be available to other centers also. They actually got a lot of devices now. This is another new technology. You know, there is always a choice. So this is good. Yeah. Go up. Yeah. Yeah. Good. Okay. So we'll just do the IVUS. Let's do the IVUS, and then, so what we'll do is, we show the IVUS, and then we will go offline, and let's get our all three experts there, so that I'm sure a lot of our audience want to ask questions, and I'll join in the next 15 minutes, but let's just show the IVUS first, because key is we have seen, and you'll see it also now, that very circular lumen. Why? Because you basically has, good, working, good, okay, back. With nice expansion, we published the data back then, 2016, comparing rotational atherectomy and orbital with the OCT. There are deeper cuts, more plaque ablation, less malapproach struts, and they actually use our slide work, and that has been a consistent. So we also learned, good, yeah. We also learned that this device really works when there is circular calcium. Much better, yeah.
Nodular calcium.
Yeah, and nodular calcium, shaving it. And I know the nodular calcium is a big one. Okay, let's show the IVUS there now on the main screen. We just need to see the IVUS on the main screen now. Good. Yeah. Moving.
Yeah.
Okay. Now we are in the stent. Yeah. Look at the circle. Nicely, because we need to see two things, expansion and apposition. Apposition is all there. Expansion, you want to have a good lumen. In this 3.2 kind of 3 vessel, your lumen should be at least 8.59. And we know that has been associated with the subsequent TLR. So minimum should be 5.5, but you can always go with a bigger balloon. Here, there's a little bit still on one side. We need to, but so far coming out quite well, nice expansion. We have gone to that diagonal and preserved the vessel. And that's another good advantage. Actually, that goes with the both atherectomies. We published that back then. The rotational atherectomy also preserve the side branches and so also orbital. So anytime you are taking away the plaque, so it's not going into the side branch occlusion is much lower. Yep. Nice circular. It may not be coming out, you know, I can see on the TV little crooked, but believe me, it's a total circle.
Oh, Sami, we can see the IVUS very
Okay.
clearly.
Oh, very good. Good.
Yeah, it looks good.
Fantastic. Look at this. The all lumen is throughout will be 9 plus millimeter square. Okay. So with that note, we'll stop here. And so any comments from any panelists and other questions will be, but we stop our the transmission now. And we thanks our delegates and of course the national and international faculty to make this a very wonderful experience after 3 years. We did one Zoom Eternal 4, but since 2018, we are supposed to do it 2020, but that time that was supposed to be April, but then COVID hit and happened to be, and I'm so happy that by all the efforts, this has been a great, successful. I learned quite a lot, and I hope others too. With that note, we want to conclude our today's live presentation from here.
Yes, wonderful case. Thank you very much.
Thank you.
Okay, we'll have some questions there. Thank you.
Congratulations, sir. Very nice case, perfectly done. I just ask one question.
Okay.
During orbital atherectomy, we have noted some jumps while device was advancing at the crown.
That's a
So
very
what
good point.
does that mean?
Yeah. So basically, so this is kind of same thing happened any atherectomy. So remember, there is any time when you have a tight lesion, you are engaging with the device. As soon as you will come out of it, it's going to jump no matter how slow you are. But you saw that it's a minor jump. So it happens with the rotational atherectomy and with the orbital. So more important, this is at the angle. Angle will be very troublesome. So you try to say, and I tell everybody that if there is an angle, don't go with any device. If you have done rest of the vessel with the atherectomy, orbital or rotational, you have really cut the interelastic lamina and your lesion will expand. So key is that yes, and this was at the angle. It was in the mid part, the tightest lesion. So even Sanjeev was going very slow, it will jump few millimeters, and that is expected. But as long as it didn't go 30 millimeters, that's it. But just to say that that is small, and that I can tell you, having done so many rotational atherectomy, we see sometimes coming out of the very tight lesion in the straight segment, even some jump occurs.
Thank you, sir.
Okay.
And one question.
Yes.
So how much you have experience like in ostial LED calcified lesion use of orbital atherectomy?
Oh, yeah. So question is from the orbital, you starting with the left main. So aorto-ostial or non-aorto-ostial. So we actually have published that aorto-ostial. My 5th case was the ostial left main, and that time, of course, now they have made the device change. They have put the Dyna assistant. So at that time, because what happens? What keeps the burr to go in the vertical axis is your vessel, and if you are doing the ostial lesion, your guide is out. It will go very vertical, and that patient caused the ostial left main dissection. Then we immediately did a balloon, put a stent, and actually patient felt so good. She was our poster child for the orbital atherectomy. We had in the New York Times, and her saying was that diamonds are forever, because she did good after the diamond burr. So just to say, the ostial LED, ostial circumflex same. No matter what device it is, circumflex will always give you trouble. Unless it's a very calcified, you don't want to use atherectomy. But yes, if it's calcified, both ostial LED, ostial circumflex, you can use, there is no issue. Here, it does not have a tension. What we have for the rotational atherectomy, you just already have checked the speed outside, just few millimeter proximal to lesion, and you go further. Some people actually do, there is a system called Dyna assist. They say, well, we don't want to start in the left main. I want to go distal and then come back. So this is still a little theoretical, but key is, yes, ostial LED calcified right from the beginning can be done. Our first case was the ostial LED, which Sanjeev posted this morning. 2 vessel, ostial, RC and ostial LED to mid LED. So ostial LED calcific lesion, very good for orbital atherectomy.
Sir, at the end, I will ask you, what is the cost of this device and how much?
Yeah, so that's a very good point.
Is it really?
Yeah. Well, that we need to see.
Yeah.
So question, there is always, everyone has their plus and minus. that one device can go to 2 places and you don't need any adjunct devices because very effective. But the price wise really boils down to, as you know, the Rota, now it's everything is the Rota Pro. And Rota Pro now is 1 lakh and 5 or 10,000, 5 to 10,000. And this one will be about 2 lakhs. Although maybe a little less, but 2 lakhs is the one they're priming it. And as we know, then IVL is what, 3 or 3.5 lakhs? 3. So it's a 1, 2, 3. Remember that way. Rota 1, OA 2, IVL 3.
And what about reusability, sir? What about reusability of this?
Yeah, reuse.
Reuse?
No.
I don't think so. It's a one-time use.
One-time use.
One-time use.
Thank you.
Yeah, okay. All right. Very good. Thank
Any
you.
question from the audience? Okay, no more questions.
We're
So
good.
congratulations, sir.
Okay,
Very
thanks
nice
from
case.
EHCC Cath Lab, the whole Cath technicians, Cath nursing, and our associates. Thank you very much.
Congratulations, Sanjeev, for
So
demonstrating
we'll
very
be joining
nice.
tomorrow morning. Yeah, joining for the gala dinner.
Okay. Thank you.
Yes, wonderful job with the case. Great result.
Hello. Thank you so much. So this was the live case, and thank you for all the questions. Now, since it was already declared that we'll have a quiz results, which we had today when we started this conclave. So to do the honor, may I now request Dr. Deepak Bhatt, Dr. Ajit Bana, Dr. Sean Penny, and Dr. Robert Rosenson, sir, to please join us on stage as we have the name of the winners, those who answer correctly during the quiz and for the questions. So the first one, and the award goes to Dr. Aarti Mishra. Do we have Dr. Aarti there with us? Indeed we have. Congratulations, Dr. Aarti. So this award is for the quiz that we played at the starting of the conclave today. And all the right answers, we have the winners with us. Congratulations. Please have a huge round of applause for her. Second one is Dr. Ravi. Congratulations, Dr. Ravi. You have also answered correctly. Please have a huge round of applause for Dr. Ravi. Third one, since Dr. Gauri is not there with us, would request someone to collect the award on his behalf. Dr. Gauri, I think he's not there with us. Please pass on this award to him. Congratulations, Dr. Gauri. And the fourth one is Dr. Karthik Mittal. Dr. Karthik, seems you have a good fan following. Some ooting is going on for you. Well, can we have a big round of applause for him, please? All right, so we'll have a session after this. And this is not the end. We would request you all to please be with us. And we request all the dignitaries to please take the seats, since we have an interaction activity going ahead now. Well, in the meantime, it's of course not the time for us to say bye-bye, because we have a session, and after that, we'll go ahead and we would also be enjoying the gala dinner. But then tomorrow also we'll be back, so we request you all to please join us for tomorrow's session at 9 a.m. And the topic will be interventional cardiology. But before than that, we'll have a session and some discussions. So in case you have any questions, you have any doubts, you have any queries, you can ask from the panel. And this goes to the entire audience, to all the eminent doctors that we have today. In case you have any questions, you have any queries, you can ask from the panel sitting on the dais. You can raise your hands, and I would request the management to please help us with the mic. Do we have any questions from any of the session or even in general? Yes, we do have. Please pass on the mic. Thank you.
So this is for Dr. Penny. You said that there is a ventricular. I'll give you an example of a case. There is a patient who comes with acute coronary syndrome. Little late presentation. Patient has a big aneurysm. LAD is 100% non-viable. And over a period of time, despite best medical therapy, the aneurysm keeps growing. So do you recommend any newer interventions which you showed in these patients?
So the question is about developing a post-infarct left ventricular aneurysm. So the BioVentrix device, which is a plication device, is under current clinical investigation to see whether or not in a hybrid case with a cardiac surgeon and an interventional cardiologist, whether you can plicate the ventricle, exclude the area of non-contracting myocardium to reduce the left ventricular size and to restore that mass to volume ratio. So that trial was underway, was disrupted by COVID, and is getting started again. I think the technical success has been very good in some of the early results that I've seen. Whether or not that translates into a long-term benefit, I'm not sure. In terms of surgical approaches, you could use the SAVR procedure. So with SAVR, a surgeon will incise through that aneurysm, open up the aneurysm sac, and then sew a cerclage around the area of viable and non-viable myocardium, and then pull that cerclage together. And then if there is a defect remaining, go ahead and patch that. And then what that essentially does is surgically exclude that area of non-contracting myocardium to reshape the ventricle into more of a proteate elliptoid shape rather than a circular shape. And again, exclude that area of non-contracting myocardium. So this procedure has been published. It's been about 15 years since Dr. Athenaeus published his experience from UCLA, showing quite good results with the procedure. And then what I showed earlier today was the results of the STITCH trial, where those individuals undergoing CABG alone versus CABG plus SAVR, the addition of SAVR did not have any effect on clinical outcomes over 5 years.
And this is for Dr. Bhatt. When we talk about residual risk after 1 year of acute coronary syndrome, we know that the residual risk may remain up to 7, maybe more years. It just keeps, the residual risk remains. Now, the problem is not of, so one is the acute use of DAPT, which is 1 month, 3 months, 6 months, or 12 months. The other is beyond 1 year. So beyond 1 year, when would you say, okay, I'm going to shift from dual antiplatelet to a single antiplatelet, even if the patient has had complex angioplasty initially? And the other is, what do you think is the role of 60 milligram of ticagrelor twice a day? Do you think in clinical practice it has a role?
Yeah, those are great questions. So if I'm going to de-escalate at whatever time from DAPT to something else, I think it's better to de-escalate to a P2Y12 inhibitor than to aspirin. And I think even if the patient's at relatively higher bleeding risk, we know that clopidogrel, as I mentioned, is more effective than aspirin and a little bit safer because of a slightly lower gastrointestinal bleeding risk. It's interesting, on a meta-analysis There also seemed to be a slightly lower risk of intracranial hemorrhage, but I'm not sure what that mechanism would be. But at any rate, we know clopidogrel doesn't increase bleeding compared with aspirin, and it probably decreases it a little bit. I say probably because the Capri trial was 75 of clopidogrel versus 325 of aspirin, and there was significantly lower gastrointestinal bleeding with the clopidogrel than 325 of aspirin. If it had been 81 of aspirin, who knows? But at any rate, I think if you're de-escalating, clopidogrel is an agent that has a lot of data. I think it's also okay to de-escalate to ticagrelor because in the Twilight trial, that's essentially what was done. Although there, the de-escalation was from ticagrelor plus aspirin to ticagrelor alone and 90 BID of ticagrelor. Now, so I think de-escalating to either clopidogrel or ticagrelor are reasonable options. Now, the 60 BID ticagrelor dose is appealing, but the context that's been best studied in is chronic therapy and not specifically in de-escalation strategies. That dose has been studied both in the Pegasus trial of patients with prior myocardial infarction, not acute myocardial infarction, but a history of prior myocardial infarction, and in Themis PCI, where we also use 60 BID. And the FDA approved the 60 BID in those contexts, that is prior myocardial infarction and high-risk coronary artery disease. So in those populations, I would use 60 BID if I'm using ticagrelor because it appears to be almost as effective as 90 BID and a little bit safer in terms of the antiplatelet effects. But to be clear, it hasn't been studied specifically in the context you're saying, that is someone on DAPT for a recent stent within the past year and then de-escalating to 60 BID. That specifically hasn't been studied. But I think it'd probably be okay because 60 BID of ticagrelor, we know from platelet function studies, provides more antiplatelet effect than 75 of clopidogrel. So if 75 of clopidogrel is safe, 60 of BID ticagrelor, I would think, should also be safe and effective. Does that answer your question?
Yeah, thank you, it does. And how many years after your DAPT are you comfortable making it single?
So that isn't an easy question or answer because I don't think there's one answer for that. I think it really does depend on the patient. Decision-making regarding antiplatelet therapy, I think, and I've got to be careful with Dr. Rosenson sitting next to me here, is much more complex than decisions about lipid-lowering therapy. I mean, all the patients we're talking about today, secondary prevention or even high-risk primary prevention, they should all be on a statin unless they have a contraindication or a documented intolerance or something like that. They should all be on it. So there's really no discussion about the data there. And then depending on their risk or their lipid levels, maybe they need to be on more than that if they can afford it, if they're not having side effects, et cetera. With antiplatelet therapy, you can't just say put everyone on DAPT for the rest of their life. That's a bad strategy. You'll cause a lot of bleeding with that. So for some patients, they may need to, if they're at a very high bleeding risk, they may need to de-escalate from DAPT at 1 month. Other ones, as was done in Twilight, at 3 months. Others, perhaps at 12 months. That might be a good sort of general practice. But for some others, it might be reasonable to continue DAPT even beyond that year, as has now been done in multiple trials in patients at low bleeding risk, high ischemic risk. I still think that's a fine strategy. But if you forced me to answer, I think 12 months might be a reasonable time as an average to de-escalate. Does that answer the question?
It does, and so I'll share something which happens in India. So we get a lot of combination SPCs here, which is a combination of aspirin 75, clopidogrel 75, and 20 milligram of rosuvastatin in one pill. And it's rampant, right? And this DAPT goes on for years. Years means 5, 7, 10 years. So the point I'm trying to make is that I think the mindset is that the act of commission also has degrees. If my act of commission is higher when I'm doing an angioplasty and stenting versus when giving a DAPT. So what I feel is that the interventionist or somebody who's had a complex angioplasty or stenting is unlikely to take off DAPT for many, many years, thinking that the patient may have a late stent thrombosis. So in this part of the world, the DAPT use is for many, many years, actually. It just goes on.
Yeah, but that's my own practice in the US. That's my default mode. I think that for many patients, not so much because of the stent these days, there the risk of late stent thrombosis really come down, but the risk of the underlying coronary artery disease that required that stent, I actually think that's a good practice. And I think the sort of poly pills with multiple drugs in them, as in India, is also a very good practice. I mean, it was studied by Dr. Fuster in a trial he led in the SECURE trial. We published that in New England Journal of Medicine. It showed that a polypill approach does increase adherence as opposed to taking multiple medications. So I actually think that Indian practice of having polypills is a good one.
Thank you so much.
All right, do we have any more questions? Yes, indeed we have, I guess. No more questions?
Well, I think there's someone in the back that has a question.
Yes.
They're asking, when is dinner? I think that's the question that the guy in the back is asking there.
Hello. My question is to the whole panel. We are fighting for the patient. I especially ask Dr. Bhatt, how will you guide our medical faculty, because a lot of stress we are taking, and there are a lot of young devices going on in our settings. So how we will approach, because even 32, 28-year-old doctors who is very well aware about his conditions going to have a very sudden onset of cardiac arrest. So how we will approach for cardiac faculty, for the medical faculty? For primary prevention or for the approach? Many medical persons having lot of device from last 10 years, young persons in medical field. So how we will approach that particular cases, not about the intervention.
I just want to make sure I understood correctly. You're talking about young physicians coming in as a patient.
Yeah.
Sure. No, that's a great question. Most of the time at these sorts of medical conferences, nobody's asking about the physicians or other healthcare professionals or their health. So I'm glad you asked the question. Actually, I was just shocked hearing the question, but it's a really good one because most of the time, you know, physicians and nurses, for that matter, are so focused on caring for their patients, they're often not caring for themselves. We really learned this, and this came to light during the COVID pandemic, in fact, where healthcare professionals suffered quite a bit, not just in terms of getting sick, but in terms of the stress and the mental toll that it took on healthcare professionals. So this is a very important part, because if we ourselves are sick physically or mentally or spiritually, we're not going to be able to provide good care to our patients. So I think it is very important for us to take care of ourselves. And I think that includes trying to exercise every day. I think and even if it isn't in a gym, just taking the stairs instead of the elevator. I just took the elevator from the first to the second floor. Would have been better to take the stairs, except I couldn't find them. But, you know, simple things like that, increasing physical activity. I think, you know, diet is extremely important. And as parts of the world become more urban, including in India, you know, traditional diets sort of get lost. I've seen, you know, so many more McDonald's popping up all the time. You know, that sort of fast food lifestyle and diet is bad for health. You know, actually a lot of traditional Indian plant-based diets are probably the best diets for health. They're the best in terms of cardiac risk. They're the best in terms of cancer risk. They're the best in terms of climate change. You know, what produces the most methane gas, in fact, in the world are cows that are kept for farming purposes. So lots of benefits of a plant-based diet, both to one's health and also to the planet. I think meditation, which originally came from India, yoga, things like that, extremely useful for stress reduction, and stress clearly plays an important role in cardiovascular and other health. So I think these are steps that healthcare professionals, but even other people should take. And interestingly, a lot of that knowledge sprung from India, but in fact has been lost in much of India, but is being adopted in other parts of the world. For example, yoga, meditation, vegetarianism are booming in the United States, even if they're collapsing in India. But, you know, hopefully those things can also be revived and help the health of the Indian population, including Indian physicians and nurses. Does that answer your question?
All right, do we have any more question? Anyone else would like to have any question? for our panel? Well, in the meantime, I would again like to request you and to remind you that this is going to be, so tomorrow is going to be our second day of this conclave, and tomorrow we'll start our session from morning 9 o'clock. So we request you all to please mark your presence tomorrow as well, and the topic would be interventional cardiology. So again, any questions? Because I think there were so many questions and we thought this is the time for us to get the clarification in case we have any questions from the panel.
Great. Well, if there aren't any questions, thank you all very, very much for your attention and staying late. And we're not going to stand in the way of dinner any longer.
All right. So I think Dr. Sameen K. Sharma sir is on his way. So he'll be coming and he would like to address all of us. So since I already announced that tomorrow will be our second day of this conference, we have another announcement for all of you. You can already book the date for our 6th conclave, Eternal Heart Conclave, which is going to take place next year, and the dates are 26th and 27th of October 2024. So in advance, you can already book the slot and the dates for our next conclave, which will take place next year in the month of October, and the dates are 26th and 27th of October 2024 for our 6th Eternal Heart Conclave.
Dr. Robert, just wanted to ask one thing.
Oh, we have some question.
I heard about HDL infusion therapy. Is this working, HDL infusion therapy?
Yeah, the question about HDL infusion therapy is really the subject of an ongoing clinical trial, not yet complete, trial that's gone on for many years. There's another approach that's not been looked at in terms of events, but it's delipidation of the HDL and infusion of the ApoA1 complex back into the patients. And there's been studies showing marked regression of carotid arterial disease in patients with homozygous FH, and then also regression of coronary athero in unselected patients. But we have to really wait for the that clinical trial to finish.
So Dr. Sameen K. Sharma is there with us now. So in the meantime, do you have any more questions from the panel?
And Dr. Robert, just one more question. What should be the HDL level in a patient who got his CABG done for the future so that his graft will remain patent? What should be the HDL level of a patient who got his CABG done for longer patency of the graft?
So HDL is a marker of disease that's not a target of therapy. And low HDL cholesterol is associated with overweightedness, insulin resistance, diabetes, cigarette smoking, air pollution. And so one tries to adopt a healthy lifestyle in order to increase the HDL cholesterol. More important than the cholesterol content of HDL is the number of HDL particles. There's one study known as STRIDE that randomized subjects to a high-impact, high-intensity exercise program, and it's only, let's say running 10 miles per week at, moderate to high-intensity rates that increase the HDL particle numbers. So the way that we evaluate HDL is changing tremendously, and a lot of the work is looking at the HDL proteins, which have anti-inflammatory properties, and moving away from the HDL cholesterol, per se. So there are two studies that I know about that are looking at that. One is study ongoing at the University of Oregon from the REGARD study. And then we're doing, for coronary events, we're doing a study funded by the National Institutes of Health looking at HDL proteins, inflammation, and incident cognitive impairment and dementia. So that's where the field is evolving. Thank you.
We are about all done now, right? Everybody happy now? All the questions have been answered? So this was a very fruitful session. I'm sure because the day passed quite, it's a little beyond time, but that always happens when a lot of discussions happen. But so thankful to everyone, and I know that everybody is just looking at, we are the one barrier to start their evening extravaganza in all the way. But thanks everyone, most important the participants and the faculty, and of course my national faculty and rest, the organizers and Eternal Hospital team and the relay, all the committee, the meeting planner and those who have done this great work. Very, very, I would say satisfying, particularly doing it after 4 years. Thanks everyone. If no question, you can always still interact with the faculty, and otherwise just ready for your drinks and dinner. Thank you. Thank you.
Thank you so much, sir. So do we have any more questions? I guess no. So it's time for us to move ahead for the gala dinner. But once again, a gentle reminder that tomorrow at 9 o'clock, we request you all to please be here as it would be the continuation of this conclave, which is going to be the second day, and we'll start by 9 o'clock in the morning. And yes, once again, a kind reminder to block the dates for our 6th Eternal Heart Conclave, which will take place next year on 26th and 27th of October 2024. Thank you so much. Enjoy the evening.
All the slides will be sent to the participants of the pledge.
And all the slides will be sent to all the participants. So you'll get all the slides as well. Thank you and enjoy the evening. Thank you so much. And we'll see you tomorrow, 9 o'clock in the morning, for the second day and the continuation of Eternal Heart Conclave 2023. Thank you so much.